Assalamu alaikum, Wahib.
Wa alaikum salam, Hassan. How are you? I think you're muted again. Dr. Salim, I think you're muted.
Right, just wanted to confirm, Wahib.
Guys, we're live on Zoom and live on YouTube as well.
Assalamu alaikum, Wahib. Wahib, can you hear me?
Yes, I can. Can you hear me now?
Yes. So do I stay on mute until you allow me in?
Yes, so I'll do a brief introduction and then I will introduce you. And then he'll come back to me and then I'll introduce Professor Kidd then for his talk. Oh, looks like you've gone into mute again.
All right. So in terms of the camera, do I turn it on when you introduce me? Or you're on mute?
I would leave your camera on, Dr. Hassan. You're making the screen look pretty. Okay, I think we'll start now. So, Assalamu alaikum and good morning, everyone. Thank you all for joining us today for the first of many high-profile, informative, targeted conferences organized by INTERYem. I'm Wahib Al-Azani. I'm a trainee orthopedic surgeon in the UK, and I've been with INTERYem since its formation in 2014. I'm currently a project coordinator for the organization. Our friends in Yemen are very close to our hearts, and the least we can do is acknowledge their struggle and outstanding resilience in these difficult times and help them in any way to be the best they can ever be. Our conference today is being held virtually via Zoom and YouTube. If you type in INTERYem into the YouTube channel, you should be able to find our channel. Our guest speakers today and tomorrow represent a diverse, elite, and highly skilled group of inspirational speakers in the field of family medicine from all over the globe. I would like to thank our guest speakers for their time and their passion to pass on their knowledge analysis, and recommendations to help our dear friends in the whole of Yemen. So INTERYem stands for International Network for Training, Education, and Research for Yemen. Started back in 2014, but of course, due to the political struggle, it has been a slow start. Our ambition is to facilitate collaboration between colleagues from Yemen and the rest of the world. We hope to do this through exchange of ideas, sharing expertise, and building friendships to improve the education, training, and healthcare professionals in Yemen, ultimately to help the health of the people of Yemen. More on this will come from Dr. Ahsan Salim, who is one of the trustees for INTERYem. The INTERYem Family Medicine Conference program is over 2 days. I'll share with you the program and we'll go through it. Okay, I hope you all can see the program. So if you don't have a copy of the program, this is a good time you can take a screenshot. So we have a few sessions today and a few sessions tomorrow. Each session will have a couple of keynote lectures, lasting up to 45 minutes with 15 minutes for Q&A at the end. We'll start today with Professor Michael Kidd, who will talk to us about principles of pandemic preparation for family medicine doctors. And then we'll have Professor Grant Russell, who will talk to us about principles of improving family medicine services. We'll have a couple of hours break because we are accounting for audience from different parts of the world. So we're trying to integrate good lengthy breaks in between. After the break, we'll have Dr. Akaya Osman, who will talk to us about family medicine training in Ghana, lessons learned after 20 years. After that, Professor Bob Marsh will talk about strengthening family medicine care through family medicine doctors, lessons from South Africa. Then we have another long break. After that, Professor Ali Batarfi will talk to us about the challenges and successes of family medicine in Yemen. Followed by that, Professor Muslim Ismail, who I think Professor Mansoura Fuad will be talking on his behalf. We'll talk about family medicine in Yemen, thoughts for the future. Then we have a break. And after that, we'll have Dr. Wafa Haj talking to us about assessment of patient safety culture in primary care setting. And then Professor Huda Basim will talk about the need for pre-service education and integrated management of child illness. Then Professor Abdul Latif Abu Talib will talk about experiences of family medicine in Sana'a. And then we have Dr. Hamoud Al-Hani will present his paper, as well as Dr. Najla Al-Ghairi. That will be for today, and tomorrow will be a shorter but equally important session. So just a little bit of housekeeping. So please keep your cameras switched off and your microphones on mute, except for the panelists. There will be closed caption, i.e. subtitles available if you want to see these. There will be a Q&A session after each presentation. If you would like to ask a question, you can type that in the Q&A box on the Zoom, and then we will pick on that and forward it to the panelist or the speaker at the end of their talk. Certificates for those who have registered will be available online via a link after completing a short feedback form. As with any conference, there are multiple sessions, some of which will be more of interest to you than others, depending on your practice. I recommend that you identify these and try to attend them as much as you can. For the purpose of certificates, you'll need to at least attend 75% of the sessions over the 2 days. So I'll just hand it over now to Dr. Ahsan Salim, who is one of INTERYem's trustees. We'll give you a little bit of background about the organizations, and then we will kick off with that. Dr. Ahsan Salim, are you with us?
Yes, thank you. Can you hear me?
Yes, can hear you.
Right, okay. Okay, thank you, Wahib. And Assalamu alaikum and good morning from Manchester. It's 8:30 here. So as Wahib mentioned, my name is Dr. Hassan Salim. I'm one of the trustees of INTERYem. My background is I'm a health and safety specialist, and I've worked in the UK offshore oil and gas industry for the last 20 years. So firstly, on behalf of the trustees, I would like to welcome you all to this inaugural INTERYem conference. And as Wahib just mentioned, we have a program with 2 full days, which includes leading world experts giving updates in their area of family medicine. We also have specialists from Yemen sharing their experience of family medicine in Yemen. Now, although this conference is aimed primarily at family medicine specialists, we feel the conference will also be relevant for students interested in this speciality, for policymakers and NGOs wishing to engage in this area, and also for non-specialist healthcare professionals who have an interest in this topic. So we think this is the program is actually relevant to a lot more people than just family medicine specialists. So to give you a little background first, as most of you will appreciate, Yemen is facing many challenges, including food insecurity, a non-functioning financial system, and the collapse of public services. It has been estimated that half of Yemen's public healthcare facilities are currently not operational, while shortages in staff and medicines have left the other half partially functional. And it was out of this need that INTERYem was set up in 2014 by a small group of dedicated doctors as a non-partisan, non-sectarian NGO to help develop the capacity of healthcare system in Yemen. So the ultimate aim being to improve the provision of basic healthcare for the people of Yemen. It's been a long but rewarding journey, and we are now in the position of registering INTERYem with the UK Charity Commission. And some of you will know that the Commission regulates charities in England and Wales, and we are therefore required to work within the relevant UK legislation. So as such, INTERYem's governance and due diligence is overseen by a board of trustees, of which I am one, and we are responsible for making sure that INTERYem does what it was set up to do. And in turn, we the trustees are responsible and accountable to the Charity Commission of UK and have to report on the work of INTERYem on an annual basis. So it's a very regulated structure in the UK for charities and how they function. As I said, I'm one of 4 INTERYem trustees, and you will get an opportunity to meet the other 3 in future INTERYem conferences. I also want to say something about the work of INTERYem, and I know it's going to repeat some of the things that Wahib has already said, but I think it's worthwhile re-emphasizing. INTERYem stands for International Network for Training, Education and Research. Oh, just looking at a message I've just received, sorry, apologies. And our mission, as Wahib said, is to facilitate collaboration between healthcare professionals from Yemen and the rest of the world. So INTERYem's objectives are to promote and facilitate education and training of healthcare professionals in Yemen, to raise the public awareness of health issues in Yemen, and to support and enable health-related research on Yemen. Now, in pursuing these objectives, our work is underpinned by 6 key values, which are respect for all, excellence and professionalism in what we do, teamwork is how we want to do things, and finally, empathy and humanity, which we feel is at the core of our purpose. So our aim is to facilitate long-term sustainable partnerships rather than short-term gains. This will require trust and commitment from all our partners. And we know that this will take time, but we are in this for the long term. We do not wish to work in isolation from the health context of Yemen, very important to us. So our intention is to work with and within the framework of the Yemen healthcare system and not set up structures outside of that system. Ultimately, we aspire for a Yemen where communities prosper through good health and healthcare professionals excel and inspire Yemen and the world. So that's a little bit about Yemen, INTERYem. In terms of this conference, again, Wahib has sort of outlined the contents of the program. And some of you may be wondering why we have chosen the theme of family medicine for our first conference. This will become clear as the conference proceeds. But as an introduction, there is now good evidence to suggest that family medicine and economic development go hand in hand in developing countries such as Yemen. So if the Yemen healthcare system can utilize family medicine effectively, it is likely to have lower health to cost ratios and better health outcomes. But unfortunately, despite this accepted wisdom, healthcare services in Yemen remain skewed towards specialist care. So for Yemen, the challenges of high chronic disease rates, poor infrastructure, and the lack of access to secondary care for the majority of Yemenis makes a very strong case for prioritizing training in family medicine, and hence the topic for INTERYem's first conference. The objectives of this family medicine conference are firstly to provide an update for family medicine practitioners in Yemen, or an overview for those new to the field. Secondly, we think it will provide an opportunity to exchange information between family medicine practitioners and academics from several countries around the world, and thereby sow seeds of collaboration. And finally, we want to try and identify any potential gaps in training among Yemenis family medicine healthcare specialists, and to try and work with Yemeni colleagues to fill those gaps. So that's the aim for this conference for over the next 2 days. So on a final note, I was reflecting on the work of healthcare professionals, and I was reminded of the Lebanese American writer who wrote some words about people who give generously. And he says, through the hands of such as these, God speaks, and from behind their eyes, he smiles upon the world. And as the COVID pandemic has shown, such are the healthcare professionals. They are a vital part of a civilized society. They carry great responsibility, and they are the epitome of compassion. And on that note, I would like to end by thanking Dr. Mubashir Chaudhry, Wahib, and their colleagues for their tireless work in organizing this conference. Thanks also to all the speakers for giving up their valuable time and sharing their knowledge and experience with us. And last but not least, thank you to all the participants for your support and making our efforts worthwhile. So on behalf of the trustees, I wish you all an enjoyable conference and successful conference. Thank you.
Thank you very much, Dr. Hassan Salim, for the introduction about INTERYem and about the conference. And thank you very much for your involvement, and also thanking all the trustees as well. I'm just gonna mention a few, summarize a few things that I've mentioned in the English language, now in the Arabic language. I'm aware that there is a lot of Arabic speaking people following us out there. But please feel free to ask any questions if you want anything to be clarified. Some of the speakers will speak in both languages, so they may use that in their keynote speeches, but the majority of this conference will be in English. أهلا وسهلا بكم في هذا المؤتمر لطب العائلة. هو يعتبر أول مؤتمر من نوعه في اليمن، وهذا مرتب له من قبل إنتريم. إنتريم هي عبارة عن منظمة جديدة تحاول أن تعزز التدريب والتدريب المهني والعلمي في اليمن، وتكوين رابطة قوية جدا بين أخصائي الصحة في اليمن وفي الخارج. في هذا المؤتمر لدينا كوكبة من خبراء العالم في طب العائلة من أستراليا، من أمريكا، ساوث أفريقيا، من الشرق الأوسط، وكلهم أتوا هنا كي يساعدونا كي نفهم كيف ممكن أن نعزز طب العائلة في اليمن، وكيف يمكن لنا أن نساعد الأطباء في اليمن والمرضى في اليمن بشكل عام في هذه الأوضاع الحرجة. طبعا المؤتمر هو عبارة عن فيرتشوال، يعني هو عبارة عن إنترنت مؤتمر، فكل المحاضرات ستكون مسجلة، ممكن الإطلاع عليها في وقت آخر. والمؤتمر شوية مكثف، لذلك سيكون هناك العدد من الاستراحات بين المحاضرات. إذا كان عندكم أي أسئلة ممكن تطرحوها في الزوم بوكس، أو ممكن إذا عندكم الإيميل لإنتريم أن ترسلوها لإنتريم. فإن شاء الله نتمنى أن تستمتعوا معنا في المؤتمر، وإن شاء الله يكون مفيد. وهذا هو أول مؤتمر من مؤتمرات عديدة في المستقبل، وكلها مؤتمرات راح تكون قيمة جدا بالنسبة للوضع في اليمن، وأيضا كيف ممكن تحسينه. Now I'll go back to my English voice, and I would like to introduce our first keynote speaker, Professor Michael Kidd, all the way from Australia. So Professor Michael Kidd has a very long track record in family medicine. So he's the Deputy Chief Medical Officer and Principal Medical Advisor for the Australian Government Department of Health, where he is leading Australia's national primary care response to the COVID-19 pandemic. He is also the chair of the Aged Care Advisory Group of the Australian Health Protection Principal Committee. He's also has the appointment as the Foundation Professor of Primary Care Reform at the Australian National University. He has a long track record in digital health research, advocacy, and governance, with particular focus on electronic medical records and telehealth innovations in general practice. Without further ado, let me welcome Professor Kidd for his first talk, which will be on the principles for pandemic preparedness for family medicine doctor. Hello, hi, Professor Kidd.
Hello, good evening, everybody. Thank you, Dr. Wahib. Thank you for Dr. Osman, and greetings from Sydney, Australia. It's 8 o'clock on Saturday night, hence I'm sitting in the dark, but very pleased to be able to join you for this conference. I wanted to say a huge thank you to Dr. Mubashir and congratulations to everybody involved with INTERYem for making this historic event happen today. Now I'm just going to try and share my screen with you. Okay, I'm not sure if that's coming up or not.
Yes, that is coming up.
That is good.
Yeah.
There we go.
That's it.
Okay, thank you. So I'm going to talk to you about principles for pandemic preparedness for doctors working in community and family medicine. But I want to talk about this in the context of what the work that we do as family doctors. I do want to start off with a huge thank you to everybody who is taking part in this meeting today. Thank you for the passion you have for patient care. Thank you for your commitment to high standards of healthcare delivery. Thank you for your dedication to education and training and to research and evaluation, which is very important in family medicine. And thank you to each of you for your dedication towards making a difference for the people of your country. And you are demonstrating that dedication by being here today and taking part in this event. Obviously, our lives have been very significantly impacted all around the world by the coronavirus disease 2019, COVID-19. And so I'm going to talk to you a little bit about what's been happening in some parts of the world where Doctors working in community and family medicine have taken the lead in looking after their communities at this difficult time. And I think many of us have been involved in trying to do all that we can to help stop the spread and help our populations to stay healthy. Now, I do acknowledge that I'm not an expert in healthcare in Yemen. So my apologies if anything that I present is not specifically related to the work that you are doing in Yemen, in your own countries. But I'll try and take quite a high-level global view in what we discuss. So the World Health Organization is very committed to the work that we do in family medicine and recognizes how important this work is to the health and well-being of people in communities right around the world. This is the former Director General of the World Health Organization, Dr. Margaret Chan. And a number of years back, I was at a talk that Dr. Chan was giving to a group of doctors from all specialties. And she said, "Doctors, I have a secret to tell you. I love family medicine." And all the family doctors in the room stood up and clapped. And all the other doctors didn't look very happy because she didn't say, "I love all the other specialties." She said, "I love family medicine." And she said, "The reason I love family medicine is because family medicine is the way we are going to be able to work towards making sure that everybody gets access to healthcare. Family medicine providing care to everybody in the community, looking after the breadth of medical conditions, should be the foundation of healthcare systems right around the world. And what Dr. Chan is talking about is what the WHO calls universal health coverage. And universal health coverage, this is the definition from the World Health Organization, means that all people in all communities can get access to all the healthcare services they need, that these services will be of high quality, and that these services won't expose people to financial hardship. And what this means in a few short words is providing health for all, health for everybody. This is the World Health Organization of universal health coverage, and it embodies these three related objectives, which I'll bold. Equity of access to health services, so everybody in the country, in the town, in the village should be able to get access to healthcare. The quality of the health services should be of a high quality to improve the healthcare of those, or improve the health of those receiving care. And people should not be put in financial harm by having very high costs of being able to access healthcare. Now, the World Health Organization was established back in 1948, and back at its very first meeting, when the leaders of the governments of the world came together, and this is a photograph of ministers of health from around the world, they declared that health is a fundamental human right, which means that everybody, no matter whether they're rich or poor, no matter where they're living, no matter which country they're living in, should be able to access healthcare. Everybody should have access to doctors and nurses and the provision of healthcare. In 1978, 30 years later, the ministers of health from countries all around the world came together a second time to issue what was called the Declaration of Alma Ata. And the Declaration of Alma Ata reinforced the importance of primary healthcare. This is healthcare delivered in the community, and the importance of primary healthcare towards ensuring health for everybody. And everybody in 1978 said, what we want is we want health for all people by the year 2000. And that was the aim that all countries of the world signed up to. But of course, we got to the year 2000 and many people did not have access to healthcare. Indeed, by the year 2000, there was still 1 billion people all around the world who had no access to any health care at all. People who had not ever seen a doctor, people who were not able to access a nurse, people who were not getting access to any health care. And so in the year 2000, the United Nations came together and established the Millennium Development Goals and said, here are 8 goals that we want every country to sign up to improve the well-being of all people on the planet by 2015. And these goals included working together to eradicate extreme poverty and hunger, ensure that all children have access to education, ensure that women have equality and are empowered in societies, to reduce the rates of infant and child mortality, to improve the health of mothers and reduce the rate of maternal deaths, to combat serious infectious diseases like HIV/AIDS, tuberculosis and malaria, to ensure a healthy environment, because if we don't have a healthy environment, we don't have healthy people, and to have countries work together in partnership to support each other. And it's one of the reasons I'm so excited about INTERYem, which is people from countries all around the world coming together to support healthcare for the people in Yemen and support the doctors and nurses working in Yemen. So these were the year 2000 Millennium Development Goals. These were reported on each year up to the year 2015. And what we saw during those 15 years was we saw some improvements. We saw a very significant increase in the number of children who were going to school and receiving an education, and a very significant increase in the number of girls going to school in countries around the world. We saw reductions in child mortality in many countries. We saw countries coming together to tackle HIV/AIDS, the HIV/AIDS pandemic, and to make available antiretroviral treatments to people in many countries around the world. We saw improvements in prevention of malaria and the treatment of tuberculosis. But we still saw many people by 2015 who did not have access to basic healthcare. One of the principles behind the Millennium Development Goals was to recognise that healthcare systems need to meet the needs of the population. This may sound very obvious, but often healthcare systems do not meet the needs of the people the healthcare system is meaning to be serving. And if we're going to have health systems based on people's needs, we need to engage in all 5 groups of people on this diagram. The communities receiving the care need to have a voice in determining what care they receive. We need to bring together the people delivering healthcare, the health professionals, the people who are responsible for healthcare services, the health managers, our governments and our health departments, the policymakers, and our universities, our academic institutions, and our colleges and academies, which are training our healthcare workforce. And so these are principles that the World Health Organization has been encouraging in countries around the world. At the end of the Millennium Development Goals, 2014, 2015, the leaders of the world came together at the United Nations, and the then Secretary General, Ban Ki-moon, said that the world is at a historic crossroads. We have a globalized economy, we have sophisticated technology, we have the ability to end extreme poverty and hunger in countries all around the world. And we can decide to do that, or we can continue to degrade the planet with pollution of our air and our water and our ground. We can continue to allow inequalities and all the problems that arise when we have inequalities within countries and between countries. And he said we need to achieve sustainable development for every country. And so in 2015, the United Nations issued a new set of global goals, and these are called the Sustainable Development Goals. This time there's only one goal around health, that's number 3, but many of the goals are very similar to what we saw in the year 2000, with no poverty, zero hunger, education, gender equality, a range of measures to improve the health of our planet, and a range of measures to have people working together to improve the lives of people in countries all around the world. This is the one development goal on health, ensuring healthy lives and promoting good health and well-being for all people at all ages. And so much of the global health policy of the World Health Organization is focused on helping us to meet these goals, and many of the programs that the WHO runs in regions and countries around the world is focused here as well. In 2018, again, the health ministers of the world came together, this time for a global conference on primary healthcare, and another declaration about working together to ensure that healthcare is available to everybody. This time, recognising that healthcare needs to be delivered in the community by community and family doctors, community nurses, community health workers, and other people delivering care in the community where people are based. It's recognised that we don't address the healthcare of everybody just by building hospitals. We have to have high quality clinics and services based out where the population is based. At this meeting in 2018, the now Director General of the WHO, Dr. Tedros, formerly from Ethiopia, said the best way to provide these healthcare services is through family medicine. With our emphasis on health promotion, disease prevention, family practice, family medicine helps keep people out of hospitals where costs are higher and outcomes are often worse. So again, you can see that the work that we are doing through family and community medicine is respected, it is important, and it is recognised as being an important part of delivering healthcare for all people. So what does this mean now, though, in the age of the pandemic that we are currently experiencing in countries right around the world? The pandemic has made us focus on what really matters in the delivery of healthcare in many of our countries. And I want to share with you a series of principles of how primary care has been involved in the response to the COVID-19 pandemic in countries all around the world. And I'll go through each of these principles one after the other and explain to you some of the context for this work. So the first principle is recognising that in a pandemic, we need to protect the people who are most vulnerable to the infectious agent. And what we know about COVID-19 is that the people who are most vulnerable, most at risk of becoming seriously unwell, most at risk of dying from COVID-19 are elderly people, especially people aged over the age of 70, people with chronic health conditions, people with conditions like diabetes, severe heart disease, severe lung disease, obesity, people with cancer or survivors of cancer, among other conditions. And these are the people who are most at risk. Now, of course, everybody is at risk from COVID-19. What we've seen is even though many younger people experience milder symptoms, some younger people get very unwell and some younger people will die from COVID-19 as well. So we need to be protecting everybody in the population. And the doctors who are involved in protecting vulnerable people are family doctors and doctors working in the community, because these are the people that we care for all the time. As a family doctor, I look after elderly people. I look after people with chronic disease. I look after people who have survived cancer or are being treated for cancer and for many other conditions. I look after everybody in the community. So it's been very important as part of responding to COVID-19 that we support our community and family doctors and nurses and health workers to do the work they do, because this is part of looking after people in the pandemic. The other thing we know is that if 100 people become unwell with COVID-19, 15 may become seriously unwell and need to be admitted to hospital. But 85 out of 100 will have mild to moderate symptoms and will be able to be cared for in their own homes. Who delivers the care to people in their own homes? It's community and family doctors. And around the world, we have been providing home care and advice to our patients, often through the telephone, sometimes through video consultations, through telehealth, and through visiting people in their homes. The other group of people who have been very much at risk from COVID-19 have been elderly people living in nursing homes. I'm not sure if you have nursing homes in Yemen. I know that many elderly people are cared for in their own family homes by their family members in Yemen. But in many other countries, some elderly people, when they become very frail and disabled, end up living their lives in nursing homes, receiving full-time nursing care. And what we've seen with the COVID-19 pandemic is that if COVID-19 gets into a nursing home, it causes a very high level of death rates amongst the residents of those homes, because of course these are people who are very old, in their 70s, 80s, 90s and older, and these are people who have very significant healthcare problems, very significant chronic disease. And the doctors who provide care to people in nursing homes, again, are the family and community doctors in countries around the world. So that's the first principle. We need to protect people who are vulnerable. The second principle is that we need to provide treatment and support services to people who have been affected by COVID-19. So in many countries of the world, family doctors have been involved in testing their patients who have symptoms which could indicate that they have COVID-19. As family doctors, we are very good at assessing people with respiratory symptoms. Now, sometimes someone has respiratory symptoms. You don't know whether they have COVID-19 or they have some other cause for their respiratory symptoms. Another viral cause. Could they have asthma? Could they have other lung disease? Could they have pneumonia? I've had a patient coming in with shortness of breath thinking he had COVID-19. He was having a heart attack. So it's very important as family doctors that we're not just saying that everyone with symptoms has COVID-19, that we assess people and arrange for people to get appropriate care. One of the challenges of the pandemic, though, is that if people come to see their family doctor or their community nurse with respiratory symptoms, and if they have COVID-19, there is a risk that they may infect other people who are attending that clinic as well. So in many parts of the world, family doctors have set up two clinics, a clinic for assessing people with respiratory symptoms and a clinic for arranging regular health care for their patients. And this way we can keep our other patients safe while doing appropriate testing. You can see here a doctor wearing full protective equipment with mask, shield, gown, gloves, doing testing, in this case, of a patient who doesn't even come into the clinic, but is being tested inside their motor vehicle. The third principle is around ensuring that during a pandemic, we have continuity of regular healthcare services for the entire population. One of the things we know from past pandemics and epidemics is that if the healthcare system collapses, people don't get regular healthcare. And as a consequence, you can have people becoming seriously unwell from other healthcare problems rather than from COVID-19. And we've been seeing this in countries around the world. And it's very important that as family doctors, we are able to continue to provide care for our patients who have acute medical problems, care for our patients with chronic healthcare conditions so that they continue to be monitored, they continue to get their medications, care for our patients with mental health concerns, and that we're able to continue with preventive healthcare measures as well, that we are able to make sure that our patients, our child patients, are receiving their immunisations, that people are receiving the influenza vaccine to protect against influenza, and that people are being screened for cancers, for cervical cancer, for breast cancer, for colorectal cancer, and for others. What we've seen during the pandemic over the last year is that many people have missed out on regular health care. And this means that we are going to have a lot of preventable healthcare problems arising because we weren't able to provide healthcare in a timely manner to many of our patients. And I'm very concerned about this. I'm very concerned that one of the impacts of the pandemic is that we are going to see an increase in cancer, which could have been prevented if it had been diagnosed earlier, but may not be able to be cured now, that we will have more people developing serious heart conditions, that we'll have more people with undiagnosed diabetes developing complications, things which could have been prevented, that we will have children who have missed out on some of their essential immunisations and their health checks. So it is important that we support the continuation of regular healthcare. And this has meant if countries want to do this, then they've needed to support their family doctors, their community clinics, in order to be able to provide regular care. The fourth principle is about protecting the workers in primary care during the pandemic. What we've seen in some parts of the world is some countries have provided protective equipment to doctors and nurses working in hospitals and working in emergency departments, but have not provided the same level of protection to doctors and nurses working in the community. And yet we know, again, from past epidemics and pandemics, that doctors working in the community are just as much at risk of contracting the infectious disease as doctors and nurses working in hospitals. In fact, we may be at even higher risk because we are the people who are diagnosing patients who are presenting with symptoms. And people come to us with all sorts of symptoms. You don't know if the next person who is going to walk in the door is someone infected with COVID-19, who may put you and your staff at risk of infection, which means your family being put at risk as well. So it has been important in many countries to make sure that doctors working in the community have received personal protective equipment as well. The fifth principle is around what we know is that after a pandemic, often there are mental health impacts which can last for many years. And we will see this coming out of the COVID-19 pandemic. COVID-19 has caused tragedy for many people. Many people have experienced loss of employment, loss of contact with family members. Many people have been isolated due to lockdowns in their countries. Many people have not been able to travel to be with their loved ones, with their family members. So many people's lives have been significantly disrupted during the pandemic. And this has an impact on everybody's mental health. And I know that, of course, living in Yemen at the moment and with the experiences that you've had over recent years, your own mental health has been significantly impacted as well. And this is why it's important that countries focus on supporting the mental health of the population during times of great stress and emergency, but also that we protect the mental health of the doctors and nurses and community health workers looking after the people in our communities. And I hope that you are able to get support for your own mental health. That when you have significant trauma and experiences occurring in your work life, in your daily life, that you do have ways of being able to talk to colleagues and to get support, because we all need support at this time. I think around the world, we've seen the entire population of the planet experience mental health concerns. People who have not been sleeping properly, people who have been anxious, very anxious, people who have been panicking about the health of their loved ones, people who have been beset with many worries because of their lives being interrupted. We're now moving into a new phase, though, with the global pandemic. And this new phase relates to the opportunity to start vaccinating the people of the world against COVID-19. The development of the COVID-19 vaccines has been a modern medical miracle. I think that most of us 1 year ago, if we were told that in 12 months we would have vaccines available to protect people from this coronavirus, we would have thought that was not possible. We'd never had a vaccine developed to protect people against a human coronavirus before. There was no vaccine for SARS. There was no vaccine for the Middle East respiratory syndrome. There's been no vaccine for the coronaviruses which cause the symptoms of the common cold. And yet, over the last year, through an enormous investment of funding by governments right around the world, we now have many, many vaccines under development to tackle COVID-19. And already we have nearly a dozen vaccines which have been released for use in the population. These vaccines have only been available over the last 3 months or so, but already tens of millions of people right around the world have received a first dose of one of these vaccines. Of course, we have a real problem with a lack of equity with these vaccines, where vaccines are being used largely in high-income countries to protect their populations, and we are seeing very little distribution of vaccines at the moment to people in low and middle-income countries. That is starting to turn around. There is a global movement called COVAX, which is getting money from high-income countries to provide vaccines to the people of low and middle-income countries, but that will probably take some time for vaccines to be equitably distributed to countries all around the world. But what we do know is that this pandemic will not be over until everybody is protected. While we still have countries where there is COVID-19 present, while we still have populations which have not been vaccinated, the rest of the world is still at risk of outbreaks of COVID-19. The other thing about these vaccines is we still have a lot to learn about them. We know that these vaccines seem to be very effective at protecting people, if they get infected, from becoming seriously unwell and from dying. But it looks like many people can still be infected and have mild disease, or be infected and be asymptomatic, meaning that people may still be able to transmit COVID-19 to people who are not protected. At the moment, we don't have any vaccines for use in children, although there is research underway to try and find vaccines which can be used in children to protect children. And until we can protect our children, we won't have herd immunity and the ability to say that everyone is protected in our communities. We don't know how long these vaccines are going to provide protection for, whether we're going to need boosters in the future. And with the new variants of COVID-19 appearing in countries around the world, we don't know if the current vaccines are going to be fully effective against each of these new variants. So there's a lot that we don't know and a lot that we will continue to learn. But what we are seeing with the vaccination programs in many countries, including in the United Kingdom and in Australia, is that the people who are delivering these vaccines include family and community doctors, community nurses, in many cases working with community health workers in countries around the world. So again, we have an important role in vaccinating the members of our communities to protect the members of our communities from COVID-19. So I want to leave you with some thoughts about what are things going to look like in a post-pandemic world. And of course, we don't know if we're going to have a post-pandemic world. We don't know if COVID-19 is going to be eradicated or whether it's something we're going to have to live with for the rest of our time. We, of course, still live with diseases which have caused other pandemics. We're living with HIV/AIDS in many of our countries. There is no cure, there is no vaccine for HIV/AIDS. We've been living for centuries with the pandemic of tuberculosis affecting people in countries all around the world. We still have other serious infections like the Middle East Respiratory Syndrome circulating in different parts of the world. So we are in a constant state of diseases which start as pandemics and then become endemic. In countries around the world. They become part of diseases that we need to learn to live with and need to learn ways to protect our populations. And so the same is likely to be the case for COVID-19. We will have to look at how to protect our communities from this disease, maybe with repeated outbreaks occurring as new variants appear. It may be that COVID-19 becomes like influenza and that we need annual vaccinations to protect our population from new strains which develop over time. The other thing that we will need to look at after the pandemic is the pandemic and the experiences that we've had over the last year and the months or years to come is going to change the way we deliver healthcare in many of our countries. Inquiries will be held looking at what worked and what did not work in each of our countries during the pandemic. And recommendations will be made about things that need to change so that we are better prepared for the future. I hope that part of what these inquiries will reveal is how important it is to have a strong system of primary health care in each and every country if we want to be prepared for dealing with health emergencies like this COVID-19 pandemic. Because we are seeing in many of the countries which have strong systems of primary health care with family doctors, community nurses, community health workers, that some of these countries have been able to tackle the pandemic and protect the health and well-being of their populations better than has happened in some other countries where they've relied on having hospital-based care, which of course has not been able to deliver care for everybody. So it will be interesting to see what happens coming out of the pandemic. I will be doing my best to make sure that countries of the world remember the Declaration of Astana, that declaration from 2018, where every health minister committed to strengthening primary health care in every country of the world as a way to ensure that we have universal health coverage, healthcare available to every person in every community, in every village and town and city in every country of the world. This is the work that we do in family medicine. So, my dear chairs, I think we'll stop there, but I'm happy to take any questions that anyone may have. I'm very happy to hear people's comments. Thank you.
Thank you, Professor Kidd, for this amazing talk. We actually have received a lot of questions. We haven't got them in the Q&A session. They've come via email because some people are watching this on YouTube. Also, some people have asked whether they can ask the questions directly. Because we set this up as a webinar, non-panelists do not have the facility to actually unmute themselves and talk. So this will be impossible, unfortunately. But keep sending your questions via email or the YouTube or the Q&A session, and we will read them on your behalf. So I've got a question here. This is looks like somebody from probably the southern part of Yemen, where they have an outbreak of dengue in the region, and they're asking, is preparation for such a pandemic be similar to aerosol-like pandemic like COVID, or is it different?
Thank you. It's a really important question. We know that in the future, we are going to have further outbreaks of serious infectious diseases. And if we have a strong system of primary health care, then when a new infection appears, whether it is dengue, whether it's Zika virus, whether it's COVID-19, whether it's something completely new, when that occurs, if we have strong primary health care, then our governments can roll out preventive healthcare measures through the system of primary health care, can roll out treatments through our family doctors and community nurses delivered in the communities where we're based, and can roll out preventive measures like the vaccines in the communities where we're working. What we've seen with outbreaks of diseases like dengue in other parts of the world is the ability for public health to work with primary care to find solutions that meet the needs of the local community. And so it's not just public health measures, it's not just primary care measures, it's working together. And I think this is one of the important lessons of COVID-19. COVID-19, our governments have set up public health initiatives to protect the public, but those measures have been delivered through doctors and nurses and community health workers on the ground. So whenever we have countries which have a strong system of primary health care, those countries are better equipped to be able to tackle these important public health challenges posed by serious infectious diseases. It's a great question. Thank you.
Thank you very much for that answer. The next question is, somebody is asking, why did New Zealand do so well during the COVID pandemic compared to other countries, given that it was new for everyone, including them as well?
Yes, thank you. So I of course, am from Australia, not New Zealand. New Zealand is 2,000 miles in that direction from where I'm sitting now. Australia and New Zealand have both had very low numbers of people with COVID-19 and very low numbers of people who have died from COVID-19. And part of the reason is that both countries are islands. And so we have been able to close our borders to the rest of the world. Australia and New Zealand closed our borders to China in late January last year when the pandemic was just beginning, and closed our borders to everywhere else in the world at the end of February last year. The only people who can come to New Zealand or Australia at the moment are citizens from Australia and New Zealand returning home from overseas. And those people, when they arrive in the country, have to go into quarantine for 2 weeks in a supervised facility, either a hotel or a camp, for 2 weeks, where they are isolated from the rest of the population. Many of these people are coming from countries where there is a high incidence of COVID-19. They're infected with COVID-19, and so they have to stay in isolation and quarantine until they are no longer infectious, and then they're allowed out into the community. Even then, we have had some outbreaks of COVID-19 in both New Zealand and Australia from people who have been in quarantine. But each of those outbreaks, with one exception, a very big outbreak in the city of Melbourne, each of those outbreaks has been able to be contained really quite quickly. So there are advantages in being an island, although, of course, the United Kingdom is a group of islands as well, but because of the open borders with Europe in particular, the United Kingdom wasn't able to contain its borders as happened in other places. So there is, of course, a risk in being an island nation because we haven't had a lot of COVID-19. the vast majority of our population have not been exposed to COVID-19. We have very few people with antibodies. And so we are relying on the vaccine to protect our population from COVID-19. And if the vaccines don't work very well, when we open up our borders, we may see very serious outbreaks still occurring in Australia, in New Zealand, and in other island nations. It has been interesting looking at some of the other islands, though, which have done well. Taiwan, off the coast of China, very low incidence of COVID-19. Singapore, very effective in protecting, but Singapore forgot that they had a hidden population of people who were the migrant workers, especially from South Asia, who were living in very closed quarters. They got COVID-19 occurring in that population, and then it spread through the rest of the island. This is a very tricky virus, and these are very challenging times in so many of our countries.
Thank you very much for that. Question, I think you already touched a little bit on this one. How much should family doctors be involved in planning at a population level against a pandemic?
Yeah, look, I think that we need to bring together public health and primary care to deliver population health. So public health, looking after the health of everybody in the community, primary care, looking after individuals and families in communities, bring them together. We provide care to the entire population health. And I think one of the lessons from COVID-19 is how important that intersection of public health and primary care is if we're going to protect our populations. So, and the reason for this is pretty obvious. As a family doctor, I'm an expert or a specialist in the population of people that I provide care for. I understand the healthcare challenges of my local community. I understand the healthcare risks posed to the people in the community that I look after. And so we are the logical place for public health measures to be working hand in hand. Unfortunately, in many countries, there is competition between public health and primary care. It's not healthy. We need to bring everyone together and care for populations.
Thank you very much. That ties nicely with our next conference, which will be public health based. We recognize the importance of public health and family medicine as an infrastructure for any health system. The next question is about, again, applies to Yemen mainly. For countries who have poor infrastructure, what should be the main things that they should focus on?
Look, this is at the Astana Declaration talked about this. We talked about the need for countries which currently have poor infrastructure, for support for those countries to invest in the infrastructure they need. And it's not just building hospitals. Hospitals, yes, are important, but that's not where the majority of healthcare is delivered. The majority of healthcare needs to be delivered out in the communities where people live. So we need good clinics established and built out in the communities where our patients are, in the cities, in the poor areas of the cities, in the villages. So people can walk to get healthcare from a doctor, nurses, community health workers. We need to build the healthcare team in each of those community clinics. Doctors, nurses, community health workers working together and working with those local communities to deliver healthcare. Those doctors and nurses need to be trained and supported in their training. They need continuing education programs on clinical topics like you're running over the next 2 days with this wonderful conference. They need to be paid well. So why do we pay doctors who work in hospitals so much more than we pay doctors and nurses who work in the community? The work is equally important, and we need to value the work that people are doing if we want to attract people to work in the communities. Working in the community, we can then roll out preventive health programs, like Dr. Tedros said, from the WHO. We can roll out health promotion programs. We can look after acute problems. We can look after chronic disease. We can look after mental health problems. We can look after the spectrum of healthcare needs of the people of our local communities. One country which has done this very well is Brazil. Brazil is a middle-income country. It had very significant problems with high infant mortality, maternal mortality. The government of Brazil decided to invest in family health teams. It built clinics in the slums of the cities of Brazil, in the remote communities and villages of Brazil. It provided good payments for doctors and nurses. It provided them with training. They now have 34,000 family health teams working in clinics, providing care to the poorest people in their population. And what happens? The rate of infant mortality falls. The rate of maternal mortality falls. The rate of people dying early from preventable conditions like diabetes, heart disease, lung disease falls. The number of people with incurable cancer falls because people are being investigated. The number of children being fully immunised against terrible infectious diseases, close to 100%. This is the way that we help to raise the health and well-being of all of our people. And once we have good health for everybody, then people can work. People can work on their farms. People can work in their industries. People can work in their shops. People are not dependent on other people. People can lift their families out of poverty. People can send their children to school to get educated. And so communities change over time. And we're a really important part of that. This is why those sustainable development goals are so important. They intersect with each other. And as family doctors, we can be part of helping to improve the well-being of all people in our nations.
Thank you. It's amazing to see how impactful a kind of primary care or family medicine system can be in reducing mortalities you mentioned. And it's a good reminder for myself and other people that, how important it is to look into that in Yemen. And we are proud of, as you may see in the following programs, following talks in this program, there is now the fundstone for starting family medicine in Yemen has started, and we just want to get it really off the ground and make it even stronger. I can see some people have been trying to put questions on the chat. I think that won't be possible because there is a separate Q&A box, and I can see some questions started to come there, as well as the email. So one question, thank you very much for your talk. With regards to telehealth, as you said, it might be the way forward in family medicine. Doing research around telehealth, there are also many challenges documented that delayed the implementation of telehealth. How do you think these challenges will be overcome, such as lack of infrastructure and patients as well as physician reluctancy as well?
Yes, so in Australia, we didn't have very much telehealth until a year ago. And then when our country went into lockdown and no one was allowed to leave their homes for many weeks as we tackled that initial wave of COVID-19 before we were able to bring things under control, we had to introduce telehealth for everybody. And this was funded by the government, and it could either be by telephone or by video call. Most of the telehealth has actually been delivered via the telephone. Now, as doctors, we're used to talking to our patients on the phone, but we're not used to making diagnoses over the phone. So there are all sorts of risks associated if we just rely on telehealth. And it's very important that if we have telehealth, that we also have the ability to deliver a face-to-face consultation whenever that is required, because there are many times when you need to examine your patient in person in order to be able to make the correct diagnosis or to determine what needs to be done next with regard to management. But telehealth has an important role to play. I think that we're going to see an awful lot of research coming out over the next couple of years about how telehealth can be used in ways that improve the care of people. I understand in Yemen, many people may not have access to the infrastructure to allow telehealth to take place. But as I say, even telephone lines, landlines, can deliver some degree of telehealth when the population is in lockdown. So it'll be very interesting to see how this works in different countries around the world. And the lessons. I know one of the problems we've had in Australia is that people who take a call from their doctor on the phone are often doing other things at the same time as talking to the doctor. And that's not good. So you cannot multitask while you're having a medical consultation. You need to be paying attention to what's happening and the advice that's being given.
That's very interesting. Thank you. I think even here in the UK, we have seen a lot of GPs, which is a family medicine equivalent, doing virtual consultations. And I think it's there to stay, to be honest. So once even the pandemic is over, it will be there to stay, because it seems to be such an efficient way of dealing with high volume patients. Of course, as you said, that has its disadvantages, but I guess with time we will learn how to overcome them as well.
I think you're right. I think we use the term that the genie is out of the bottle. Do you understand that term?
Yeah.
So I think the genie of telehealth is well and truly out of the bottle, and it won't be able to be put back in. It is something that we're going to be living with. And, we have to make sure that we're going to be using it to deliver the highest quality care that we can.
Thank you. I've got a couple of questions about the welfare of the family physician, family doctor. How can family doctor look after their mental health in a pandemic where they are so stressed?
Yes, so the things that we've done in Australia, of course, may not work in Yemen, but we have online mental health resources which are available specifically for doctors. We have an organisation called the Black Dog Institute, which has provided online support for mental health of doctors. We have telephone counselling available for doctors, so you can ring up and talk to another doctor or a psychologist and get some support that way. We have groups of family doctors which have decided to come together either in person or using the telephone to support each other, to talk about how people are addressing the stresses which they are experiencing. So I think there are a number of ways that we can reach out and support each other. I think also we all need to look at what we can individually do to look after our own mental health and well-being. And that, of course, includes trying to get as much rest as we can, although many of us, our sleep has been very disturbed during the crises that we've been living through. Getting support from your loved ones, from your family members, spending time with your family. In some cases, that has had to be via video rather than face-to-face, but connecting with your loved ones and recognising the stress that we are under and seeing what we can do. In lockdown, it's hard to do exercise. Many of us find exercise is a good way to relieve stress. So I was stuck in my room for a while with a skipping rope, jumping up and down and annoying the people on the floor below me with the bang, bang, bang that was occurring. But it was helping me to feel a little bit less stressed by doing some exercise.
Thank you very much. I think that's very important for the heads of faculty of family medicine in Yemen to consider setting up the support groups. As this group is starting, having that support group from the beginning. I don't think this exists at the moment in any other subspecialty in Yemen. So I think family medicine can be a lead by example in here, and I think something we will. We have some of the speakers who are actually actively involved in the organization of and provision of training. So I'm sure they will be very keen to take that on board, because as you said, it's very important, and I don't think it's going to take a lot of resources just to set up a support group in such conditions. Another question is again about the welfare of doctors. Should family doctors be divided in two groups in a pandemic? So, for example, doctors who see in possible cases of infection, and then the other group that are seeing the unsuspected cases.
So that is a very good question, and that's what's happened in some countries. Of course, you have to have enough doctors and nurses in order to be able to do this. So in some places, you've got doctors and nurses looking after COVID patients or doing the testing of people for COVID-19, other doctors and nurses looking after other patients and not mixing. In other cases, we've got good personal protective equipment, so people are fully protected. And very importantly, people are watched when they put on the equipment, but most importantly, when they take off the equipment to make sure they're not at risk of being contaminated and infected, infecting themselves before they go and see other patients. So we have had around the world many doctors and many nurses who have been infected with COVID-19. And we have very sadly had, of course, doctors and nurses who have died from COVID-19 as well, and people who've been infected in the course of caring for the people in their communities. It is one of the huge tragedies of the pandemic, is when we see the people who have given their lives to provide care for their patients, and it's one of the huge tragedies. So yes, if you can separate the two, that's good. If you can't, we have to look at other ways of protecting people.
Thank you. And in terms of PPEs for family medicine physicians, because they are in first line to see such patients in pandemics, either unknown new disease or where TB is very prevalent, what do you think is the minimum in terms of PPEs for family medicine doctors in such areas?
Well, as you will not be surprised to know that I think that family doctors and nurses should be provided with the same PPE that we're providing to doctors working in hospitals in our countries. So in the Australian setting, for people working at times when we've had significant community transmission, it's appropriate masks, it's the eyewear and the visors, it's the gowns, it's the gloves, and it's the ability to for people not to be working on their own, to make sure that we're supporting each other. It can, of course, be very difficult wearing all this PPE when you're in a very hot climate, as of course we have in Australia, and as of course you have in Yemen as well.
Yeah, absolutely. Thanks. And with regards to testing, in areas where testing for pandemic-related diseases is unavailable, for example, in the Yemen, COVID-19 testing is not that easy to get. How does this affect what a family doctor can do in terms of calling cases and case definition for this?
It becomes very difficult. And where you can't test people, everyone becomes someone who might have COVID-19. And so you need to be protecting yourself and your other patients with every encounter, which of course is very difficult to, maybe very difficult to achieve. Of course, some people may have symptoms. If people have symptoms, then we manage them as if they have COVID-19. But the terrible thing about this pandemic is that so many people are asymptomatic or have just very mild symptoms. So it means you don't know if the next person who comes to see you is going to be someone who is currently infected with COVID-19 and could infect you. It makes for a very worrying situation, and therefore, if we can, we need to look at what protection we can provide. Where this is the case, of course, telehealth, telephone becomes even more important in people not coming together. And of course, when we don't know and we can't do testing, we don't know if the doctor or the nurse is infected and asymptomatic and maybe at risk of infecting all the patients that they see that next day. It's very difficult to manage a pandemic when you don't have access to tests.
Absolutely. I remember here in the UK when the pandemic was at its initial stage, we didn't have much, testing, and we are, a country which has lots of resources. It was really difficult at the beginning, and I remember a random testing in our ward for healthcare staff, nurses, assistants, and doctors, and we picked 20% of asymptomatic carriers.
Wow.
Right at the beginning. But of course, things later became so available, which will still be very challenging in countries like the Yemen. This is a question about the partnership pentangle. How can you use that partnership pentangle in preparing for a pandemic?
I think that is a wonderful question, and I'm not sure if I can bring it back up again. But you'll remember that that there are 5 different groups who need to work together, and I think that in countries which have been quite successful in managing the pandemic, those 5 groups have been working together. So the governments and the policymakers who have the money and have to work out where to invest, working with the communities, hearing what are the community's highest priorities, working with the health professionals who are based out in the community and understand what are some of the challenges which need to be met, working with the people who are running the healthcare facilities, and working with the universities. Of course, our universities have been so important because they've been carrying out much of the research to enable us to better understand this brand new disease which has appeared over the last year. So that's everyone, the 5 different groups in the Pentagon, all working together to meet the healthcare needs of the community. So I think it is a beautiful example of how the Pentagon can and should work.
Great, thank you very much. And with regards to the vaccination program, how should the WHO, for example, decide how vaccines are to be distributed in poor countries such as the Yemen? What do you think?
Yes, so one of the approaches which has been taken is to prioritise the population by those who are most at risk. And so when you get the vaccine, vaccinate the people who are most at risk. Now, healthcare workers are among the people most at risk. They're most at risk of contracting COVID-19, but as you pointed out, Wahib, they're at risk of having asymptomatic infection and infecting large numbers of very unwell people. So one of the first groups of people to vaccinate is your healthcare workforce, and not just the people in the hospitals, the people working in the community as well. I hope that message has come across very strongly in my talk. The second group of people to protect are the people who are most at risk of dying if they contract COVID-19. And these are the senior people in our communities, our parents, our grandparents, people aged in their 70s and their 80s, people with chronic disease, younger people with serious chronic disease, people with diabetes of any age, people with significant obesity, people with heart disease, with severe lung disease. So what we're wanting to do with the vaccines is we're wanting to save lives. And the vaccines prevent severe illness, most of them. And so we need to be getting the vaccine to the people who are most at risk of dying from severe disease if they contract COVID-19. So my recommendation, vaccinate your healthcare workforce and vaccinate your elderly and people with serious chronic disease first, and then you can start vaccinating everybody else, probably by age, because the risk decreases as you get younger. Young people won't like me saying that perhaps, but 60-year-olds are at much higher risk than 30-year-olds.
Thank you. And that's exactly the model we are following here in most of Europe for exactly the same reasons. Again, about vaccination, vaccination-related question. How people in poor countries, when they offered vaccinations with not much data published with regards to efficacy, safety, and so forth, how do they take that vaccine and that information?
Yes, so this is a real challenge at the moment. We do have some vaccines which have been released early without full data being published. And we don't yet know how effective those vaccines are going to be in preventing severe disease, in whether they're going to be able to prevent transmission at all. And so that is a real challenge. So if you have the opportunity, please ask for a vaccine which has gone through the full trials and where the data has been published. Now, the Pfizer vaccine, the Moderna vaccine, the AstraZeneca vaccine, the Johnson & Johnson, Janssen vaccine, these are all vaccines where there's been a lot of data published and where regulators in many countries have gone through their regular processes looking at that vaccines. As the person asking the question, we're still waiting for data to be published on some of the vaccines that have been developed in China and in Russia. And until we have that data published, they may be very good vaccines, but we don't yet know until we see the published data. We will probably get a lot of real-world data from China, from Russia, and from other countries using those vaccines, which will let us know, hopefully, how effective those vaccines are. But if you have a choice, my advice is, and Yemen, I'm not sure if Yemen has access to vaccines through the COVAX facility, COVAX, which has been set up internationally. I hope Yemen is able to access vaccines through COVAX. Among the vaccines that you can get are the AstraZeneca vaccine used widely in the UK, the Pfizer vaccine, the Moderna vaccine, and others.
Thank you very much. It's been really interesting. We have lots of other questions, but we'll just do one more question because we are wary of the time. And I think this is kind of nice to wrap everything up, really. This question is, what is the most important lesson from the pandemic for poor countries right now?
Look, wow, what a question. And that's probably the topic for another hour. I think that what the pandemic has shown us in poor countries is those poor countries which have invested in having strong primary care have had the infrastructure to be able to do all they can to protect the health of their population. Those countries which have had no primary care infrastructure have really, the population have been left on their own. So I think this pandemic is actually a very good example of what the WHO has been asking countries to do. And so I hope that coming out of this, those countries which do not have strong primary care will be able to work towards getting that. And so I'll finish up there. I can see my colleague Grant Russell, also from Australia, is in the room with us now. I just want to say a huge thank you for the honour of being able to speak at this conference today. A huge thanks to all the family doctors and other healthcare workers in Yemen who are joining this call. My best wishes to you all. I know you've had an incredibly challenging time over recent years, and now the pandemic occurring on top of it. My thoughts are with you all. And I hope the next time we have this conference, the world is a better place for everybody, and I can actually come and meet you all in person and thank you in person for the great work you're doing protecting the people of your country and your communities. Thank you.
Thank you very much, Professor Kade. It was an absolute pleasure having you on our program today. The information you provided and especially the answers for lots of the questions which were really important for those participating with us today were so insightful and come from lots of wealth of experience and knowledge. And we will be using this information to improve the working condition and also the ambitions and strategic plan for our colleagues in Yemen. Thank you very much, and we would love to have you again and see you in person when the world is in a better place. Thank you very much. I'm sorry that we couldn't answer all the questions, but as usual with these popular talks and inspirational speakers, they will generate lots of questions, but we will do our best to answer as much as we can within our time frame. Our next guest speaker is Professor Grant Russell, and he will be talking to us about principles of improving family medicine services. I'll just briefly introduce Professor Russell. He's there with us. We can see him in the camera. So Professor Russell is a primary care clinician and health service researcher. He is the Professor of Primary Care Research and Director of Southern Academic Primary Care Research Unit within the Department of General Practice at Monash University. He graduated from the University of Western Australia and completed his GP training with the family medicine program in 1989. He subsequently worked as a GP in Perth, in Australia, setting up a small independent general practice with colleagues. Following that, he left for Canada in 2005 to work as an academic, family physician, and clinical investigator at the Department of Family Medicine at the University of Ottawa. Professor Russell's research program is directed towards understanding and measuring the impact of primary care reform on patients, clinicians, and general practice. He has been responsible for over 100 peer-reviewed publications and over $8 million of research funding as a principal investigator. While in Canada, he received the President Award from the North America Primary Care Research Group for leadership in several national investigations of research capacity in primary care. Without further ado, let me welcome Professor Grant Russell for coming with us today and allow him to present his talk.
Thank you very much, Wahib. I would like to share my screen and commence, and it will just take a moment, as we always do with these sorts of presentations. So thank you. I'd like to very much thank INTERYem for the great honour and privilege to present to you here today. As is customary in Australia, I'd like to begin by paying my respects to the traditional owners of the lands on which we meet right across the world today. I'd like to pay my respects to their elders, past, present, and emerging. And I'll just wait until this works. Yeah. So there's been the formal introduction. I'm a family doctor. I live in Melbourne, Australia, on the banks of the Yarra River, and I have a family and a great passion for family medicine. In the last 15 or 20 years, my career has been augmented by the opportunity to research in this wonderful area of family practice. And as mentioned, my focus has been on primary care practices, on how our ways of delivering primary care, how they work, how they fit together. I've had a particular interest recently in refugee health and how we can best meet the needs of the refugees that come and resettle in Australia. As far as my career is concerned, whilst I'm Australian, living in a hot and dusty land, I spent a good period of 7 or so years working in Canada and gaining some of the knowledge that is embedded within their most marvellous healthcare system. And I feel I must at the very outset say that I'm not widely or well experienced in the challenges of delivering primary care in the developing world. I've learnt and reflected a lot over the last few weeks since my invitation came, and I've thought a lot about my time back in the early 1980s when I did an elective and worked for a summer in Port Moresby in Papua New Guinea, working in the pediatric department. It changed my way of looking at the world, and I think there it began to generate my real passion for primary care. But more of that later. INTERYem has asked me to talk about the basics of primary care service improvement. It's asked me to talk about embedding culture, how you embed cultures of improvement, how you measure improvement in services, and to touch on the link between the role of primary care and the role of public health. And I must say that over the last couple of weeks, I've thought a lot about your country, the country of Yemen. Yemen, in my memories, comes from a much loved mentor of mine who worked as a community, a worker, as a doctor within Yemen in the late 1970s. He came back with photos and stories of the hills, of the mountains, of the people. And I can still remember views just like this and the stories that he told. But Yemen was, like many of us in the first world, the developed world, it was in the distance, it remained in the distance. And only recently have I become increasingly aware of the challenges with which this nation has faced. I've read a lot about it. I read a lovely article by colleagues of many of yours in the Lancet from earlier on last year. It spoke of the essential nature of education and research for peace in Yemen. It spoke of Yemen as being the land of Sheba and the Manhattan of the desert, now only referred to as one of the poorest countries on earth, and how sad they were that the name of Yemen had become synonymous with cholera and famine, instability and war, and how the war continues to erase the lives, the history and the future of Yemenis. But conferences and meetings just like this, I think, show that there is a lot of passion and there's a lot of wisdom and there's a lot of enthusiasm to go beyond this. And it's a journey I would love to spectate and maybe even be part of in years to come. They spoke of the importance in moving ahead with facing these twin challenges of COVID and of the conflict, to establish long-term sustainable solutions to address this crisis within Yemen, which is at so many levels, but particularly they talked about how education is challenged, that students drop out of school, and many, as so often happens, professionals and academics leave the country at times of instability. And again, it's meetings such that that is one of the steps towards moving beyond this. And I'm going to say, I'll just preface my talk that I'm very aware of the fact that national health systems are so often the victims of conflict, that infrastructure gets destroyed, that hospitals are destroyed, that health professionals leave, and it's hard to get drugs and medical supplies. There are far wiser people probably on this call who are expert at dealing with this, and I can only echo Michael Kidd's feelings of wishing you well, that we can meet again when we've moved beyond this. However, what I'm hoping to do today is to talk about that future, and hopefully it's not very far ahead, where Yemen is free of conflict, where it can start to rebuild. And that's why my focus I would like to have my focus today. And I'd like us to imagine the health minister. I'm assuming he's still the health minister. And I apologize if for showing his picture, but I must say I thought of the challenges that he is going to face as years to come. Where does he start? Who are the people that are going to come knocking at his door? Who are the people that can help him reshape, reform, and rebuild the health system within Lebanon, within Yemen? I do apologize. In thinking of this, I thought of the past. I thought of my time in Papua New Guinea. That was, as I said, it was 1980 to 81. I was a very young medical student who chose to spend the summer in Papua New Guinea. I was lucky enough to meet Professor John Biddulph, who has left this earth now, but he was a quite inspirational man, because in the midst of this country that was emerging really only a decade or so away from what many have called the Stone Age, times of great, where people were very much subsistent. There was no modern drugs, communication or whatever, but suddenly Papua New Guinea was moving into a new and modernized world. And John Biddulph's passion was about how to bring healthcare to the people within Papua New Guinea. Those people were often in rural settings, not many lived in cities. And there was a lot of pressure within the healthcare system to build some hospitals, to build new hospitals that can help treat the malaria and tuberculosis that was rampant. John Biddulph said no. So he was instrumental in setting up a rural health worker workforce. He recruited health workers who didn't have to be doctors, they didn't have to be nurses. He wrote and he taught protocols for dealing with common illnesses, simple illnesses, gave them simple supplies of medication to help deal with the challenges that they were likely to face in the communities. He was passionate as a pediatrician about breastfeeding, and he was instrumental in the country being able to pass legislation that ensured that feeding bottles and what we call dummies, what they call in North America soothers, were only to be provided to mothers on a doctor's prescription. That was his passion around breastfeeding and maternal and child care. He said to me once, I get so frustrated by it. They want to spend all of the money in building these hospitals, but I know we need to take care to the people and where they live. A second reminder came from that mentor of mine who'd returned from Yemen. He ran a program in the late 80s by this stage that spoke about some of the ways in which primary healthcare could be delivered in different parts of the world. He spoke with a lot of passion about Cuba. Cuba, the country where the revolution of Che Guevara and Fidel Castro percolated and dominated the 50s. And what Cuba did was that following the revolution, they had the same realization that John Biddulph had, that doctors and nurses and health workers needed to work in rural areas. They set up a network of polyclinics. They made every doctor who trained to, by necessity, do 3 years of work in primary care. So notwithstanding the fact that Cuba's gross domestic product was low then and is still low now, they are one of the world's leaders now and were in the late 80s and 90s in terms of things like infant mortality, neonatal mortality, and life expectancy. A remarkable story, Cuba, and it's a story that I think that many of us should revisit and remember. So what about the roadmap, the way that we're going to help our health minister? I'm going to talk today about alma ata. I'm going to talk about evidence, I'm going to try and talk about some of the evidence that underpins some of the reforms to primary care that I'm hoping that we can be part of right across the world, but particularly in a post-conflict Yemen. We're going to talk about getting some of that theory and the evidence into practice, and I'll give that with a rider that is very much, it's a personal view. I don't claim to be an expert about this, but I do have a passion, and I think that later on in this weekend there are some wonderful experts whose life has been devoted to this. You've heard from Michael Kidd, been a wonderful advocate for family medicine throughout the world. Bob Mash later on has done some wonderful things in Africa and his home country of South Africa. But the road towards reforming primary care is a long one, and it started many, many years ago. I just want to walk us down that road a little bit. For many, the road really begins at a conference called Alma-Ata in 1978. However, it was before that, because I don't think we can understand primary care in the world now unless we understand what medicine and healthcare was like through the early years of the 20th century. For a number of reasons, the expenditure, the focus, and the delivery of care was very focused around disease, around hospitals, and around training people to work in hospitals. There were some major moves done around medical education, but all in all, it was a period dominated by specialism and by hospitals. But during the 1960s, early 70s, all over there was, in lots of places of the world, there was becoming a realization that we had to do things a little bit differently. There was a time of social change in the 60s and 70s. Social change, at least, at the very least, in the Western world. People marching in the streets, protesting for the first time against wars that one's country was involved in. And this feeling of social change disseminated over to healthcare, with the result that the World Health Organization sponsored a conference that brought those who were passionate about community and primary healthcare, community care, family medicine, together for a week in the city of Alma-Ata in what was then the USSR. They left that with a manifesto, but just a few stories about Alma-Ata shows how important single people can sometimes be to change. The World Health Organization Director General at that meeting stood in front of representatives of every country in the world and almost shouted, "Are you ready?" He asked them a question, "Are you ready to introduce, if necessary, radical changes to the existing health delivery system so that it properly supports primary health care as an overriding health priority?" He went on to ask whether the participants, whether their governments were brave enough to fight the political and the technical battles required. And just reading the history of Alma-Ata, this man, Halfdan Mahler, a Swiss, was the catalyst, the driving force behind Alma-Ata. So what happened at the end of the conference was that these disparate countries, really in the midst of the Cold War, made a declaration and they committed to move towards it. And the first of the principles of Alma-Ata was that health was a complete state of well-being as opposed to an absence of disease, and that it was a human right. Secondly, that unlike had been thought of with health through decades, it's not just health, it's not just hospitals and drugs, but that you're only going to improve health with economic and social development. They contended that primary health care was the key to realising the right to health. And this definition I'm going to read. It's essential healthcare made universally accessible to individuals and families in the community through their participation and at a cost that the community and country can afford. And that dream can only be sustained by integrated and functional systems leading to a progressive improvement of comprehensive healthcare for all and prioritising those most at need. I think for many of us who work as nurses, as doctors, as health workers, as politicians within the healthcare system, it wouldn't be a bad thing to put up on our walls in our offices. And it's that's worked as a manifesto for 40 years to focus much of the activity of what's been really a really exciting move towards primary care. As often happens with at these times, there was a bit of navel gazing, a bit of doubt following the conference. That dream that I've just talked about was almost seen as too big. And so then started a dilemma about, should we really be having, well, what should we be doing? Should we be maybe selective in primary care, or should we be more comprehensive? And so a whole debate lasted for 10 or 15 years as to whether we should be seeing health as just this broad state of well-being, where there's community participation, or that what really matters in the healthcare system is that the interventions are effective and they're efficient and that they make a difference and they have great value for money. There was a big debate about whether really what we should be doing is having big programs to address malaria, to improve immunization, to treat tuberculosis, or to have our focus on a much broader and maybe a slower sense of change, which is trying to build economic capacity and have links between the health and other sectors and capacity building. Selective primary health care was very much linked with donors. The old third world dilemma or developing world dilemma of donors having money investing in a country with a specific program. Whereas those who were advocates of comprehensive primary health care were much more interested in a long-term view to build the population and build public health. And this debate, when I first got interested in this, was raging around, and it still bubbles around a little bit. But I think what has happened over the last last 20 or 30 years, I think that this view of comprehensive primary care has become much more accepted. And again, there are experts on this conference who might be able to reflect on that in a little bit more detail. Nevertheless, the momentum of this change and revolution to primary care, the momentum built. The United States, where the hospitals and the specialists were king, provided a really major report in 2001, which talked about using primary care to help cross the chasm of quality that they saw within their system. The World Health Organization continued to advocate for primary health care. So that it was almost like a snowball, that there was continuing interest. But how does that actually get met? There's a lot of vague and perhaps optimistic wants and intents. But it wasn't really until we began to understand what is quality primary care that it became easier to implement. And to this, we we really owe a great debt to another pediatrician, a quirky American pediatrician, Barbara Starfield, who wrote about the foundations or the pillars of quality primary care, those things that can help to hold up the whole edifice. Starfield said that there was 4 things that were fundamental and unique about primary care: continuity, comprehensiveness, the ability to coordinate and integrate, and a focus on first-person access to care so that you could get care when you wanted it. I'm just going to talk about those because it's been very important in thinking about how if we don't understand quality in terms of primary care, it's very difficult to improve it. So if you define access to care, well, this is a plain language definition, but it was the ease of which people in the community can initiate contact with a primary care clinician or team for a new or existing problem. It means that the greater the access, the less that cost gets in the way of seeking care for a problem. The greater that distance, the less that distance gets in the way, the less that even our fear or our anxieties about seeing a health provider who is of a different culture or doesn't speak our language. She spoke of the importance of comprehensive care. So unlike where you go along to a doctor who's maybe expert at HIV or malaria, that come to see a primary care setting and that your needs should be able to be met. The broad range of your needs should be able to be met, the common and existent problems. That coordination is critical, that only primary care clinicians can act, whose job it is to coordinate care received from elsewhere. It's only if you see a specialist or if you go to an emergency department, it doesn't matter to them as to how well your care fits together. But if you go to see a community health centre in Africa, part of the job is to see how everything fits together. And finally, that care is continuous, that there is a place and or a person that you can continue to go to, you and your family across time. So Starfield saw these 4 components as being fundamental to differences between healthcare systems. A healthcare system that was accessible, gave comprehensive care, that was coordinated and continuous. The theory was that they should do better for their population than those that don't have those effects. But no one ever knew that. And what Starfield's model has generated is a great deal of research. There is very little doubt that the more a health system's aligned to those 4 pillars, the less the neonatal and all-cause mortality. A big recent study in Europe showed that the better the primary, and they looked at all European countries, that there's less admissions, less years of life lost, better self-reported health in those countries and regions that have got a better adherence to those 4 principles of care. There's costs that they thought, if you're going to set up a primary care system, it costs something. But however, that burgeoning challenge that we all face of more and more money being put into health is less of an issue with systems that are more oriented to primary care. What about specialists? I keep talking about specialists. The model also showed that in regions that, as we've said, key health outcomes are directly related to the quality of primary care, to the degree to which it meets those 4 components. And ironically, inversely related to the proportion of specialists that are in healthcare systems in each region. And what about the disadvantaged? I think that's one of the really big things about primary care, that it is equity busting, that inequity busting. So there's a consistent link between the better primary care development and better health for the disadvantaged and reduced healthcare inequality. So the dream of Alma Ata met the evidence of Barbara Starfield and her acolytes and her men and her students. We now know that those principles are associated with better care for our populations. It applies particularly to lower income countries. A study published about 10 years ago showed the biggest impacts were on infant mortality, again, equity, and there were 36 studies done in lower income countries. 31 of those 36 studies showed that the greater the primary care orientation, the better the outcome. So let's get back to our minister. Where is he going to start? Who's going to knock on his door? And who's going to help him? And the first thing I'd suggest is that maybe he needs to ask the specialist to just wait outside until he talks to those who know and understand how to deliver and how to organise primary care. So, as I said, this wonderful organisation that's organised our conferences asked for some implementable solutions. And purely from my own perspective and from reading the literature and having a think about this, I think that there's a range of solutions that are absolutely fundamental. And it's not mine, it's really transferring this from other people's knowledge, but there must be a government investment in the healthcare system. The net amount of GDP that a number of countries in the region, including Yemen, spends on healthcare is around about 1.5%. This proportion of the GDP needs to increase, so more money needs to be spent on health. It's difficult, but it's fundamental. And our fortune doesn't need to be spent, but more needs to be spent. That with that money, it needs to be oriented to primary care, to build the people, to build the places, build the linkages that can help make a vibrant primary care system. And that there's got to be some investment in preparing the system to meet the challenge. And that's education, it's training and research. Again, INTERYem, fundamental foci. I'm just going to give you some ideas about some of those who've written about investments in improving primary care. So it's almost like the strategies for ministers and health leaders to move ahead. And the first thing a lot of people talk about is universal coverage, such that everyone in the population, just like in Oman, the Sultanate of Oman, can have universal coverage. They can be covered, insured for their requirements to help their healthcare. Looking at some comparative data, I was quite struck by the fact that the high number of out-of-pocket costs, high proportion of the population that have to use out-of-pocket costs to access healthcare in Yemen. It concerns me, and clearly that's going to be a focus for the future. The second, that this really lovely article that was in the Harvard Business Review a couple of years ago, just talked about equal partnerships with public and private sector organisations. There's those bodies that are outside the country, as long as they're not going to be running an agenda of selective primary care, but they're keen to help. Leadership is fundamental in investing in primary care. And I think that is something that challenges our professional organisations. Those people are teaching our doctors and nurses and health workers, that we need leadership. We need leadership on the ground to be able to help move and improve things. And the final thing I thought was really quite striking was that primary care needs to be marketed, that people in the population, just like happened all those years ago in Papua New Guinea, need to know that primary care is special, need to know that they're going to be better off finding a good place of care close to them that they can trust, and that health systems are very aware of understanding and also measuring patient experiences, how good a healthcare system seems to a patient. Secondly, we've got to clearly build on the pillars, build on Starfield's pillars. So it's about making it easy, so dealing with access to care at a number of levels. And that's not just changing the way that services are organised, with opening hours, with people who are able to speak the language of those that are in their area. But it's also about understanding what are the barriers from individual patients to accessing care. As far as comprehensive care, we need our health providers to be trained broadly rather than narrowly. And they need to be great collaborators. They need to be able to work with nurses and other doctors, and they need to work with pharmacists, and they need to work with those local health workers and birth assistants that are meeting with the patients and the people in the community. Care needs to be coordinated. We've got to get information about what's happening in other parts of the system, and that we need to embark on a philosophy that it's important to find a home for one's care. And right through North America, the concept of the patient-centered medical home is really big, but there's nothing special about it. There's nothing first world about that. It's about linking a person with a trusted place of care. INTERYem's principles, I was really struck by education. So let's look at having a department of primary care in every medical school. I've talked about leadership, but let's make sure that our nurses and midwives and allied health professionals and family doctors are trained in the community as a majority, as opposed to being trained in hospitals. And finally, research. That's sort of half my life. So building a primary care research capacity is not going to be a very easy thing to describe to you. However, I would say that if any nation is going to be wanting to build a primary care system, is that research needs to be focused on system improvement, not rare diseases. We need to be able to measure how well the system's performing. We should measure quality at the patient, provider, and system level. And that information needs to be shared with patients and providers and professions and governments. It's not a job just for universities, it's a job for all of us together trying to understand and improve the system. So that's my personal views. Beyond that, fortunately, this journey of primary care continues. But there are the sustainable goals are been a wonderful sort of focus for the activities of the United Nations and the World Health Organization. There was a repeat of the Almaty conference in the same city, which has actually changed its name. It's a slightly more sophisticated concept of people-centered healthcare and putting people at the center of health systems and empowering people was a real theme that came out of that. So I'll give my personal view in this strange way where I'm sitting in Melbourne and you're in Yemen or in the UK or many other parts of the world. I'd be really interested in your questions, but I hope that you can understand my passion and belief that primary care is fundamental to improve health. That you who are working hard and in the midst of such a terribly difficult situation. You're part of a worldwide movement. You're not on your own. But to make your jobs easier, there needs to be funding, there needs to be attention to the 4 pillars. We need a well-trained workforce, we need infrastructure, and we need to measure how well we're going. So the main messages to government: take nothing else. You need to reallocate money to primary care. You need to support the workforce. You need to think about where care is delivered, close to the person. Community health centres in rural areas, just like they did in Cuba, and support this. Primary care people need skills in delivering services. They need to know about public and community health, and they need to be really good at collaborating, working, and understanding the communities in which they live. So thank you very much. I'll conclude there, and I very much appreciate, as I said, the opportunity to speak to you this morning.
Thank you very much, Professor Grant Russell, for this amazing talk. Lots of important points, and we have some policymakers listening to us, and some of their devotees. So hopefully these will be vitally important for them to kind of learn from, and also understand when they plan anything futuristic. We have a couple of questions. I also have some questions, but I'll start with other people's questions. So if we run out of time, then at least I have attended to our audience questions first. One question here: how can we get our staff to include continuous improvement in our working culture, whether in clinic or in any medical department?
I think that's a wonderful question. It begins with the leader, and I think that that's where my sort of advocacy for leadership and leadership training is. It's a really a necessary component. And so building that culture of quality improvement from those who are leading clinics at all sorts of levels, clinics and other systems. There's a bit of science done around it, but I think that one of the things that, in my mind, is that it starts when we're hiring staff, when we're at that first meeting to be talking about and advocating quality. So again, I guess at an individual level, it's a responsibility of the leader, and it's trying to build a culture within their organisation with which they work. At a broader level, I think that the whole concept, and it's a concept that INTERYem uses, which is of train the trainer, so that if leaders can be coming together and to make those issues apparent and important and measurable as well. I think that this concept of measuring performance is an extremely good way of helping focus on quality improvement.
Great, thank you very much. On that note, there is a question related to measuring outcomes or performance. So this question says, when should we start thinking about improving family medicine services? Should we do this before we start the service, or once we are getting data, measurable data?
Yeah, that's a great question. And I think that the principle I've always used with these things is you plan the measurement while you're planning the system. So, and I think that one of the burdens, one of the things we've got to remember in that early planning is that family physicians, family doctors, community workers, nurses, midwives, their job and their skill and their talent is with caring for patients. And we want to be very cautious to not make it an end in itself. So measurement needs to, I would say, to be planned from the beginning, but to be very cognizant and very aware of those people who are delivering the care. we don't want that to get away from their ability to deliver. Now, in a reforming system, as Yemen is got to hopefully have before very long, the last thing I would want you to duplicate is some of the form filling, the documentation that gets done in some of the in UK primary care, Australian primary care, and particularly American primary care. So it's got to be sensible, it's got to start early, and it's got to be relevant to the real outcomes that matter. You know, down the track, it's great to be able to sort of get some of that data automatically. So and that's where computerization can be really good in being able to help us extract data without distracting from patient care.
Thank you very much. That's really, really important. I remember when we did a field trip to Yemen 2 years ago, and we wanted to do some a kind of baseline measurements in one of the hospitals there. And we couldn't find any records that we could actually retrieve meaningful information. So because there was nothing to measure, we couldn't see whether the interventions we did made any impact. And then we had to reevaluate and say, actually, we need to actually start some form of electronic records or some form of data entry somewhere where it can be retrieved and analyzed. And
yeah,
totally without agree. That, it's very hard. And also when it's in terms of continuous improvement, once you see an outcome, you know you can improve on, or you know you achieved your improvement, you can move to something else. And something I think is a big challenge, huge challenge in Yemen, because of the internet problems, data protection, electricity problems. So is there anything you'd suggest?
Yeah, that's a very good example, but you know, it goes beyond health. So part of the health of the community is getting a reliable electrical system and reliable ability to sort of even basic and fundamental connectivity, internet type connectivity. I guess the other thing I would say around the measurement is that maybe it's consultants, if you want advice on these things, often those who are most passionate about it will make it incredibly complicated. Whereas my feeling is, with the sort of needs that you maybe faced 2 years ago in Yemen, and I even face in my own clinic, it's actually fairly simple. The information isn't all of that complicated, and that's where getting in the way with complexity can be a real challenge. So if there are health planners on this call, it's make it as simple as you can and as relevant as you can. But it's so important. I totally agree.
Thank you. And also for our attendees who are policymakers and planners, and also the leads of the faculty, the newly formed faculty of family medicine in Yemen. This is a really good thing to start thinking about now, because there are about 40 residents in the whole of Yemen now. And if these individuals can have that kind of, data records and measurements in mind, they can lead the way and set example for other specialties, but also make a case for family medicine in Yemen as a whole, because those 40 residents are only in one region of a huge country. So taking that on board will be a very important thing to do. And we are going to be making some notes and speaking to people directly about as well. Thank you very much.
Just one thing I'll just quickly add to that is that it actually can be quite good to have a concentrated area, so that it can become like an exemplar. So if you can put your energy into a smaller region, and then the relevant data, the relevant understanding has then got a chance to be able to spread out. So again, it's sometimes the problem with these technological solutions, that we feel like we've got to get the whole country, but we've just got to get it working properly in a sort of pilot or a smaller area, I think could be really beneficial.
Absolutely, yes. Thank you. And I've got a question, again, it's related. What would be the best way to start defining service values and performance standards when we start this as a new program?
I think the word, this is one of those things, there's a whole science and a whole groups behind this, but I would say the one thing that I would absolutely do is to try and reach consensus, so that as far as performance is concerned, it's different things to different people, it's different things to different stakeholders within the whole system. If there can be consensus reached, and that the first process is actually to try and find out what actually is important to people, and then you can start to work the experts into it. But without knowing what the needs are, not just of the population, not just of policymakers, but across the system, someone's going to be disappointed. So it's to make it matter for people, I think, would be my sort of strong, my take-home message there. And it's a whole science. It's people make a lot of. I guess one other thing, just one other thing that comes to mind is that there's some quite good frameworks and models of. It's almost like models to consider when you're doing this. Like we often. This is a problem for family doctors. We always think we've got all the answers, unfortunately. And we sort of forget sometimes that others have looked at these issues in quite a bit of detail. So the more we can collaborate, these sort of meetings like this are really wonderful. That to take your own passion and others' knowledge and reaching a sort of a mutual benefit there.
Thank you. And in terms of collecting data to improve service, what is the priority? What kind of parameters would be the priority when collecting data?
The simple answer to that question is really my earlier answer, that you've got to reach consensus as to what the priorities are. My gut feeling is that it's what matters to people should be the priorities. And I would be very surprised as a parent if one of the key ones are that I want to ensure that my children are being fed, that when they're sick, that they're being dealt with well, and that when my daughter goes into labour, that she's got a good chance of her and both her and her child being safe at the end. So it's those, to me, those very population and community oriented outcomes, things that matter to people, would be where I'd be first starting.
Great, thank you very much. We have
hard to argue against, in a way.
I know, yeah, definitely. So I guess consensus, decide on the priorities and then measure them and hopefully improving them the next time, and then maybe add some other stuff to measure as well.
You know, and I think that one of the things that, and this would be from the policymakers and from the government, there's so many of these things are about trade-offs. So what can you do? You spend money in one area, then you're not going to be able to do it in another. So it's to be very conscious that everyone's got to be on the same page. And if you're not on the same page, then the government doesn't have the will, or the population doesn't have the want. So,
yeah,
it's a really good question. It's a great question.
Thank you. I've got a question from Maha Al-Minawi. She's asking about research. Given your extensive background in research, she's asking, how can a junior doctor improve their research kind of portfolio in an area, a deprived area, such as the Yemen, for example?
Okay. Well, I think the first thing that I would say for a junior doctor is to try and find a mentor or someone who has got skills and knowledge about it. And that could even be beyond the country. I'm going to hopefully be able to circulate my slides that I've used today, but I put one of my final, I actually didn't show this, but I've got some key contacts of some organizations that will be really good for those interested in research and interested in capacity building. In fact, I could even share my screen if you like, if that's all right, just whilst we're talking. Just give me a minute. Yeah. So, hope that's clear. So the World Association of Family Doctors, National North American Primary Care Research Group, the Primary Healthcare Improvement Group, which is a really wonderful set of resources. And another one I found, which is associated with one of the large universities, two of the large universities in the US, Ariadne Labs. We've got a wonderful set of resources for those who are interested in primary care improvement. So I'd really advocate. Sorry, getting back to our colleague in a deprived area. The first is to get someone to help you. And one of the things I've found is that people who've got experience in research are generally very, very interested in helping those who are interested in building their own careers. The second thing I'd say is that to be just mindful that what you're seeing and what you're doing in your own practice, where you're working, being able to gather data, and that doesn't have to be numbers data. That can sometimes, I've had one of my strong research interests is around qualitative research. So it's people's stories of trying to of how their health is, how they face health challenges, but being able to put those stories and those messages out, but particularly of those who are just close to where you're working. I think that's the second thing. The third thing I'd say is, notwithstanding the challenges of technology and the internet, but to get a bit of training about some of the fundamentals of research. And there's some good courses around that are free internationally. And some of these organizations that I've highlighted here, particularly Wonka and NatCraig, can be really good at can just provide opportunities and ideas around helping learn some of those fundamentals.
Thank you very much. And with INTERYem, we recognize research as a massively important component of continuous improvement. And in these conferences, we invite junior doctors to submit abstracts to present. And we have a few that will be presented later today. So it's a kind of a way to encourage them to get involved at an early stage, but also give them a platform to share their experience, their findings, discuss the results, and get feedback from experts in the field. And we encourage the faculty leads to encourage this environment, and also we hope to deliver some of those courses you mentioned with regards to research fundamentals. So this is something a very important pillar for us to it's
really important.
Yeah. On that note, it's been a real pleasure listening to you talk, Professor Russell, and the questions were really engaging, and you can see that it was thought-provoking. People started thinking, how can we measure, in these difficult, maybe lack of resourcefulness areas. But plenty of meat for thought. Thank you very much for being with us today. And we hope we see you again, either in a conference or maybe face-to-face in a better world.
I would love to see you face-to-face. It's been a hard time for the world, but a much harder time for Yemen. And it's been a wonderful journey for me, just learning more about the country, and I really hope to get to meet with some of you in the future. And as I just reiterate again, it's an honor and a privilege to be able to spend time with you today. So I wish you all well, and I hope to be able to join you for some of the time anyway over the weekend. It's a bit late in Australia now, but thank you again, and I wish you all well.
Thank you very
Bye-bye.
much. Thank you very much.
Thank you. Bye.
Bye.
Stop sharing.
Okay, thank you very much for staying with us and engaging with questions. We have a half an hour break before we move into our next key talk, which will be Dr. Osman from Ghana talking about family training in Ghana, lessons learned after 20 years. This is a very important talk for us because as you say, you don't have to reinvent the wheel. You can just look at previous examples and take lessons from that. So we'll meet again in half an hour to listen to this important talk. And in the meantime, if you think of any other questions that you'd like to ask the panelists, please send them across on the Q&A session, Q&A box, or via email if you are on YouTube. Thank you very much, and we wish you a good break, and we will see you in half an hour. So there are different attendees from different places, so check your time. So my time, it will be 11:30, but that's GMT time. If it's Yemen time, it will be 2:30 in the afternoon. Thank you very much. Bye.
Yes, hello. Why?
Hi, Dr. Ezuman. How are you?
Fine, thank you.
Very nice to have you here on our program.
Thank you. I've been on for some time.
Yes, I did notice. Thank you very much. I hope you find a nice flow to the talks.
Yes, extremely useful. I've picked up a few lessons myself.
We are now moving from Australia to Africa. We move on continent.
Yes, highly innovative. I congratulate you for that.
Thank you very much. To be honest with you, this COVID pandemic brought lots of challenges, but also opened the way for stuff like this.
Yeah, yes, that's true. That's true. And we have benefited a lot from our training program because of this quote unquote unfortunate circumstance. So you just have to make the best out of every situation that comes your way.
Absolutely, absolutely. That's what we're trying to learn, that it's not the lack of resources, it's the lack of resourcefulness.
That's
what we
right.
try to.
That's very true.
Okay, thank you very much. So what I will do, I think
It's
everybody, yeah,
time. Yeah,
it's about time now. So I will just welcome everyone. I'll introduce you and then we'll start. Is that okay?
that's right. I think I can share. After that, I can share my screen. Yeah.
Yes, yeah.
Thank you.
Good afternoon. Hello, everyone. We're back again for our third key speech today, following again on the theme of family medicine. So our guest speaker now is Dr. Ekia Izuman. He's a senior lecturer in the family medicine faculty and geriatrics as well in the Department of Community Health at the University of Ghana. He's also an associate faculty member at the Center of Aging Studies, University of Ghana, and a consultant family physician at the Kolebu Teaching Hospital in Accra. Dr. Izuman was the first Ghanaian to graduate with a fellowship in family medicine from the West of Africa College of Physicians in 2005. He is currently the chair of the Faculty of Family Medicine in Ghana, having served in previous positions as secretary, training coordinator, and chief examiner. Dr. Osman has extensive international experience through his service as a trainer and examiner for the family medicine resident in the Western Africa sub-region. He served as the West African representative on the executive committee for Prima Fam Ed Network, which is an organization of academic institutions in sub-Saharan Africa with global partners. He also represents Ghana on the WONCA Working Party on Education. Dr. Izuman positioned ambition and passion is to see family medicine firmly rooted in the health delivery system in Ghana. To this end, he has provided leadership and development the curricula for innovative programs like the modular system of training resident and fellowship programs in geriatric medicine and sport, exercise, and rehabilitation medicine. Dr. Izuman research seeks to explore the role of family medicine in health delivery systems in Ghana through community-oriented primary care. So with that extensive experience, we would like to welcome Dr. Izuman to deliver his key speech today. Dr. Izuman, I give you the floor and the Zoom control if you would like to share your screen.
Okay. Thank you very much, Wahid. I find it very exciting to be invited to this August conference. I was really surprised when I had an invitation all the way from Yemen. And I had to ask a few questions as to whether they were really dealing with the right person.
Okay. No surprise, no surprise.
Yes, so judging from the array of very highly experienced speakers before me and after me, I feel like my contribution is going to be like a drop in the ocean. but I'm comforted by the fact that when the drops are being counted, and this mine will be counted as well.
Not at all.
So I'll share my screen and then we'll just proceed. Here we go. Select this. Okay, thank you once again. So this is the Ghana College of Physicians and Surgeons. That's where maybe the hub of training of family physicians in Ghana. I have no disclosures, and the Wahib has done a good job by introducing me and who I am and what I do. Okay. So this would be my outlines and also act as my section slides. Just a brief profile of Ghana, and we'll look at socio-demographic features and a few issues about health delivery system in Ghana. And then we'll spend a bit of time in the family medicine training program. And we'll look at what we might term achievements, and then so the challenges, and hopefully this might also be relevant to our colleagues in Yemen, how we intend addressing this the way forward. And then we'll have some time for the questions and answers and contributions, etc. So Ghana is located in West Africa. If you look at the global map, I hope you can see my arrow. So this is Africa, and then where you find the colored red country, that is Ghana. If you come below it, you see West Africa. So we are bordered on the west by La Côte d'Ivoire, or Ivory Coast, and then to the east we have Togo, Benin, and our big brothers in Nigeria. So that's where Ghana is. We occupy an area of almost 240,000 square kilometers, and the current population estimated at about 30.4, with a doctor-patient ratio of 1 in 1,000. We just met the WHO requirement. But then the doctor population ratio, that's still quite high. In terms of other socio-demographic features, the capital is Accra, population of about 4 million. We speak English as a national language. Literacy rates gradually moving up, almost 80%. Like most of you know, we are a low middle income country, and that's our per capita, our GDP per capita. In terms of our health system, how it's organized, we just have this, 3-tier system. So the tertiary level care, that's at the national level. And there we have the teaching hospitals and other specialized centers of excellence. So we can have the radiation and oncology centers, we have cardiothoracic units, etc. These are specialized centers at the national level. Then we also have the secondary level care. There we are dealing with our regional hospitals. Currently, there are 16 regions in Ghana. It used to be 10. Recently, it's been increased to 16. So the regional hospitals, which are also departmentalized and specialized. Then we have the quasi-government hospitals. For example, the hospitals belonging to the security forces, like the police, like the military, etc. Then we come to the primary level care. So at the primary level care, we are looking at the district level. And within the district system or the primary level care, we also have subsystems. So for example, we have the district hospitals at level C, district hospitals and the polyclinics. Then you have the health centers level B. They are the sub-districts. And then you have community clinics. In Ghana, we call them community-based health planning and services, the CHIPS compounds. So these are the entry points, for patients to come into the system. So patients can walk into any primary level care. Okay, so we'll be talking a bit more about the primary level care because that is where we think that family physicians should have their main operation or main training. So let's now go into the training program itself. So family medicine training in Ghana is credited to the Society of the Private Medical and Dental Practitioners. I think this is similar to many jurisdictions where you have general practitioners in private sector coming up to start general practice training later for family medicine. So that's exactly how it happened in Ghana. Our neighbors in Nigeria had already started their national program, the National Postgraduate Medical College of Nigeria. And after some time, they thought that it would be useful to extend this training to the rest of West Africa, because the other countries in West Africa like Ghana, Liberia, Gambia, etc., did not have their own national colleges. So the West African College of Physicians, was initiated or was birthed. And we also have the counterparts of West African College of Surgeons. So the West African College of Physicians now extended the training that included all the other specialties, internal medicine, pediatrics, etc. But I'll just restrict my discussions to family medicine. So in about 1991, colleagues in Nigeria through the West African College of Physicians extended training of family medicine to Ghana. What happened at that time was that they accredited or elected some distinguished general practitioners in Ghana as foundation fellows. So they were going to be the nucleus around which the training program was going to be organized. So these were people who were already practicing and had distinguished themselves. So the college sort of grandfathered them into fellowship. So some of these elected foundation fellows now became the nucleus or the pivot around which the new training program is going to start. But it was not until about 8 years later, April 1999, that the extended West African College of Physicians program in family medicine started in Ghana. And I was one of the initial free candidates or trainees who were in the program. Then along the line, a couple of years later in 2005, Ghana established its own postgraduate training institution. That's the Ghana College of Physicians and Surgeons. So now you have two colleges that are training family physicians side by side. You have the West African College of Physicians, the Ghana chapter, and then you have Ghana having its own college that also trains family physicians. The faculty members, the curricula are virtually the same, but they are harmonized. Yes, so it's just having various avenues. Nigeria also has the same system where you have the National College and the West African College. And more recently, Liberia has also had its National College alongside their chapter of West African College. So we need to understand how the system works in our sub-region. So what is the structure of the training program? The colleges, in this case, the Ghana College of Physicians and Surgeons, is responsible for curriculum development. They ensure that the curriculum is of standard. Then the college accredits the training institutions. The training institutions, as we'll talk about that later on, and then also conducts the examinations, and also responsible for conferring qualifications on those who come out successfully. So that's the role of the college. The training institutions that are accredited by the Ghana College of Physicians and Surgeons are the teaching hospitals, the regional hospitals, district hospitals and polyclinics, private hospitals, and other clinics. Now, I've highlighted the district hospitals and polyclinics and private hospitals because these are the institutions where the residents are based. And that is where the training program is actually carried on. But then they carry on some rotations in the other places like the teaching hospital, regional hospitals, and even go to clinics, health centers, and community clinics as well to do rotations. But the training program is situated or positioned in the district hospitals, polyclinics, and some private hospitals that are accredited by the college. The training is in two parts. So you first do a membership where it might take you 3 to 4 years. I will explain why 3 and 4. So 3 to 4 years for you to come out with a membership. And then you might do a further 2 years minimum or more for the fellowship of the college. So in a certain way, it's patterned after the British system. What's the process? The candidate enters the program through the primary exam. So the primary examination evaluates the candidate's theoretical knowledge in the basic sciences that relates to family medicine. So you do applied anatomy, physiology, you do pharmacology, genetics, a bit of biostatistics, etc., etc. And that evaluates your knowledge. So on successfully passing the primary exam, you are now admitted to start your membership program. And the membership program will evaluate your clinical competence and practical skills that you require to manage the conditions that present in all the major clinical specialties. So you do rotations in all the major specialties. You do adult medicine, women's health, you do child health, do some general surgeries as well. So that takes you from first year, second year, third year. You go to the district to do some comprehensive district work for about 12 weeks. Yes. So all that is incorporated into the membership program. And we have 2 tracks in the membership program. One that we call the regular program, which takes about 3 years, and another track which was developed later in 2016, which we call the modular system. That has to do with residents who do not have to move to the teaching hospitals for training, but they stay within the districts and then have their rotations. So they come down to the teaching center periodically for lectures. They go back to the districts, to the accredited training centers, and they go through some rotations under supervision using an approved logbook. After successful completion of your membership, you exit through examinations and you are conferred as a specialist family physician. So you are given a member of the Ghana College of Physicians. The fellowship program evaluates one's clinical research skills in a chosen field in family medicine. So there's teaching that also goes on in the field of teaching, health management, and leadership as well. There are also special interest areas that one may want to pursue for his or her fellowship. And such areas as geriatric medicine, or some will say care of the elderly. We also have palliative and hospice care. There's sports, exercise, and rehabilitation, women's health, adolescent health, preventive medicine, and integrative medicine. So these are recognized special interest areas within family medicine, which anyone with a fellowship can decide to pursue, etc. There's also the opportunity to have an elective program abroad, and the minimum of 3 months exposure to best practices, global family medicine, etc. So that makes the program quite exciting, and you have the opportunity to, as it were, rub shoulders with your colleagues on other jurisdictions, and it helps to strengthen the program. So depending on what field you are engaged in, the fellowship program could be could be between 2 to 3 years. Now you exit through your research dissertation and some examinations, and you come out as a senior specialist family physician. And you are conferred with the degrees fellow of the Ghana College of Physicians. So far, what has been our output? So far, we've qualified about 15 fellows, but then we have members that are qualified about 110, and current residents in training, that is those who are doing their membership, it's about 130. I may come back to this slide when I'm talking about achievement and challenges. So what has been our achievements and our challenges so far? Well, in terms of maybe admissions to the college, currently we rank third in our residency admissions. We are somewhat at par with internal medicine. The most sought after specialties in Ghana is the obstetrics and gynecology, followed by general surgery. So I tell the obstetricians that they are our targets, and that we'll be overtaking them very soon. So we are gradually, moving up. But then also we have been able to decentralize training via the modular track, which I mentioned earlier on. So this is a 4-year district-based program, which utilizes the concepts of the training complexes and also backed by online teaching. I would speak a little bit more on this one. We also have quite an adequate support, quite a strong support from the government. I would also expatiate on that. And what has been a great reward to us, and if there are any lessons to be learned, has to do with collaboration. I always say collaboration, collaboration, collaboration. And our 2 major collaborators, people who really, I would say, offered their shoulders for us to stand on, is the Prima Farm Med Network, and then also the University of Michigan. I'll talk about these ones. My last bullet might seem a bit controversial, but the issue of commitment and loyalty to our cause from our trainees. One of the pep talks that I always give during the orientation process for new residents is that within the constraints of resources and other things that we have, misunderstanding of our specialty by other colleagues and all that, some people take up the challenge, they sacrifice at times even their personal resource, etc., to get the specialty going. So it is expected that at least those who are benefiting from the training would also recognize what the pioneers are doing, what the the forebearers are doing, and give that sort of due recognition to them. Okay, so that's the point which we always want to let's support those who have taken up the mandates to get the program going, and at least to be a source of encouragement for them. So this is a model of the decentralized district-based training program, modified from Jan and my senior in US of Ghent. I wouldn't dwell so much on the undergraduate program, but here we have with the postgraduate family medicine program, and we're working through what we call training complexes. So a training complex consists of the district hospital where the residents are based, actually, or maybe a polyclinics, etc. In the urban areas, we have the polyclinics. So that is where the program is based. But then you have a teaching hospital or a regional hospital which supports the training. So residents are able to do some of the rotations in the various teaching and regional hospitals. So for example, if you want to do a rotation in adult medicine or internal medicine, they go there and rotate for a while, or to do general surgery or obstetrics and gynecology, then they also do some of those rotations. So the district hospital and the polyclinics offers comprehensive or integrative practice. So you go to do your rotations, and then you come back and you integrate that sort of practice. We also have the health centers and the community clinics also as part of the training complexes, because we believe that the family physician should be able to have some practice responsibilities within the district system. So the district system will be the district hospital, the health centers, and the community clinics. So I talk about the vertical axis within which the family physician should be able to operate. It might be difficult to ask a family physician within our circumstances here in Ghana to go and work or stay maybe at a village in the rural area where you have a health center in view of the scarce resources, human resource. But then a district hospital is appropriate. So as part of the doctor's responsibility to pay periodic visits to the health centers and the community clinics, both to practice and also to build capacity. And this is the whole idea of community-oriented primary care, which we're trying to incorporate into our training here. So that's the system. And then also we have the e-learning platform, which has been enhanced by the recent experience, by COVID. So that had really taught us to make good use of the e-learning platform, which I'll talk about. So when we talk about part of the achievements, we're looking also at the government support. And government is the main sponsor for training. There are other institutions, private institutions that also sponsor their residents. But government more or less gives some subvention to pay for their tuition. It's not very much. It's almost about $1,500 per resident per year. It's not, but at least so far as the resident is concerned, you know that the tuition it's been taken care of. Then the government also recognized family physicians and that we are par with other specialists on the same salary scale. So whether you're an internist, you have membership, you are a pediatrician with membership, you are a surgeon, general surgeon with membership, you're on the same salary scale as the family physicians. If there are any variations, that may occur for people who work maybe in the private sector or with other quasi-government organizations like the banks and the maritime organizations, etc. They may have very attractive salaries. But within the public sector, be at par. So that makes it encouraging for people to go into the training. So that is maybe a lesson that we can also look at. So currently we have family physicians who are working in academic institutions like myself, and most of us are in district hospitals and polyclinics, and also in the private sector. We have a memorandum of understanding with the government that we should be able to train large numbers of doctors in the district. In fact, this is what gave birth to the modular program. Okay, and the target is that at least we'll have about 2 family physicians per district, and that is a huge challenge to us. But that is something that we have to put our shoulders. When it comes to collaboration, as earlier indicated, 2 of our collaborators have been outstanding. And then, so I can talk about the primary healthcare and family medicine, like Prima Famed. I'm sure the next speaker would say a little bit more about that. But this is a North-South-South collaboration promoted by Professor Jean de Marcinia from the University of Ghent, yes, in Belgium. So it started in 2008, and the aims of that collaboration was to assist universities in sub-Saharan Africa to establish departments of family medicine. It was also involved in curriculum development, setting up of the training complexes, as I earlier explained, and also capacity building in terms of faculty development for teaching, training, etc., and also for research. So Prima Famed has been very, very instrumental in assisting us. And I think that if there's any lesson from our colleagues in Yemen, then it is really having a good collaboration. And that is why I want to congratulate INTERYem for this initiative, because it is really needed in low resource areas like what we have here in Ghana. Okay, so there has been several, almost yearly conferences together with WONCA Africa. WONCA is the World Organization of Family Doctors, so WONCA Africa region. And then we have exchanges of faculty. So we'll have people like Professor Bob Marsh has been to Ghana to serve as a resource person. I've had opportunity of going to South Africa a number of times to also observe what they do, etc. So these are the ways in which we build capacity. Okay. And the other collaboration has also been with the University of Michigan. And that has also been a very, very instrumental collaboration. So as part of the Ghana-Michigan Charter projects, there was a huge collaboration, and part of it, family medicine became part of it. And the aims here, the same way, so for faculty development, and also for research, and also to help develop our fellowship programs, especially the special interest areas, as I mentioned, and also to help structure the undergraduate program. So within this collaboration, there's also been faculty exchanges. You have situations where some of us have been to Michigan Department of Family Medicine to participate in their programs, conferences. We've also had some of them coming down a couple of times to be as external examiners or to come and offer some lectures, some tutorials. So that's also helped us. There are other collaborators that also assist us, but these are the very main collaborators that we have. What are the challenges? The challenges are quite peculiar. They're not peculiar to Ghana. The continent also experiences some of these difficulties, but we're yet to write a strategic plan for family medicine in Ghana. Our colleagues in Kenya did that as far back as 2007, and I believe that has helped. So even though we have that sort of templates, we're yet to develop that. And it is important because that's going to help us more or less define the exact role or the niche within which we occupy as family physicians, and have some sort of a roadmap as to what should be done. So it's been discussed. We have a fair idea of what's supposed to be, but we need to document it. And that's, I think, is very important. Sometimes there's a bit of confusion as to what our role exactly is. If you happen to be in a district where there's comprehensive practice, it's not departmentalized, it's easy to work. But let's say you work in a district hospital where you have departments like general medicine, pediatrics, you have obs and gynae, etc. But the question is that where you work. So you have to have different models and see where you occupy. Is it in ambulatory care, only at the outpatient departments, etc.? What do you need to do? So these are things that we need to clearly define. Then the challenge of acceptability by medical schools for undergraduate program. Okay, this is linked to the next point of the dichotomy, and I need to explain a few things as to what happens in Ghana and in the West African sub-region. The universities are under the Ministry of Education, and they more or less are responsible for the medical schools. So the undergraduate program is within the universities. When it comes to postgraduate medical training, it is outside the jurisdiction of the universities. It is handled by the colleges. So that is why you have the Ghana College of Physicians and Surgeons, which is an agency of the Ministry of Health, not the Ministry of Education, but the Ministry of Health, being responsible for postgraduate training. So this sometimes presents some difficulties, especially for those of us who work in the universities. So you realize that sometimes you have to divide your time between the college and the university. And the university that pays your salary. The college is more of, more of a voluntary work that you're doing. And I don't know the system in Yemen, but that's something for you to think about. Okay, so the acceptability by the medical undergrad program is still a challenge. But gradually we are making inroads, and hopefully we'll get to a point where we'll have independent academic departments of family medicine within the universities. Then you would have noticed when I put up the slide on the program outputs that the completion rate for our fellowships is rather slow. So we have about 110 members or people who call specialists, family physicians, and who are waiting to graduate into fellowship. And that has been one of our major challenges. And as a result of inadequate numbers of trained faculty, and then also inadequate capacity, for research. Unlike some places where maybe residents may get funding for research, even as part of their programs, that does not exist. You either have to, fund your own research projects, or sometimes in very, very rare situations, apply for some grants elsewhere, but that doesn't really happen. The government does not give grants or does not support research. They only give some support for tuition. So that has been an issue, and one of the challenges that we are set to address. And I think that the previous speakers, I listened to Professor Grant Russell, and he did make that strong point that good research, it's the foundation of the platform for a very good program. So that is an area that you have to look at. And certainly it's collaboration that would help. So what is the way forward for us? What are some of the things we are looking at doing? Well, at the current chair, working with my team, there are specific things that we really want to get done in the next couple of years. We need to produce specifically these 2 documents. And one has to do with the, let me say, completion of a strategic plan for family medicine training and integration into a health system. So a kind of a blueprint for what family medicine is about in Ghana. And then also to provide a template for medical schools to develop their curriculum at the undergraduate level. Each medical school may have its own peculiarity, but then at least there are certain basic things or core issues in family medicine that should cut across. So all that we want to do is to provide a document that will form as a template for the curriculum development. And then each medical school can pick on that and then build their own curriculum. Then we just started what we call the faculty-based online teaching, which has been occasioned as a result of the restrictions by COVID. But then also there's another reason why we decided to develop this faculty-based online teaching. The other reason that we realized that some of the training centers are well resourced and quite and strong in terms of faculty and the teaching program, compared to some of the newer ones, which do not have that sort of resource. So there's the need to have a centralized program that would ensure that every resident, is brought up to speed on the basic principles of family medicine. So the mantra is that no one should be left out, irrespective of which corner of the country you are. We should be able to reach you. And residents are made to make presentations, and there's on rotation basis. So the country has been divided into 4. We have the Northern training complex, we have the Mid Ghana community, we have Southwest and Southeast, because the southern part is heavily populated. So we have that. And we do rotate with the various training centers, that whether you're a regular resident in an academic institution or you are a modular resident in a training complex somewhere, you still participate in that. So that's something we just started, which is gradually catching on. The other thing we need to do is to strengthen our collaborations. And through Prima Famed, we started the e-workshops very recently, just this year. And we've incorporated that into our faculty development seminars, focusing on research and education. So we involve all the senior residents who are fellows in training and all the faculty in these programs. There are other faculty development seminars that are also organized by the West African College of Physicians and also the Ghana College of Physicians at that level. So we make use of all these opportunities in order to develop our faculty, right from their fellowship training until they come out and also become faculty. That's also one area we are looking at. Another area that we looking at with our collaborators is the joint supervision of research dissertations. And I think Professor Russell also made an allusion to that. It should be possible. For example, I mean, my candidates here that are supervised, and then to have another supervisor, either from Michigan or from Stellenbosch or from Yemen, somewhere, so to supervise a candidate and it's acceptable, to the college. So this builds research capacity, and those are the things that we're going to look at as we go on. Then, of course, we've been quiet for too long in Ghana, and we've been doing a bit of talking. And I mean, advocacy went through the World Family Doctor Day, somewhere usually around May 19th, and other celebrations. We have our residents speaking on the media. We're very active during the COVID-19, campaigns, etc. But we all agree that we still need to do more because there's still a lot of misunderstanding, even after these 20 years, misunderstanding of the role of family medicine in Ghana. So we need to educate our colleagues in other specialties. We need to educate those in policy. We need to educate the general population itself as to who a family physician is and what he or she can do. So we need to do more of advocacy. Probably you may say marketing or whatever term you want to use, but that is something that we think that's going forward we need to do. Okay, so maybe I'll just conclude, do my acknowledgements, and then we'll use the rest of the time for our discussions. So I really want to acknowledge our main collaborators, Famed, very great from University of Michigan, Department of Family Medicine. They've been the giants on whose shoulders we have stood. And we'll tell them that we are not going to get down very soon. We still need to be there. And maybe we have to also look at other collaborators as well to work with. I'm also grateful to our faculty board, family medicine, the fellows, members and residents of family medicine in Ghana. It's been a long and tortuous and arduous journey, but we are very hopeful that we're already chalking some successes, and we need to get there. And then also, I'm very grateful to INTERYem conference organizers. As I said earlier on, I was surprised to have the invitation, but I'm grateful. I came in when Michael Kidd was ending his talk, was doing a Q&A, and then sat through Professor Russell's presentation. And I have picked up quite a lot of information which will be useful to me. And I believe that as I sit through the next speakers, Bob Marsh and another presenter on family medicine in Yemen, I think we'll be able to pick up some very good lessons for Ghana as well. So thank you very much. That's my family. I think I will end here for discussions, questions. Thank you.
Dr. Osman, thank you very much for this. It's such an amazing journey. And it looks like you have a solid program, which is really, really something we aspire to have in Yemen. So this whole journey took 20 years, right?
Well, we're actually 22 now.
22 years.
Yes, yes.
So do you think it will take us 20 years to do the same in Yemen?
It shouldn't. Yes, because you always learn from the path that others, have gone. And I think that's the essence of one of these conferences, to learn from the experiences of maybe a program that's, situated within similar socioeconomic circumstances, and to find out how they manage to navigate some of those tortuous pathways. I wouldn't say we are there yet. Certainly you recognize that we are still not there. But I believe there are one or two lessons that Yemen can pick and maybe circumvent that challenge. So I don't think you need to travel 20 years before you do better than what we are doing.
Thank you. And another question comes to me is about the patient. I guess in Ghana, it'll probably be similar as in lots of hospitals, maybe private sector, and patients got used to just turn up to a hospital. What makes, the patient decide to go to a family medicine doctor rather than go to a hospital?
Yes, thank you very much for those questions. It's a very insightful one. In fact, the information that we have, and we need to gather the data actually, it's that, and these are reports from our residents and from other specialists who come into contact with our family physicians. The distinguishing factor between a family physician and, if I should say, other specialists is not really about the type of medicine you give or the procedure that you do, but basically has to do with a patient-centered approach. I mean, basically, that is where you really seeing the patient as a partner in the healthcare provision. Attitudes, towards the patient. The concepts of family medicine, it hinges around the behavioral sciences. So it's sort of really makes you patient-centered. So that's very principles that we apply in patient care, exploring, for example, the illness experience of the patients, what we call the FIFE, looking at the fears and feelings of the patients, the ideas that he has about his condition and any impairment of function and his expectations. Just exploring that alone is enough for the patient to actually come out and talk to you about what is really happening. So those are the issues that would make that patient come to you. I always tell the residents that anybody at all can prescribe medications for malaria, okay? But what will make that patient come back to you as a family physician? It is your approach to care. And I think that is a distinguishing factor in family medicine. That's what I experience here in Ghana.
Thank you very much. This will certainly be a challenge in introducing family medicine in a country which is not used to family medicine.
Yeah.
Thank you. I have a question from just a note for participants. Please post your questions on the Q&A chat box because we can see who's asking. We've been getting emails and people put in questions on the YouTube. But if you were, if you make use of the chat box, that would be great. This is quite an interesting question. As you said family medicine is now ranked number 3 in terms of popularity in Ghana's training programs. How did the family medicine become such a popular training program? And what's the mix between women and men in that training program?
Thank you very much for the question. Very interesting. It's interesting. When we started the program, there's something that we used to do initially. We called it family medicine promotion seminars. So annually, we used to organize a promotion seminar or orientation for final year medical students, house officers, and medical officers who are in the system. Our system is such that after your house job, you could decide to just work as a medical officer and through in-service training become a senior medical officer, principal medical officer, chief medical, etc. Then there is the academic track, where after house job, you go into residency. So you train along that line. So we try to capture those who are quote unquote untrained, academically. So we hold the seminars, the promotion seminars, and there are a lot of questions that come and we try to answer their questions. We show them textbooks that's been written. We show them that yes, there are professors in family medicine, globally, and so you can also advance your career in the university. We show them there are researchers in family medicine, so that exposure was there. Then when some of us got into the academic institutions to start teaching undergraduate family medicine, we were able to model the family medicine practitioner to them. So they come with us to the clinics, they see us work, they see our approach to patient care, and the things that the mix of skills that some of us have could be medical skills, surgical skills, obstetric skills, whatever, to a certain appreciable degree. So they saw that sort of thing. And then also when some of us started publishing, so all those things became, a point for them to realize the need for family medicine. Then of course, we also have what we call some champions from the other specialties. So you may have someone who's a surgeon or an obstetrician, but who really understands family medicine, and they also become advocates for us. So when our residents go on rotations in the teaching hospitals, these are the people who will talk favorably about family physicians, and they will say that we need to train them well so they can work with us. So that the cases that are, for example, referred from the peripheries to the regional and teaching hospitals will be, well sorted out. We'll make sure that patients are well treated and the referrals are done appropriately. So these and other factors are reasons why maybe family medicine has become quite popular in Ghana.
Right, excellent. What about the mix?
Yes. In fact, it got to a point that we're having more females, more women in family medicine than men. But now I would say it's about 50%, either way. Yes.
Do you have also women trainers?
Sure, we do. We do have women trainers on the faculty. Very, very strong and versatile female faculty who are part of the trainers. Yes, we do.
Thank you very much. That's really interesting to see how, it changed from, non-existent into a popular one. That's very interesting. We've got a very big fan, Dr. Osman, somebody who likes the chicken in the background. It reminds them of the village in Yemen. So their question is, how would you encourage our policymakers to encourage family medicine training in Yemen?
Thank you very much. I think the previous speakers made some very good points. And I think there's enough evidence also to suggest that any country with a very solid primary care has very good health indices. And the last speaker quoted Barbara Starfield. There are studies in the US itself. We can cite examples from Cuba, Brazil, and know that when there is a very solid primary care health delivery, it translates into a total healthcare of the population. So it's very important for us, and this is where the advocacy comes in, to show this evidence to our policymakers, engage them in some of our meetings, conferences like this, allow them to also pose their questions, show them what's happening in other places, and then show them what we have also done. That is also a very important point. It is important for us to start with the little that we have and show that, well, we started in this small way, but this is what we've been able to do. So if we get your help, we should be able to do better. So is it possible to have a pilot project somewhere in Yemen, somewhere in Ghana? And as part of the training program, you showcase what can be done to the health of a defined community. And when data comes out from that research, you'll be able to show that this is what we've been able to do. And therefore, with your support, we should be able to expand it.
This actually leads nicely to the next question, which asks, is there any data to see the impact of family medicine in Ghana? What was the impact?
Yes, thank you very much. So this is one of the areas that we need to work on. Recently, myself and the next speaker, Bob Marsh, led us to do the impact of community-oriented primary care in Africa. And we realized that one of the data that was lacking was really about the impact, to really measure what family medicine has done. And that, I would admit, is one of the challenges that confronts us, that we have to give concrete evidence. So far, I must say it has been quite anecdotal, and we need to put that data together in order to show that evidence. Yeah.
Oh, that would be amazing. That would be amazing. A question here about, in terms of getting the training program recognized, what was the critical or the crucial step in making the training program recognized?
Well, I think in a way it started from establishment of the college, and at least Ghana College could learn from the West African College of Physicians, which had already started a program. And within the various, the college, let me just restrict to Ghana College. Within the Ghana College, you have the various faculties. So internal medicine, surgery, obs and gynae, etc., etc. So then family medicine had already become a recognized specialty in the sub-region. So it wasn't a difficulty incorporating it into the college. And once that was recognized, the next step was to get faculty who would do the training. I don't know that the postgraduate system in Yemen, but if there's a college, or if it's the university that is responsible for training, then it behoves of that particular body to give that sort of recognition to family medicine. In this particular case, if it's a program that is starting ab initio, then you need to look at best practices elsewhere, the experiences from some of the people you've invited, which would be enough evidence for recognition of such a program in Yemen. So that was the genesis of our program. There were examples in the sub-region and from elsewhere, so it wasn't a difficult to recognize, right?
Great, thank you very much. We are running out of time. We have two more questions, but I think we'll just, for the sake of time, we will just wrap up. Thank you very much, Dr. Osman, for your insight into the history and the gradual progression of establishing family medicine training in Ghana. There's definitely lots of lessons for people like us who are starting from scratch to learn, especially since we have policymakers and people who are leading in this faculty. Thank you very much for your time. We hope to see you again, and hopefully in a better
realm. Yes. Thank you so much for the privilege. I'm very, very grateful, and I wish you all well in Yemen.
Thank you. Thank you very much. Okay, thank you very much for everybody for staying with us. We have one more lecture before we break for lunch or dinner, or because we have people from all over the globe. It was night in Australia. It's now around midday in Africa. It's morning here for us in Europe. So it's quite different times. So I'd like to welcome Professor Bob Marsh, who will be talking about strengthening family medicine through family medicine doctors' lessons from South Africa. A little bit of an introduction for Professor Marsh. He is a professor of family medicine and primary care in South Africa. He's also the coordinator of the Prima Fam Med Network in Sub-Saharan Africa, which we have heard about briefly earlier. Professor Marsh is an established primary care researcher in African context with over 190 publications in peer-reviewed scientific journals. And he's also a leading researcher in Africa in the field of family medicine. He has developed, he's helped to establish the discipline of family medicine in South Africa and also many other nearby countries such as Zimbabwe, Kenya, Malawi. He's currently the president of South the South Africa Academy for Family Medicine. He's also the chair of the steering committee for a global primary healthcare research consortium. He's committed to the development of community-oriented primary care, primary health care, and district health services in the region. Without further ado, please let me welcome Professor Bob Marsh to deliver his keynote speech.
Great, thank you very much. I assume you can hear me.
Yes.
Okay, good. I'm going to share the slides, inevitable slides. So great. It was great to hear Ache speaking just now from Ghana. Actually, it's not just collaborating with Prima Family, he's part of the executive of Prima Family, so he's kind of collaborating with himself there. But I hope, Ache, I hope you're going to stay on, because I see that you've got a couple more questions for you later. I've probably got, Wahib, I've probably got about 20-30 minutes here to share about South Africa. And I'm kind of hoping that, people will then ask some questions. I'm not quite sure what aspect, is going to land with you, what's going to be helpful for you as you think about family medicine in Yemen. So I'm hoping people will ask questions in the Q&A, and then we can have some time to discuss. If Ache is still here, he can also join in, I guess, later on. So my talk, as you can see, is strengthening family medicine care through family medicine doctors in South Africa. That was the title I was given, Lessons from South Africa. So I'm just going to set a little bit of the scene where I come from. Obviously, I don't really understand the Yemen context, but I can at least sort of tell you about my context and what's happened in South Africa, and then we can see what lands with you. So this actually is where I've worked clinically since the 90s. And this is on the edge of Cape Town, Khayelitsha, which means our new home, somewhat ironically. And you can see there in the background is Table Mountain, the sort of iconic Table Mountain. So this is my clinical context. This is a very old photograph. It's an aerial photograph of Cape Town. You can see in the background is our famous sort of Table Mountain. And then here in the foreground, of course, is the inevitable tertiary hospital, Tygerberg Hospital, and linked to it on the right, the medical school. And, that dot more or less shows you where these days I now sit as an academic in the medical school. And you can see, looking out here across the Cape Flats, some of the communities that we are serving. And then just to show you inside the medical school, this is the family medicine division, and these couple of my colleagues. So you can see in the middle there's Michael Pather, who heads up our undergraduate teaching in family medicine. And then on the left is Seppo Mutsui, who heads up our postgraduate teaching in family medicine. So that gives you a little bit of a picture of where I'm coming from. More broadly speaking, I mean, I don't know how much you know about South Africa, but on the top left there, of course, is our rather ignoble past and the apartheid system, which ended, of course, in 1994, but which meant that our health system was very much fragmented along these so-called racial lines. And that's been one of the challenges as well, that primary healthcare was very, very underdeveloped in South Africa, particularly for Black and so-called colored and Indian communities. And that's kind of our legacy. And you can see on the right, I've put in these two photographs to show you that inequality in South Africa is still very much a major issue. And even on, on Thursday, I couldn't get to where I was working due to protest action about housing and sanitation and water on one of the freeways coming into Cape Town. And then, of course, another aspect you may have picked up on down the bottom left there is President Zuma, who of course is now our ex-president, but is now in court facing charges of corruption and the whole issue of state capture. So these are some of the broader sort of political and contextual issues that frame primary healthcare and family medicine in South Africa. This is what we're dealing with. This is our burden of disease, and you can see that we have an enormous amount of HIV, sort of more than almost any other single disease. In fact, we have the largest antiretroviral program in the world in South Africa. And then our burden of disease has been described as a quadruple burden. So you can see here that HIV is essentially a quarter of the burden. Then we have a very large contingent from non-communicable diseases. So in fact, as of a year or two back, diabetes is now the leading killer actually of women in South Africa. And I think HIV and TB remains the leader amongst men. We also, of course, have, as you can see there, a big problem with trauma and violence, both road traffic accidents and interpersonal violence. And then finally, the sort of traditional, I suppose, issues around maternal and child health with deaths from, lower respiratory tract infections and diarrhea and so on. So so we've got a very, very significant burden of disease and, amongst I think we're about 55 million people now. So the health system, you can see on the left here, I've put in just a sense of how these 55 million people are using the health system. So about 80% of the population are uninsured, often actually very poor, and are using, in essence, the public sector. So the public sector, which I'm predominantly talking about, serves about 80% of the population. And then there's about 20% of the population who are insured and slightly more affluent, sometimes very affluent, and they are looked after by the private sector. So our health system is pretty much similar, I suppose, to most health systems. At the top, we've got quite a lot of tertiary hospitals, then we have regional hospitals, and underneath that, the district health services. So for example, in the Western Cape, I think we're quite well off. We've got 2 tertiary hospitals. I think we've got 3 regional hospitals and then 5 health districts. So the district health services, of course, is the natural habitat of family medicine. And this is what it looks like, a little bit more detail on this slide. So most of the districts have at least one, if not more than one, district hospital. And these are often small, quite often rural and remote hospitals with sort of 50 to 100 beds, something like that. And these are generalist environments. These are not divided up into the traditional specialist departments. And what we have been moving towards in South Africa is that the family physician would be the lead clinician in these teams working in district hospitals. And you can see there on the left, that's Klaus seeing a patient in, I think that's Mossel Bay District Hospital. Then, of course, underneath and connected to the district hospitals, we have the primary care platform. And in South Africa, the main primary care provider is actually a nurse practitioner. And so you can see here in the photograph, one of our nurse practitioners. And there's, of course, a variety of different types of primary care facilities. We some of them are quite large, and some of them are open 24 hours, might have a maternity unit, might even have an emergency center attached. And it goes all the way down to small clinics and mobile clinics, which might just have 2 or 3 nurses. And then underneath that, we also have community-based services. And I put in here a photograph, more recent photograph of community health workers and health workers from the local primary care facility doing community screening and testing for COVID-19 in Cape Town. So these 3 elements of the district health services are very much where family medicine is located. We have, I guess since 1994, the new democratic government in South Africa has had quite a policy emphasis on primary healthcare as sort of the foundation of the health system. And I've introduced quite a large number of health reforms, to try and strengthen our health system, particularly along the lines of primary healthcare. And I just put up a few of them here, which I think are important, also context to where family medicine is and is going. So we have a desire to introduce national health insurance in South Africa, and there is policy published on this, somewhat derailed by the coronavirus pandemic. But the idea, of course, is that every South African actually should be covered by national health insurance, and healthcare should essentially be free at the point of use. We've also introduced across the country what I've referred to here as community-orientated primary care, which has introduced teams of community health workers called ward-based primary healthcare outreach teams, but essentially they're community health worker teams led by a professional nurse who are responsible for a delineated community. So, one community health worker would have plus or minus 250 households that they are responsible for, and would have responsibilities around health promotion, disease prevention, as well as support for some treatments, and potentially also issues around rehabilitation and even palliative care. So that's been a major shift, shifting the system from people sitting in primary care clinics waiting for people to come because they're sick, to looking at the population at risk and covering that population at risk through community health worker teams, and being more proactive in terms of outreach to the health needs of communities. Then down the bottom left, another intervention was what they've called district clinical specialist teams, which were introduced to improve maternal and child health, particularly in relationship to the Millennium Development Goals at that time, and now the SDGs. So these were teams, as it said, of specialists, so sort of an obstetrician, a pediatrician, a family physician, an anaesthetist in some cases, and others, whose job it was to try and raise the quality of services within districts for mothers and children. And that actually meant that every district in the country had at least the opportunity of one family physician at that level. And then finally, I put in here, I'm not sure whether the government would see it like this, but one of the key health reforms from my point of view was the recognition of family medicine as a speciality in South Africa in 2007. So this is a little while ago now. So I guess coming up almost for 15 years, family medicine has been recognized. And I think one can see the introduction of family physicians with postgraduate training in family medicine, specialists in family medicine into the health system as another key reform. So why did, so I think somebody asked actually this question, why did South Africa recognize family medicine? And I think I put these 3 reasons. I think there, as I said, strong advocacy from the discipline. So in fact, even going back to the 1980s, we had the discipline of family medicine in South Africa, often at that point quite focused on private general practice, but building up a sort of a level of momentum and political advocacy for the relevance of the discipline to improving primary healthcare and district health services. And I think that eventually landed with the policymakers. And partly it landed because research has shown very clear skills gaps at these district hospitals. So we had hundreds of these district hospitals around the country, but a lot of them were not actually offering the package of services that they were meant to offer because of a lack of competence amongst the people that were working there. And so the potential of introducing family physicians who were well-trained generalists with a full package of competencies was seen as a way of filling that gap. And then, of course, despite the improvements in policy towards primary healthcare and to some extent the infrastructure in primary healthcare, the quality of primary healthcare has remained fairly low. And so I think there was also the recognition that having a family physician contributing to the team in primary healthcare could also raise quality. And in fact, our National Development Plan specifically mentions family physicians in relationship to clinical governance. In other words, improving the quality of district health services. So what are the roles then of the family physician in this health system? And I've got Martha here, Martha Mekabeb, one of our recent graduates, to remind us that we're talking about people like her. But I've sort of boiled this down into three areas. So the one, of course, is that family physicians must be, really good clinicians, obviously, at the district hospital in South Africa, as well as in primary care. But their role really is not so much first contact. They're not as I've said, the primary care provider. That would be a nurse. Their role in both of these spaces is more that of a consultant. So they might come and see more complicated patients in the primary care space, and they would oversee the district hospital team and probably also be directly involved in more of the complicated patients. So their role would be that of a clinician, but in fact, something of a consultant to the rest of the team. Having family physicians in the way that, say, Europe or America has them, it's just not feasible with the resources in Africa. Then the second role, which I've sort of mentioned already, is clinical governance. That's been given a lot of emphasis by policymakers. And essentially it's around improving the quality of care. So a lot of the family physician's time is also looking at implementation of guidelines, audit and feedback, training, looking at data coming out of the health system on sort of rational prescribing, use of investigations, et cetera, but all of it designed to improve the quality of clinical care. And then the third major role is that of capacity builder and clinical trainer. So capacity builder really saying is that this person is the most highly trained member of the team, both at the district hospital and at the health center or clinic, and has a responsibility to improve the training of the other members of that team. So, the other members of that team often have quite sort of brief training, I suppose would be the way to say. A nurse practitioner probably is only trained for 1 year to take over that role. Community health workers may be trained for a matter of months. And so there's a lot of need for capacity building. And then clinical trainer sort of implies a little bit more of a formal role. And these days, they may have more a formal role towards medical students, interns, and registrars in family medicine. So the placement of the family physician in our health system, and I think I've said quite a bit of this already. So clearly they're a lead clinician at the district hospital, in the healthcare team. At the primary care level in large community health centers, they may actually be placed there permanently and full-time as the lead clinician. In some sub-districts, they may be performing outreach to all of the clinics and smaller facilities from the district hospital or from one of the larger health centers, where they would be doing outreach and support essentially to that primary healthcare team. And then in the community, and I think this is a role that they kind of need to really engage with more, is to support the community health worker teams and the activities taking place in the community. And then, as I've mentioned, we also had a number of them employed in these district clinical specialist teams. And there are some regional hospitals that have developed departments of family medicine where they're employed, and quite a number, in fact, of people we've trained have also been taken up in the role of clinical managers at district hospitals around the country. So how do we train them? In fact, we've got 9 university-based training programs in the country, and they all, so slightly different actually from Ghana, where they've got a college, primarily a college system. They do an MEd degree with the universities. It's a 4-year training program. We have to accredit the training complex with our National Health Professions Council. So the complexes these days typically consist of district hospitals and primary care facilities, with some use of the regional hospitals or tertiary hospitals. We have agreed nationally on a set of programmatic learning outcomes that all programs buy into, and a set of clinical skills that are required by all programs. We've also agreed nationally on a portfolio of learning to show what is happening in terms of workplace-based learning and assessment. And that portfolio is required as an entry, it's an entry requirement to our national exam. All of this, and getting all of this sort of national consensus has required coordination. That's now done by the Academy of Family Physicians, which is the sort of professional body in South Africa. So they bring together people from these 9 programs to ensure that we remain on the same page with each other. And then we also have another body, slightly confusingly, the College of Family Physicians. In essence, they're responsible for our national fellowship examination as part of the colleges of medicine of South Africa. So all specialties are included in the colleges of medicine. And then one of the colleges is for family physicians. And this college runs our national licensing examination, where people would obtain a fellowship. And we've sort of linked together the MEd and the fellowship processes so that both the universities and the college are happy at the end of the day, and they actually get both qualifications. So the training of family physicians, a little bit more on this. So on the left here, you can see that programmatic learning outcomes are divided up into these 5 areas. So there's a focus on leadership and clinical governance. There's a focus on the whole person medicine, which is really the sort of clinical competencies. There's a focus on community-orientated primary care and supporting and developing that. There's a focus on the skills you need for teaching and training, and then ethics and professionalism. So you can see how these unit standards relate to the roles that I mentioned earlier around capacity building, clinical training, clinical governance, and being a clinician and consultant. And then on the right here, you can just see that we have divided the sort of clinical world up into these 10 domains, which people are meant to be trained in during the course of the 4-year program. We've also developed a number of educational resources, which I think are also used. I think Ghana also uses some of these. There's the Handbook of Family Medicine, which is more about, well, it has quite a lot of clinical content these days, but it also sort of describes conceptually, in a way, what the whole discipline is about. There's the South African Family Practice Manual, which actually is very much focused on the clinical and procedural skills required. And we've got a list of just over 200 of these skills, and all of them are then expanded on in the manual. And then we also have a national South African Family Practice Journal, which is one of the things that the Academy does. And this also supports training. So we have a big section on continuing professional development and a special section for registrars in training. We also have other training options for family medicine in the country, apart from the specialist training. So one of the things we've introduced in the last few years is a postgraduate diploma in family medicine, which is a 2-year diploma focused very much on primary care and not on district hospitals. And the idea of this was to upskill and reorientate the very large number of primary care doctors in the system who will probably never become specialists in family medicine, because that would require them to become registrars, and they're a bit old for that. So this is really focused on that group. We also have a Bachelor of Clinical Medical Practice, which is run by some of the family medicine departments, and which is a 3-year bachelor degree to produce what's referred to as clinical associates. Other countries refer to them as clinical officers or physician assistants. It's essentially a mid-level doctor, and they are targeted at district hospitals to assist there. And then I think, as Aceh also mentioned, over the last 10, 15 years, all of the universities have introduced family medicine into their undergraduate training, and now actually have quite significant exposure at the undergraduate level. And then this year, actually, the 2-year internship program, which you do immediately after qualifying as a doctor, now includes 6 months of family medicine and primary care. So it's literally a quarter of the entire internship that's been dedicated to that. And that seems to actually be going quite well. I've been visiting some of the interns just last week. So I have mentioned, I think already, the South African Academy of Family Physicians, and I've put this up here. You can, of course, go and have a look at the website if you're interested. But one of the things, of course, that the Academy does is to also provide continuing professional development to the discipline. So this is a relatively recent piece of work that just shows you where we've got to in terms of human resources for health in family medicine in South Africa. You can see there's 2 groups here. The one is referred to as medical practitioners. So these are actually people who have had postgraduate training in family medicine, but have not been grandfathered over onto the specialist register. They were trained prior to 2007, and they haven't made it across. And there are 969 medical specialists who are on the specialist register as family physicians. And they, of course, make up all of the recent graduates since 2008, as well as those that were grandfathered across from the previous sort of non-specialist family medicine register. And you can see that from our picture on the bottom left of South Africa, that the distribution of family physicians is not uniform, as in many countries they are sort of congregating in the metropolitan areas and are fewer in the rural areas, and certain provinces have embraced family medicine more than others. I see somebody asked actually earlier on about men and women, so you can see on the, it's the right-hand side here, that the number of women currently on the register is 26%, and the number of men is 74%. The women are slowly increasing. And then down the bottom, also with the new family physicians, of course, the demographics are also transforming, and we've got a lot more, black, colored, and Indian family physicians, which is a good thing. So the pipeline, look, also just thinking of our human resources for health, the pipeline is there, but it's not flowing as fast as we would like. The grey bars represent the sort of cumulative production of family physicians since the speciality was formed. And you can see that we've produced almost 200 family physicians since then. But for 9 training programs, that's not a great accolade. And there are reasons for that. You can see that new registrars coming into the training programs around 50 a year, and the people exiting is around 20 a year. And here, I think that the line to look at here is the little orange line with the red dots, which is showing you the density of family physicians against population. So you can see that we have improved, actually gone up 4-fold. From 2009, we had 0.04 family physicians per 10,000 people, to now we've got 0.16 family physicians per 10,000 people. So improvement, but not great. You know, if you were to look at even other middle-income countries like Brazil, for example, the numbers would be more sort of 1 to 2. If you go to higher income countries, you know, you're talking, you know, 10 per 10,000, that kind of figure. We have done a little bit of work on the impact of family physicians on the health system. And in fact, this is the work of Klaus von Presselton, who did his PhD on this topic. And this is just one of his studies, where he looked at, he did a survey of family physicians around South Africa and asked all the people working with the family physicians to evaluate their impact. So it's sort of like a 360-degree evaluation of them. And you can see on the left that the impact, if the impact was more than 3, then it was considered to be a high impact. And so people were rating their impact pretty highly across all of the roles that I mentioned earlier. The one that dropped a little bit was capacity builder. And then on the right, they were also asked, so, but I mean, is the impact of this family physician actually any more than just having any old medical officer here, you know, without postgraduate training? I mean, does it really make a difference that they're a family physician with this postgraduate training? And interestingly enough, the answer that they gave was actually yes, the family physician's impact relative to the medical officers across these roles is much, much higher than if we just had medical officers without that training. So you can go and look at his work. I think I've put it in the bibliography at the end. So we've got some early evidence of the impact of family physicians on the health system. But of course, given the very low density, it's quite hard to show high level impact. So the future of family physicians, our stated goal, which we're trying to argue with the policymakers, is that we should have at least 1 family physician for every district hospital, and there should be a post for that, and they should be employed. There should also be 1 family physician for every community health center or every sub-district if they don't have a community health center. And these are fairly modest goals, but we think it's achievable within the next few years. Of course, we do need a supportive human resources for health policy in South Africa to support both the training posts and the family physician posts and the growth in the pipeline. And unfortunately, at the moment, we actually don't have a human resources for health policy. So that's an area. And of course, we also need supportive financing policy. We need to ensure that the plans around the National Health Insurance Scheme take account of and encourage you know, appropriate remuneration and posts for family physicians. And also in the private sector, the medical aids have been patchy in the way that they remunerate family physicians relative to other GPs without postgraduate training. And that's another area where we're working on. And of course, as been mentioned, there's a need for an increase in evidence base on the contribution of family physicians to health systems in Africa. And in fact, right now, the African Primary Healthcare Family Medicine Journal has a call out for people to report on how they're making a difference in different countries around the region. And of course, the regional support and networking has also proven to be important in articulating and conceptualizing the discipline. And Prima Famid, as actually mentioned, I think has been important in the region. And we have now developed some useful contacts and connections to the World Health Organization in our region. So here's just to show you, this is the African Primary Healthcare and Family Medicine Journal, and some of you might be interested to go check this out at some point. I'm actually the editor-in-chief, so I have to promote it. So, but a lot of the research from the region is published here. And then also just to mention to you as I finish, the Primary Healthcare Research Consortium, which is now a global consortium that is trying to do research on some of the unanswered sort of big questions around primary healthcare. And that might also be of interest to some of you to go and have a look at what we're doing and to connect into that a bit. Okay, I have put a bibliography at the end here, not that I'm going to speak to it, but just that some of you may want to go and look at some of the underlying literature to what I've been saying in the talk. So I've given you that really, so you can look at it later if you're interested. Okay, that is my talk. How are we doing? Yeah, that was about half an hour, wasn't it? So yeah, I am happy to discuss things, answer questions. I don't know, has anybody posted anything in the Q&A? Absolutely nothing. So, back to you. Let's see if there are any questions.
Thank you very much, Professor Marsh. That's really, really an interesting talk, and so many things that actually I wasn't expecting, especially the interplay between primary care and district hospitals. Coming from the UK, from Europe, we don't see this model, and it was just like, really, you know, and but I can see how this may work for a country like Yemen. One of the things you mentioned there, you said having the same model as the US, UK, or Europe would not be practical in South Africa. Is that because of resources or something else?
Well, yeah, it's mainly due to the, well, it's two things really. I think it's the scarcity of human resources for health. So although we're a middle-income country, we don't have huge numbers of doctors, and we certainly don't have huge numbers of family physicians. So, you know, if we wanted to have a health system, you know, where a family physician was the primary care provider, you know, we would need to supercharge our training program, but then we'd also have to have huge amounts of money, you know, to pay doctors to take on that role as the sort of the first line primary care provider. And we also don't have that money. So back in 1994, you know, when the new government looked at the situation, they said, you're going to have to base this on nurses because we've got lots of nurses and we can afford them. And that was the decision taken. It probably was the right decision. So, and if you think about it, South Africa is an upper middle income country. And lots of other countries in the region are actually low middle income countries or low income countries. So they're even in a worse off position, both in terms of human resources for health and in terms of the economics. So it's just not feasible to promote a primary care system that's based on a family physician as the first point of contact for everybody.
Great, yeah, thank you very much.
If you try and sell that to policymakers, then they'll show you the door.
I think the door is already open for us from even before. We hope they are listening to us.
Maybe your policymakers, you know, I can't speak to your situation, but in Africa, if policymakers think you're trying to sell sort of a European model of general practice, they're not interested because of all this.
I think there is definitely a case for looking into implementing something like this in the Yemen. In fact, the next speaker, Professor Ali Batarfi, is quite heavily involved in the structure of training in Yemen, and this will be one of my questions to him. Another thing as well I wanted to ask you is, we had a number of questions about research-related kind of activities that Yemen doctors can get themselves involved. Knowing that you have a journal and you have those research networks, would their work be, possible to be, submitted to a journal and get that involved, maybe?
So, well, first of course, it is very important to have some research activity in the primary care space. So very much supportive of that. And actually, one of the things that's really worked locally for us is setting up a family physician research network, so that busy clinicians can participate in research without having to carry the whole academic load of it. I'm not sure what journals you have in your region. I'm sure there are family medicine journals in the region. The African Journal, unfortunately, of Primary Healthcare and Family Medicine, we do tend to nurture people submitting from Africa, and we don't tend to prioritize people submitting from other regions. But surely maybe you've got regional journals, and of course there are international journals as well that one can apply to. What have you guys got in your part of the world?
Well, to be honest with you, I'm sure there are Middle Eastern region.
Yes.
But I'm not aware of a Yemeni journal. I think we're very early on that journey, to be honest.
Right. There must also be, have you connected with WONCA, the World Organization of Family Doctors, in your region?
I think the connection is there, but I'm not sure if it's there in family medicine. So these are some of the questions which Professor Ali Batarfi will give us more insight, because he's been heavily involved with that. So more and more questions for,
yes.
And it flows in very nicely because he's the next speaker after the break. So we don't have to wait too long.
You're going to have to wait. Okay, you'll get the answers there. But I mean, one could also have a working party on primary care research globally. And yeah, so there would definitely be ways or avenues towards publishing if you had research that was being done in Yemen. Yeah.
Great, thanks. And one question, I think this question was asked earlier, but I think it's probably related. Is there a perception of family medicine doctor to be inferior to a tertiary or secondary care doctor?
Well, look, yeah, so that's an old chestnut, isn't it, as they say. It's a problem everywhere, that, I mean, even in the UK, which supposedly has the one of the best, general practice systems, there's still that perception, amongst some people. And I think it's kind of reflects the dominance really of tertiary hospitals and hospital-based specialists in our medical schools and in the health systems, So definitely in South Africa, yes, there would still be a perception amongst many, that, if you're going to really be successful, you should, become a cardiologist or a neurosurgeon or whatever it is, probably not a family physician. I mean, having said that, we also have people who are totally passionate about family medicine. We have people that are hugely committed to rural healthcare and to serving communities. And those are the people that tend to opt for family medicine. And having now this exposure at undergraduate level and internship level, people seeing what family medicine means, seeing family physicians, working with family physicians, we're getting a lot more interest in the discipline. But I think that sort of tension will always be there.
It seems to be universal. You're right.
Yes, universal. We'll have to live with it and sort of deal with it.
Thanks. A good question. I think you may have touched on this already. How do you maintain standards of care by family physicians? How do you how do you ensure continuing professional development?
Okay, so is the question, how do you ensure that family physicians have continuing professional development? Is that the question?
Yes, so maintaining standards of care by family physicians and ensuring they continue their professional development.
Okay, all right. So I'm going to take it almost as two questions, but to
I think
answer,
they are.
So in South Africa, the Health Professions Council have regulations about continuing professional development. So you are obligated to get, as in many countries, you're obligated to get a certain number of continuing education units every year in order to remain registered as a doctor. And so family physicians, along with every medical practitioner, are required to obtain those educational units. And of course, there are many different ways that you can do that. And in fact, the whole CPD sort of thing has shifted online, actually, and away from the traditional, CPD lecture and meeting. So a lot of people are doing short courses online and stuff related to journals online and so on. But in fact, the Health Professions Council are wanting to shift to a slightly more sort of educationally effective system of CPD. The old system is, I can go to a lecture and sit there and dream about the weekend for an hour and get a point, but I don't actually really learn anything. And then in the new system, it's going to be, I think you're going to have to be much more active in terms of defining your specific learning needs, maybe keeping a portfolio of learning, of how you have learned and addressed your learning needs. So it'll be a much more educationally engaged system. But at the moment, I think largely not very feasible to implement. So, but that's the direction they want to go in. So it's essentially mandated, and then people have to get a certain number of units. The first question to me, was that really saying, how do family physicians improve the quality of health services? Was that the question?
How do you maintain standards of care by family physicians?
Oh, okay, so it's more about how do family physicians maintain their standards. Yeah, so that's essentially how it happens in South Africa. And you have to get a certain number of ethics points, and that's because of our unethical history. So whatever else you do, every year you have to get a certain number of points in ethics and professionalism.
All right, and what does that involve, just out of curiosity?
Well, yeah, they're difficult to get. So you have to do a course or something where you would be looking at key ethical principles related to your practice. So you'd be looking at issues like consent or confidentiality, or like ethical issues. Right now, a typical theme would be around telemedicine, which has become quite a thing during COVID. And what are the ethical and professional issues there? But being conversant really in ethical principles and how they apply to your practice, so the typical things of autonomy and beneficence and non-maleficence and justice and legal issues, making sure that people understand them and apply them to their practice.
Does this apply to all doctors or just family medicine? All doctors. Okay. Yeah. Yeah.
Yeah.
I'm starting to get worried about family medicine doctors in South Africa.
No, they're not picking on us.
Okay, fair enough. Okay, cool. So yes, please keep questions coming to the chat, the Q&A box rather than the chat box.
Ache had a couple of questions as well. If you, I don't know.
Yeah, sure.
No more for me. I see he's still here.
Yeah.
Well, yeah, I think I answered them on the chat.
Oh, is it?
Yes.
Okay. All right. That was a good move.
They answered. All right. Thank you.
Okay. Right.
Excellent presentation, Bob.
Thanks, Ache. Thanks.
What's the difference between primary care facilities and community-based facilities? That's one of the questions.
Okay, so maybe I was a bit, maybe I confused people. So I was talking about community-based services. So in other words, these are services that are in the community, but they don't really have a facility. So for example, the community health worker would visit every household that she's responsible for and assess the health risks in that household. In fact, there's a form for that. And then would also be doing like health promotion and disease prevention work, potentially in sort of educational spaces like schools, workplaces, also potentially, as well as social spaces. They would also be running sometimes support groups, for people with chronic diseases. Actually, under COVID-19, one of the big things that they've done is they've delivered medication at home for all people with chronic conditions. So they don't have to come to the primary care facility and sort of crowd with other people and run the risk of infection. So they're offering services in the community, but they're not doing it from facilities. They're doing it in these spaces, homes, social, educational, and working spaces. And they link to the primary care facility. So the idea is that the community-based people and the facility-based people should work together as a team.
Just out of interest as well, is there any other country which adopts the South African model in family medicine?
You mean what I've just talked about, the kind of thing?
Yeah.
Brazil would be a very good example.
Okay.
And they call them family healthcare teams. And of course, at the moment, Brazil not doing quite so well. But if you look back at some of the literature on the sort of family healthcare team rollout in Brazil, it's had a huge impact on the health and health status of their communities. So that would be one really good example. I think Thailand also have got something similar. Yeah.
Great, thank you very much. Did you still wanted to ask questions?
Me?
Yeah.
No, I've got no more questions.
You've got no more questions. Because there's a question for Dr. Osman there. It said, you used the British system for training and exams. How did you adopt it to meet the needs for Ghana?
That's a good question.
Okay. I thought I'm done.
No, you're done.
Bob kept pulling me back.
Yeah. The longer you stay, the more questions you get. Yeah.
Now I'm interested in the next talk as well to know what's going on in Yemen. But I guess probably it's from our association with Britain for quite some time. But that has been a system even through the West African College and then gradually coming to Ghana. So we are used to maybe the British way of life. But I must say that with time, we're adopting other systems as well, especially with the association with the American system. So it was easy to identify with the British and their system of training. It wasn't a very sharp shift in paradigms. I mean, it was something that we're all used to. So that's what I'm saying. And quite a number of physicians have also trained in the UK, etc., before postgraduate programs started. So I would say it's a natural progression.
Can I also comment on this one? So
yes,
the Royal College of General Practitioners, of course, is an enormous entity in the UK, and we have worked with them in South Africa. But what we haven't done is we have not imported their exam or their sort of they have this MRCGP International, because we said it's not contextualized, it's not appropriate, not relevant to South Africa. What we did was we said, you guys are absolute world experts on assessment of family medicine and of training in family medicine. So they actually helped us tremendously to improve the standard of our national exit exam and to improve the training of clinical trainers in the workplace in South Africa. but we didn't sort of import the kind of the model of general practice and the exam that went with it.
Exactly. Yeah. Exactly.
It's nice. For tomorrow we have Dr. Crowley, Helen Crowley. She's from the Royal College of GPs,
yes.
so she will.
She'll have a, as you can see, I don't know what she's going to say. Yes, but yeah, let me say nothing more.
we'll hear more about that then. Out of interest as well, Dr. Osman, you said the first thing you established was a college.
Yes.
Now, that college, was that independent or was that government affiliated, or how was it at the beginning?
No, the Ghana College is an agency of the Ministry of Health. So it was actually established by the Ministry of Health by an act in the year 2003. So 2004, the various programs started, but it was not until 2005 that family medicine program began. So the Ghana College is an agency of the Ministry of Health, and that is why it is subvented. It gets some sort of sponsorship from the Ministry of Health too. Yeah.
Great, thank you very much. So really, for our colleagues in Yemen, if they want to follow suit, then they have to get government backing.
It's a lot easier if that way. But most of the time, you end up having the private practitioners advocating for this to start. If there's a college already in existence, then family medicine just becomes part of the college, becomes a faculty under the college. But if there's nothing at all, then it becomes quite challenging. I'm interested. I'll be waiting to listen to next speaker on what Yemen has done so far, and sort of hope, and I can make some notes.
Oh,
and also
amazing!
Yes.
Thank you very much. And just a word of time. Last question for Professor Marsh. This question is about integration of services. How do you integrate midwives, pharmacists, and nurses with family medicine clinics?
Okay, so so first of all, to say integration of primary care is really important, and it's something that we are also striving towards in South Africa. So integrating, HIV care with other chronic care, integrating, adult and child care, so that, all of this is available in one place, and not in vertical programs in different places. And so our sort of primary care team would typically really have a number of nurse practitioners. In large health centers would have maybe even 1 or 2 medical officers. Often, like we have community service medical officers in South Africa. They're obligated to do a year of community service. Interns, junior doctors, basically. Sometimes a few more senior ones, and then a family physician. In a large health center, that would be the typical primary care team. And of course, you would also have a pharmacist, you'd have a reception staff, you would have midwives if there was a midwife obstetric unit, and then you would have, of course, you'd have facility manager and all of those sort of people. And then often sort of slightly lower level people like health promotion officers, and so on. So it's can be quite a big team, but the heart of the clinical team would be nurse practitioners, medical officers, and hopefully a family physician, who, and you work together as a team, really, the nurse practitioners would see sort of the more straightforward, as it were, patients, and the medical officers and the family physician would see the more complicated patients, often also look after the emergency center if there is one. And the midwives, of course, would run the MOU with support from the family physician. Don't know whether that answers the question. It's not to say that there aren't issues of teamwork and sort of interprofessional relationships. Of course, there are.
Great, thank you very much. For some reason, I just lost
We
my
lost you.
ability to
We lost your video.
show me myself on the camera.
Yeah.
But I'm glad I still can hear you and can speak. Thank you very much. I think we have actually cleared all the questions, and it's perfect timing for our next break. We really appreciate you coming and give it an insight into the South African experience. I'm sure there are lots of lessons for us to learn. Thank you very much for your time. Thank you very much, everybody who stuck with us until now, and we hope to see you. The next talk will be in about half an hour time, and that would be Professor Ali Batarfi talking about the successes and challenges of family medicine in the Yemen. See you there, inshallah. Assalamu alaikum.
Hello. Hello. أتكلم على الصوت. هذا مبشر. Hello.
Yes, we can hear you.
Do you hear me, Dr. Mubashir?
No, it's Wahib. It's Wahib.
Wahib. Okay. Do you hear me, Wahib?
Yes, I can hear you.
Do you want me to start or still 3 minutes?
2 minutes. Let's give
2
it
minutes. Okay. Okay, good. Alhamdulillah.
Alhamdulillah. I can see that you were in work.
I think there was a technical problem in the name. I has used the name of the center. This is not the college, actually. This is the cardiac center, because we got a trouble in the college there, in the electricity and the net. So we changed to this place. They have a good facility here.
Yeah, but it's very good. We can see you clearly and we can hear you.
Alhamdulillah. Alhamdulillah.
Did you see any of the previous lectures? Did you?
I want just to share this the PowerPoint later on. I have few PowerPoints, not about 6, 8 PowerPoints.
Oh, good. I think there's lots of people who have lots of questions for you.
Okay. Most welcome.
No,
Are we ready? Are we ready to start, Wahib?
I'm ready.
Ready?
Okay, you take over now.
Okay. Right, so welcome back, everyone. My name is INTERYem. I am a pediatric nurse and currently involved in a number of healthcare forums for Yemen. Firstly, I'd like to thank all of those who have organised this exciting event, and most importantly, all the guest speakers who have given their time to participate in this conference that we are hoping will help us make a difference to the healthcare system in Yemen. It is my great pleasure to introduce Professor Ali Batrafi, who will be elaborating on the challenges and success of family medicine in Yemen. Professor Batrafi is not only a surgeon by training, but has become a fellow of the Iraqi Commissions for Medical Specializations in General Surgery in 1994. By understanding the value of medicine, family medicine, for strengthening the health systems, Professor Batrafi established the first postgraduate training program in family medicine in Yemen in 2010. Now I'm going to hand over to Professor Ali Al-Batrafi, and I'd like to say welcome and thank you very much once again for giving us your time.
Okay, can I start?
Yes, go ahead.
Assalamu alaikum. Good evening, good afternoon, according to local time for everybody. Well, first of all, I would like to thank all the organizer of this conference in family medicine. Actually, it is the first conference to touch this field. And I'm very happy that we have achieved at least one of our goals in HUCAM, that the spread and creating the awareness of this topic for the top management people in the country, and then especially in the Ministry of Health. So my talk will be about family medicine in Yemen, challenges and success. I'm going to talk about the history of establishing family medicine in Yemen, which was the first one, and then challenges facing family medicine practice. And lastly, I'm going to talk about our vision in HUCAM. By the way, HUCAM is Hadramaut University College of Medicine. So I'm going to talk about HUCAM vision of family medicine program. This is the campus of my college, which was opened in 2006. When we moved the first phase and second phase of medical students to this building, the Council of Trustee in Hadramaut University decides to evaluate this college, and they say, well, now we donate to them a new building. We want to see, are they on the right track or not? So they sent a group of consultants from Kingdom of Saudi Arabia and Bahrain. And among these consultants, actually, there were two famous family medicine in GCC. Dr. Nabil Al-Qarashi from Saudi Arabia, he's a very famous family medicine in GCC countries. And Dr. Faisal Nasser, also a famous family medicine physician from Bahrain. So they were among the group who came to evaluate HUCAM. And in the discussion with this group in different disciplines, Dr. Nabil suggested to us, he said, Dr. Ali, why not to focus on family medicine and to start these important neglected topics in Faculty of Medicines? Our answer was logic that we haven't cadres and staff in this specialty. So I said that just at least create a state of awareness, Dr. Ali, about this, and do whatever you can do, but put it in your mind. Well, we said, okay, we will do. And the first step, it was that we agreed with Dr. Abdullah bin Ghoth. He was the head of the community medicine department. We said, let us start at least by changing the name of the community medicine department into community medicine, into family and community medicine department. And this was the first step in our long journey. So we established at least the name that this is no more community medicine department, it is now family and community medicine department. In 2010, there was a Dutch project supporting HUCAM through NOFIC organization in Holland. And there was a collaboration between us and Maastricht University. And then I was on a visit to Maastricht University. Then I discussed with the Dutch people that one of our objective is to establish a postgraduate program in family medicine, and we want a help from medical college in Arab countries. And we found that Suez Canal was the nearest to us. And there was actually a link between us and Suez Canal and cooperation regarding problem-based learning in the program, the BBL. So they agreed. Listen, they gave me the green light to go to Egypt and to discuss the issue. I went there and I met, that was in February 2010, and I met Professor Majid Khattab. He's also a famous family medicine in Egypt. And we agreed that he should come to Mukalla, Yukam, and pay a visit to make situation analysis. He came in and stayed for about 3 weeks or 2 weeks in a discovery visit to analyze the situation. Are we ready to start such a program without having a local cadre in Mukalla? So we make a systematic studies. He did visits to different health centers, belonging, of course, to the Ministry of Health, did different meetings with key persons in authority of health in the college, in the university. And finally, we agreed that we have to conduct a workshop, and that was in 5th of April 2010, to answer the big question: are we ready to start a first medicine program in Yemen? It was a challenge, of course. This workshop, first workshop, was attended by the rector of the university, Professor Abdurrahman Bamatraf, by Professor Majid Khattab himself as a consultant, as an expert in this workshop, and Professor Ghanim Sheikh, the founding dean of UCAM and WHO expert. The discussion was continued for about 3 days, attended by, as I said, key figures in key Office of Ministry of Health, College of Medicine, Community, Family and Community Medicine Department, people from NGOs, and the decision was taken that now the college can start a program of family medicine within 6 months from now, provided that the needs to start with this program should be fulfilled. Actually, there was a high commitment from the rector of university and from the college itself. At that time, I was a vice dean. I was not the dean. So we sent, between April and October, we sent a staff to Suez Canal to have a discovery visit and to see the experience of Suez Canal University in family medicine, and to arrange for a collaboration, official collaboration in this field, and to finalize also the content of the program. And that happened actually. As I said, the agreement was to have 6 months from April to October to prepare everything and then to announce the starting of this program. And that happened. And bifadlillah, alhamdulillah, in October 2010, we start the first accepting enrolled, the first batch. In this program, there were 11 candidates. And we start the first batch. It was really a challenge, but we accept this challenge. And as I said, there was a commitment from all the staff in the community medicine and family medicine and community medicine department. And I think the electricity is off. Do you hear me?
Yes, we can hear you.
You hear me? Okay, because
We can hear you, yes.
they have automatic change of electricity. Good.
No problem.
So I can continue, huh?
Yes.
Okay. Okay. So, as I said, there was a commitment actually from the Department of Family and Community Medicine, from the deanship of the college, from the university, and from our colleagues in Suez Canal University. So, as I said, the first workshop in April 2010 was conducted by the expert Professor Majid Khattab, head of Department of Family Medicine in Suez Canal. And then in January 2011, second workshop started also to discuss the concept of family medicine and its application in Mukalla. We involved the people in the health centers, primary healthcare centers, coast of Hadramaut, and the NGOs. We decided to involve people in planning so that they can help us in implementation. And this is well known that if you involve people in planning, they will help you in implementation. And this workshop actually was conducted by an expert, Musleh Ismail, who is going to talk after me in this conference. I'm very happy that to have Dr. Musleh with us in this conference regarding family medicine in Yemen. So he was the expert at that time in this workshop. And then we continue, of course, in implementing this program with great help actually from Suez Canal University and their staff. Professor Majid Khattab, Professor Musleh Ismail, Professor Abdul Majid, Dr. Rida, and others. Then actually there was something, at that time we considered it as a change actually. We were very happy. There was an invitation to us. You come? I became already a dean, and then so the Minister of Health called us and said that you have to send experts from or staff from your college, you come to Sana'a to train physicians in Sana'a about family medicine concepts and to start this important specialty in Yemen. We were very happy. We said, okay, now we will reach to a state in which we can spread and disseminate the concept of family medicine, not only in Hadramaut Governorate or in Mukalla city, but since the top management of Ministry of Health are in charge of this and they asked for this, so we thought at that time that the road will open to us and everything will be fantastic. 3 months after this, in March 2014, sorry, not 13, 14, 2014 March, second training workshops in Sana'a, done also by staff from our college to train physicians in a center called Abdul Moni, I think. I'm not sure for the name. I think Abdul Moni health centers. To start having family files, referral systems, communication skills, everything regarding family medicine. But unfortunately, what's next? Since that time, the Ministry of Health and the top management people, they didn't contact us. Although we sent messages to them that we are ready to help people in all Yemen to start this important specialty, neglected specialty actually, in Faculty of Medicines. In every meeting, in every conference, we try to spread the idea of why not to start family medicine department in the college, at least as a joining specialty with community medicine department, which has existed in most of the colleges. So why not to add, at least as we started, the name, and then step by step, you can focus on family medicine. But unfortunately, we didn't have a good response. And what makes us very sad that even the Ministry of Health, when they thought to start the fellowship, which is one of our future vision, to make an RTP program, residency training program in family medicine, they didn't talk with us. They didn't even ask us, what do you think? It's essential to start this, or what do we need to start? Or At least to have sharing. Sharing is caring, as they said. If they share, they care. But unfortunately, nobody asked us. And I don't know what's their opinion at that time. And it's still the same people who are in charge of family medicine now. Our colleague, Dr. Amatul Latif Abu Talib, I think she has a talk also in the conference regarding family medicine experience in Sana'a. But we feel very sorry that they didn't contact us. I don't know. Although we told them from the start that we don't want to take the flag, just we want to help. We have a commitment regarding the health of our people in Yemen. I'm a surgeon, my background is a surgeon, but I do believe in the comprehensive concept of health. Health is not the absence of disease. It is a state of well-being, physically, socially, psychologically. I do believe in this. So we think, actually we are sure that this is what everybody knows, that the base of the health of pyramids is the family medicine practice. A lot of money is spent for the tertiary care. I'm not saying it is wrong. This is okay. By the way, I was practicing even open heart surgery. I trained in cardiac surgery in Iraq and Saudi Arabia. But this is issue, but taking care of health as a concept, regarding of your specialty, is the important thing. And we told the Ministry of Health, please, we want to help you to implement these programs at least in Sana'a as a capital, in Aden as a second capital, and in all governorates where there is a college of medicine. It's not difficult. I know that there is a shortage of budget, there's lacks of resources financially, but I don't think our problem in Yemen is the lack of financial resources. We lack coordination. We lack cooperation. We lack working in a team. Everybody wants to work alone. And this actually made us sad that the body which should be responsible about family medicine in Yemen, which is the Ministry of Health, is not taking care. Just show business. They call us in December 2013, and then in March 2014, and that's it, finish the story. And I don't think, I'm not sure, maybe 3 or 4 years, they announced that they want to open a fellowship board in family medicine, but they didn't succeed. And they will not succeed if they think with this mentality. So I'm saying that challenges facing family medicine practice in Yemen, in my opinion, it's first of all, it's one challenge. Main challenge, I would say, is the commitment of the top management people in Ministry of Public Health. If there is a commitment, if there is a will, there is a way. If there is a commitment regarding family medicine practice, definitely we will succeed. We are ready in HUCAM to share with anybody, call any college of medicine in Yemen, with our simple experience. How can they start a family medicine program to provide the offices of Ministry of Health in different governorates with the cadres, with the doctors? You know that one of the challenges also is lack of doctors, shortage of doctors. Till now, we have 47 graduates in this program. The good thing is that out of these 47, 4 left Yemen, 2 for postgraduate studies, 1 in Malaysia, 1 in Egypt, and 2 they went to neighboring countries to work. That's a good thing. Only we missed 4. And 2, actually, they go for further study. So the retaining of this doctor, we have to encourage them. So this challenge can be overcome by the help from the College of Medicine in Yemen to open such a program to provide the Ministry of Health with the efficient doctors and family physicians. But the main challenge, in my opinion, the main challenge is the commitment of the top management people in Ministry of Public Health. Let us talk frankly. They are not convinced. And if they are convinced, well, they don't care. What can I say? They are not oriented, okay. We did our best to orient them, to explain everything. But when they become oriented, they don't implement. Either because they are not convinced or they don't care. For the ball is in the Ministry of Public Health. We will provide, as a college, as an educational institute, we will provide the Ministry of Health with the cadre, with the doctors. We will train them, we will update them. But the system, the health system who will use them, he should prove that he cares about them. Needs of family medicine practice. They have to take care about the infrastructure of the primary healthcare centers. Buildings are not suitable, no enough clinics, not well furnitures, equipped, medical instruments, essential for this. There are no referral system. There are no practicing of file family, which is essential for family medicine. Professor Masleh Ismail, when he came to train our candidates in Hadramaut, he used to use this word. He said, the surgeon has the knife. The family medicine have the family file as a knife. See the comparison. It's the knife and the surgeon, and we know that. Sorry for this. I am a surgeon, so they said, surgeon said always, knife is better than wife. So here is the comparison, means the file, family of file is very important. No awareness or care about the people who are in charge of these health centers or in the main office of the health services in the government. There is no system of quality assurance. No support, even from the Ministry of Civil regarding their cadre, regarding the payment. They are underestimating them. So how can we want them to work in an environment which is not fit? They are digging in the stones. I made it simple. I will not call it a questionnaire, just a simple questions. The question was, are you satisfied that you are practicing family medicine? 94% answered no. Only 4% answered yes. More than 90%, 94%. And almost the same problems from all of them, that there is no commitment from the people in the health offices. Nobody is taking care. No encouragement to work in this specialty. Simple things. Sometimes you don't need money. You need just an organization. No organization, no system, no file family. So actually, family doctors in Mukalla at least, they are disappointed. We have a chance to change. And I always say to our candidate that, please, I want you to be changer. Not only just an addition to what a number of doctors present. You have to be changing agent to the health system. In the College of Medicine, it will, if just will provide the community and the health system with doctors without interfering in changing the health system, I don't think this is a correct strategy. We're a community-based school. This is our philosophy at community-oriented medical school. And that's what actually made Dr. Nabil Qureshi in 2006 to say to us, if you are a community-based medical school, community-oriented, why not to adopt family medicine? And he was right in his thinking. For this, as a community-based medical school, as a community-oriented medical school, we think we have to change the health system positively. We have at least to share them in providing the adequate health services to people, to equity health services, accessible to poor people, quality, proper utilization of resource. All these things in social accountability should be taken into consideration. Actually, when we talk about health system in general, we feel very sorry. When you talk about family medicine as one of the solutions to improve at least our health systems, we have to adopt a cost-effective strategy. I don't know. The thinking of the people in the Ministry of Health, I don't know, His Excellency, the new Minister, Dr. Basim, I hope that he will listen to what I'm saying now, that there should be a clear, policymaker should be clear in this, and there should be a commitment from them regarding adopting a family medicine program and practice. Actually, UCAM has a vision. When we establish the program and we start to accept the first batch in 2010 October, as I said, the vision was like this, the future business plan. In the five years from 2010 to 2015 is to disseminate the culture of family medicine and building up the capacity of doctors at the institution regarding this. And the second five, from 2016 to 2020, which is now finished, is to implement a health system based on family medicine practice and improvement of the master program to an RTP program, fellowship program. Actually, last March, exactly 1 year from now, I met Dr. Ahmed Al-Mandari, who is the regional director of EMRO. And by the way, he's a family medicine specialist, consultant. And I told him about the story of family medicine in Yemen. And I asked his help to extend the program and to upgrade it into a fellowship. He agreed, and he did a letter for me to our colleagues in Oman. He said there is a good experience of family medicine in Oman, but I don't know, because of the political situation maybe, and Corona, there was no positive response, but still we are fighting to start or to upgrade the program from master program to fellowship program. And unfortunately, if we continue in this trend and this directions without response from the Ministry of Health, at least when they will reach to a conclusion that maybe it is useless. I don't want to use this word, but unfortunately. Anyhow, as I said, I'm not a family physician, specialist, surgeon by background, medical education expert, but I do believe really that to improve the health situation of people, to improve the health system, we haven't other option than depending on the family medicine practice as a base of health pyramid. And then, of course, we need a tertiary care, we need a secondary care, all this. Don't say that we don't depend on it or we don't care about it, but at least the priority for a poor country like us is to utilize our resources in a proper way. Thank you. Okay.
I think Intanya maybe.
Hear me?
Hi, sorry. Is everything okay?
Do you hear me, Noor?
Yes, I can hear you. I can hear you now. Sorry.
I left a space for if there is questions or discussions.
Yes. We have one question at the moment, but before I go on to the questions, I just wanted to kindly remind yourself and everybody else that despite the challenges, we'd like to remind everyone that politics is beyond the scope of this conference, and hopefully that we will just be able to continue just answering all the relevant questions. Our next question is, considering the challenges in implementing family medicine in Yemen, how can the mentioned challenges be overcome, and how confident are you in bringing the government on board with such programs and policies?
I didn't hear the question, but if I am right, I understand that how can we implement the program with the government and the board?
Yes.
As I said, Dr. Ahmed Al-Mandari, the regional director of EMRO, he promised it, and I think he will keep his promise. He said he will help us in opening this program. And the problem is that whenever you talk to responsible people in Yemen and they say, oh, we have no shortage of money, we have no budget, we can't, establish new things. I told them, this is not a new thing, actually. It's an old thing requested by our needs for the health system to work in a proper way. If the people will think that don't open new projects, don't open new programs, you haven't budget, you haven't money, this is incorrect thinking. This is an essential thing. It should have the priority. That's my answer, if I understand the question correctly.
Yes. Our next question is, how can Yemen attract more trainees to family medicine?
Pardon?
How can Yemen attract more trainees to family medicine?
Well, attract them if they see their colleagues who graduated are practicing it in a proper way. If they see the positive impact of their colleagues in the community and positive impact on the health system, definitely they will come.
Okay. And what is the way forward if government support was never available?
We have to depend on ourselves. I think we have no other option than this. We have to depend on our services and the local community. As I said, now in our 10 years since we start our program in 2010, and we tried to discuss this issue with other colleagues in colleges of medicine, but I don't know, they are not satisfied, or I don't know what's the justification. But I don't blame them. I blame mainly the Ministry of Health. Ministry of Health, whether in South or North, as you said, we are not talking about politics, we are talking about Yemen. They have to take care about adopting this strategy for the health system to build it in an effective way to help people.
All right. Is there a college or university in Yemen that accredit family medicine training?
That's family medicine training?
Yes.
Actually, till now, the body of accreditation is not practicing its work in a proper way. Imagine that. Our college, HUCAM, in 2013, now 7 years, in 2013, we submit our self-study, SAS, self-assessment study, and we invite the body of accreditation and quality assurance to come to us to make the judgment. They didn't did it. They said, still, we are not ready. And first of all, they said, oh, it needs a financial budget, and expert from outside will cost $20,000. We haven't money. Are you ready to pay? At that time, by chance, I asked the Dutch people who are supporting us. I said to them, the body of accreditation and quality assurance in Sana'a, they said the cost may reach up to $20,000. Are you ready to pay? They said, yes, we are ready to pay. And I write an official letter to them that, okay, send your reviewers and come to us. We are ready to pay the ticket, the accommodation, everything, fees for this. but it's not our fault not to be accredited because nobody is doing this.
Okay. So our next question is, how can family doctors counter misinformation from patients regarding family medicine, and also about wiring ideas such as about COVID?
Actually, one of the things that should be actually done is that we have to create a good awareness about this specialty among community also. Still, people, sick patients are not digesting the concept of family medicine. And as you said, as you know, that 90% of the cases can be treated out of the hospitals. So in the family medicine clinics, they can treat hypertension, diabetic, asthma, all these diseases, chronic disease, can be managed at a level of primary healthcare centers and this. But I do admit that still there is maybe some of defect from our side that we didn't create a good awareness among people, and not only people actually, among even healthcare providers in the Ministry of Health or in some offices. But it is a challenge, as I said. We have to fight, no other way that. We have to fight in the academical front, we have to fight in the services front, and we have to fight not for fight, we have to fight for help of people. We want people to digest that. We are not asking something in the moon. We are asking simple things. Just please apply practice of family medicine in primary healthcare center because we are a poor country. By this, we can save a lot of money. We can improve the health of the people. And then gradually open a center for transplant of the heart, for transplant of the liver, whatever you want. But at least start with simple things.
Okay, thank you very much, Ali. Next question is, how are different universities acting together to improve family medicine training and practice in Yemen?
Actually, if in general, we have a good cooperation with the University of Suez Canal, and Dr. Muslah is going to talk after me in this conference. They helped us a lot, actually. They support us, actually. And even the discussion of the master degree, they came to attend it in the beginning of the program. But if you talk about the cooperation between Yemen University, unfortunately, I don't know what's their excuse. And but we have to admit that we failed in convincing them to start with this. Is this a mistake from our side, mistake from their side? I don't know. But what makes me sad is that till now, 10 years now since we started, and no university in Yemen just thinks even to start family medicine or asking us for help in establishing the program. As I said, just the Ministry of Health in 2013, they asked us for a workshop, and then in March 2014, and that's it. After this, nobody opened.
Sorry, Professor Ali, do you have currently have any international collaboration in family medicine? And if so, how much value has that added? Have you had any?
We have international cooperation with Master of the University, which continued for about 8 years. It's a long time actually, but now because of the conflict in Yemen and the situation, all this unfortunately stopped. But the cooperation is internationally, regionally at least, with Suez Canal, and internationally with the Master of the University.
And is the family medicine in Sana'a different to that in Hadramaut, if you know?
I don't think there is a family medicine in Sana'a. This is my opinion.
No.
Because we didn't continue to complete the training. They thought actually in opening a board or fellowship, but they didn't start. But I don't know, Dr. Ahmed Al-Latif is going to talk about, maybe after 2 hours or something, about family medicine experience in Sana'a. You can listen to her, but to my knowledge extent, I don't know if there is practice, but I doubt if they are practicing family medicine proper.
Okay. And how is family medicine incorporated in undergraduate curriculums at the moment?
Pardon?
How is family medicine incorporated in undergraduate curriculums at the moment?
Family medicine, actually, we have an undergraduate course in the 6th year. Now it's in the 5th year. The undergraduate student is having lectures, practical sessions in family medicine, and it is an independent course. And the postgraduate course. The undergraduate actually started earlier. After the visit of the group, the consultant in 2006, we started it from 2007. We changed the name, actually. It was a primary healthcare course block. And then we make modification on this block of primary healthcare, and we change it into a family medicine block. And still now it is an independent block taught for the undergraduate schools, of course, in addition to the master program of family medicine.
One important question is, Dr. Ali, how can organisations such as INTERYem help establish a strong family medicine programme in Yemen?
Well, I will come back to my challenge in the slide. Commitment. If there is a commitment from, at least from our side, university, college, we think that we are committed. Still, we are fighting and maintaining the program, although all the difficulties, all the shortages, the impact of the conflict, but we're still maintaining the program. And we received it, by the way, before 4 months, we received the 6th batch. There are about 10 candidates. As I said, till now we graduated 47, and now we accept on November, we accept 10 new candidates in their 6th batch. But the ball is in the side of the Ministry of Health. They are the consumer of our graduates. We are the factory who will produce. The doctors, they will consume this. And if there is a will, there is a way. If the Minister of Health, top management people, convince it about the strategy of adopting a family medicine, I think the solution is easy, just a commitment.
Okay, and how did you adapt the SUS university curriculum to meet the needs for Yemen?
Well, Arab countries is similar to each other in their culture. So I don't think there is a big difference, but of course, when we took the curriculum in 2010, as I said, from April 2010 to October 2010, there was a discussion at the curriculum committee reviewer, and we add to it from the benchmark of the reference, not only Suez Canal. We take the British system, the Canada system, the Saudi board, family physician, Bahrain. So it is from different countries, actually, not only Suez Canal. But the main core of the curriculum was the Suez Canal.
Okay. Is there any data from Yemen to show that family medicine is needed in Yemen, or any research that you're aware of?
The practice is enough as an evidence. I don't think people will disagree about the importance of primary health care and practicing family medicine in centers. This is without research, in my opinion, without research. It's empirical evidence, daily life.
Okay. What can you do to make family medicine more attractive for doctors to enter the training, from your experience?
To prove to that after their graduation, they are going to practice family medicine in their future careers, and they will have a positive impact on health of the people.
Okay. And how do we raise awareness of decision makers and academic personnel and community regarding family medicine? How do we convince them?
I think community or NGOs in general, whenever they will see something which is positive toward the health of the people, something which is good for them, they will not object. Just you want to make things simple to them. as I said, KISS strategy. Keep it simple, straightforward. If you adopt a KISS strategy by explaining to them the importance of this, the cost effective of this, and the priority, this is what people in Yemen needed. Maybe in other countries, although still I think family medicine in poor or in developed countries, it's the pyramid of or the base of the health pyramid, regardless of the country, whether it is poor or rich. But at least for us as a poor country, we have to adopt systems, strategies that is relevant to our situation, simply. I don't make copy and paste of experiences of family medicine from X country or that country. But at least what makes me sometimes think that what's wrong? Things is very clear. Why people don't want to apply family practice medicine in the health sectors, in the health system? Why? I don't know. I have no explanation other than top management people, either they are not convinced or they don't care. That's it. I have no other or third options for this.
And I think we've got a last question, which is why do you think Hadramaut Hukam is leading the way in family medicine in Yemen?
Because they have commitment. Because they have commitment. And the philosophy of the college from the start, from 1997, the college was started in 1997, September. The founding dean was Dr. Ghanim Sheikh. He stayed in WHO for about 10 years as a human resources advisor. From that time, we started a philosophy of and strategy of community-based education, community-oriented medical education. This facilitates our work to adapt family medicine as a part of the community-based education. And the strong relation between primary healthcare and family medicine. It's a matter of background and philosophy.
I'm not sure if anybody has any more questions. I can't see any more. Dr. Wahib, do you have any other questions or?
No, thank you very much, Professor Batarfi. I was very interesting insight into what's happening in Yemen in terms of family medicine training. There's a lot of things that will be beyond the scope of this conference. For example, we can't influence what's happening in the political arena. We don't have political affiliations, but we have lots of skilled, experienced people from all over the world. In case if there is anything you think we can help with to maybe either keep going with the independent Hadramaut training program, or maybe establish something more inclusive. What do you think?
Well, I think, as you said, we are out of the political arena and we are discussing here scientific things and we share thoughts and ideas. But at least if we succeed in conveying messages, it's a peaceful message for the top management in our, especially Ministry of Health, whether in the south or north, that please try to discuss the situation and to make priority. Is the priority to build a tertiary hospital or to reinforce primary healthcare services and family medicine, for example? So prioritization of issues and of topics is an important thing. And of course, I may be right in the thing and you are wrong in one side or aspect of this issue. The other way around is correct also. Maybe I am the right or you are the wrong. Anyhow, the message which I want to convey is that let us have a dialogue and discussions and open-minded mentality to share. Also share, they said sharing is caring. If you share with me, you care. Please for His Excellency, the Minister of Health, try to think and what are the factors that may, I will not say family medicine, I will say improving the health system practice in Yemen.
Thank you very much. We have listened to speakers from Australia, from Africa, examples from Africa, examples from Brazil, Cuba, and family medicine. You know, I'm a surgeon like yourself. Family medicine, although very junior, not a professor, family medicine has shown to improve all rate mortality, natal mortality, lots of stuff which is kind of high impact, very important for the general population health, a very effective measure, even from public health point of view. I mean, we're very happy to, the message has been clear from previous speakers that, the evidence is there to show family medicine does make a difference. We're very happy to support any awareness raising or, forward any evidence. At the end of the day, we recognize one of our aims is to help improve the health provisions for the Yemeni patient, and this is one of them. So we're very happy to support anything you think we may be able to do.
See, the title of the lecture was Challenges and Success in Yemen. And I'm since 12 o'clock mid-afternoon in a challenge to maintain the electricity and net to participate in this conference. Do you believe this?
Yes.
Now I'm talking to you from the cardiac center and not from the College of Medicine or from the university, because problem of electricity at night. And thanks for people in the cardiac center in Mukalla that they gave me the chance to come to their center and to participate. This is a big challenge to us, but at least there is actually a poetry from Yemen. Of course, you speak Arabic. عبد العزيز مقال حسد سنظل نحفر في الجدار إما فتحنا ثغرة للنور أو متنا على وجه الجدار. This is our logo. Please translate it to your colleagues there in the conference.
Jan will translate. This is better than me, I think.
So, if any question,
maybe then you will continue digging the wall.
I want to say one thing. I want to say that if you are convinced in an issue and believe in it, you can fight for it. My background is surgery. I'm not a family physician, but I do believe that a family physician, a family medicine, practice is essential. I can say to the people, go and be a surgeon in, for example, maxillary artery here, in facial maxillary, only in the maxillary artery specialized. But please practice primary health care. Why not to educate people in rural country that when they have cut wound, for example, to clean it, to make first aid and to clean this hand, to suture it. Otherwise, if you lift it, it will be infection, hand abscess. Then this hand abscess needs an incision and drainage under general anesthesia. So you have to shift him to a tertiary care or a secondary care. But if you clean this cut wound in the hand from the start, you make good dressing, you suture it in a proper way, you save people and you don't need to go to the tertiary. For being a surgeon or a gynecologist or an ophthalmologist is your all right. Nobody is against this. But please, this is a message to all specialty. You have to practice the preventive aspect of your specialty. That's it. Not only the curative aspect, and you neglect the and rehabilitate. That's all the struggle, which is always, I don't know, doctors, how they are thinking. I can give a lecture about cardiac surgery, but if I explain to them that the importance of prevention of rheumatic fever and taking preventive aspect, the student will like this and will practice it. I think one of the underestimating of primary healthcare and community medicine is the specialists themselves. They are not defending their specialty. They are not fighting to explain that.
Okay. Thank you, Professor Ali Patwari, for an insightful talk. We really appreciate you giving us your time today, and I think everyone has enjoyed it very much. So thank you again from everyone.
Thank you.
Next we have, firstly, I'd like to send apologies on behalf of Professor Mohsen Ismail, who couldn't attend this afternoon, but however, his colleague will be talking on his behalf. So I'd like to kindly introduce Professor Mansouri Fawaz Salim, who will be discussing and elaborating on family medicine in Yemen, thoughts for Yemen. Professor Mansouri Fawaz Salim is a professor of family medicine at Suez Canal University, Egypt, and also a professor in family medicine, College of Medicine in Qatar University. Also a former professor of family medicine in clinical medicine in Qatar, and also former primary program director at family medicine at the Department of Health in Qatar as well. So I'd like to hand it over to Professor Mansoura Fawaz Salim. Welcome and thank you for giving us your time today.
Assalamu alaikum wa rahmatullahi wa barakatuh. Do you hear me? Yeah, I'm so happy and delighted and actually lucky to get this chance to be with you today to give this talk on behalf of Professor Mohsen Ismail, who is the head of Family Medicine Department, Suez Canal University, head of Scientific Council of Egyptian Family Medicine Fellowship, and vice chair of Training Committee in Arab Board of Family Medicine. Actually, we are looking, inshallah, soon to get Yemen back happy. And as we consider Yemen for us is the origin of Arab and origin of the real civilization. To have a good future of family medicine, actually we need to rely mainly in family medicine. And luckily, that's the theme of the WONCA day this year on 12 March 2020 was building the future with family doctor. Outline for our presentation today to be sharing vision about primary healthcare, family medicine, GB, setting the scene of health sector in Yemen, role played by primary healthcare physician in Yemen, how to prepare 5-star doctor, and futuristic view for happy Yemen. Actually, today in early morning, we 2 to 3 of our respected speakers talked about primary health care and about the changes happened before 1978. But here I will just only focus on small things just to find and to show that there is big changes before 1978, as there was lack of health services in some areas, duplication and inaccessibility in others, which ended, of course, by dissatisfaction with the existing health services. And in 1977, WHO Assembly agreed upon health for all by year of 2000. And after that, in Al-Ma'ata conference, the famous conference that made big changes in primary health care, accepting the WHO slogan of health for all by 2000, and adopting primary health approach to achieve health for all. Primary health care principles and elements have been defined clearly at the time. And after Al-Ma'ata conference at 1978, after 1978, other principles and elements were added to primary health care, and multiple revision and recommendation of Al-Ma'ata conference, moving from to health service reforming and reforming also in medical education to achieve health for all by Al-Ma'ata, and Millennium Development Goals up to 2015, and Sustainable Development Goals after, and Universal Health Care. The Global Conference in Primary Health Care, also in Astana, Kazakhstan, at 2018, emphasized on the role of primary health care approach to achieve universal health care. Primary health care, it is essential health care made accessible to the individual and community through their full involvement and participation as the cost that the country and the individual can offer, with method that is scientifically evidence-based, sound, and socially acceptable. Actually, our circumstances in primary medicine, in family medicine, that the situation is unique, as the family physician need to know and to deal with the public sector, with the folklore and folk sector and professional sector. And the patient we usually saw came for us with undifferentiated clinical uncertainty. As we can see, patient with body ache and after 3 days develop rash and measles and etc. And they came for us earlier or late. What we call sometimes till now, unfortunately, we saw the patient by the radar syndrome. The radar syndrome is reactive responding mainly when the person is sick. Unfortunately, the patient appears, the patient is treated, finding the problem, the medical problem, treating it, and the patient then disappear from our screen. Despite family medicine, the true and real family medicine supposed to provide the full care from promotion, prevention, and the treatment for acute, which the radar system represent only 25% from the service that provided by family medicine. And we can call it the iceberg phenomena that family medicine and primary care usually, and primary care and secondary and tertiary care only provide 20% of the medical services needed for the community. And the rest, and the vast majority is 80%, they rely on themselves or come late to us, they rely on CAM, complementary and alternative medicine, over the counter. And when they come late, actually the cost and the risk and the hazards is more duplicated. In 2016, there is also a recommendation from WHO to consider that the primary health care is the main service that can provide care, and the main core for it is the primary care physician. Of course, when we'd like to talk about family medicine, we cannot forget Professor McQueenie, which is the father of family medicine, and he is born at 11th October 1926 in UK, and passed away, died on 28 September 2012 in Canada. He has multiple publications in family medicine. And he's described family medicine within the context of family medicine principles. He addressed the principles that govern the action of family physician. Actually, he defined 9 principles of family medicine: an open-ended commitment of patient, an understanding of the context of illness, the use of all visits for preventive purpose, the view of practice as population at risk, the use of community-wide network of support, the sharing with patients of the same habitat, the care of patient in office, home, and hospital, recognition of subjective aspects of medicine, awareness of the need to manage the resources. The principles related to care itself: access to cost-effective care, of course, continuity care, comprehensive personalized care, considering the biopsychosocial approach when we are dealing with patient, team-based care, patient self-empowerment, and encouraging for patient autonomy and to share in his plan of management, family-oriented care, community-oriented care, coordinated care, evidence-based care, and preventive focus care. Principles related to family physician caring attitude, of course, communication and counseling skills, clinical competency, CPD, and continuous professional development all the time. So nowadays, principles of what primary health care are embedded in principles of family medicine. This is very famous lecture. We call it "How Many Faces?" just only to remind ourselves about the principles of family medicine. Some people saw less than 10 and others see more than 10. Let's see. The key is here is that the integration and amalgamation of principles is important in family medicine. One of them is not enough. We need to have all together. Most specialties define themselves by exclusion, such as we call age, gender, body organ, system, but in family medicine doesn't limit itself. It is a specialty of inclusion. The focus in family medicine is on the patient and not only the disease. This is my favorite city and also the favorite city for Professor Mosleh, city which is located in the northeastern of Egypt, called City of Beauty. It's famous by Greenland and Suez Canal. And actually, it has Faculty of Medicine, Suez Canal University, which I'm honored to be a graduate from it. And it's considered the pioneer faculty in the Middle East, which is oriented in family medicine, and hundreds graduated from it. And actually, many of them in the Gulf area, in the Middle East, initiating many programs of family medicine. So, setting the scene in Yemen, to just setting the scene, we would like to know, do rapid SWOT analysis for the current situation in Yemen. And the source that I got the data from it is the WHO indices. Here, we can say that population living in urban area, around 35% from Yemeni population lived in urban area. And primary healthcare facilities per 10,000 population is 1.7. Actually, it's not bad, but we don't know the component of this structure, meaning manpower, in addition to the manpower and the material and methods inside it. But as facilities, the number is not bad by WHO. The density of physician per 10,000 population, actually the problem is here, that the manpower here and the physician is so deficient. Only we have 4 physicians per 10,000 population, which is, we cannot compare it even by the minimum. The minimum is around 45 physicians per 10,000. Again, the manpower here is the problem in Yemen, including nurses and midwife. As we can see, that only 10 nurses per 10,000. And the minimum is 45 too. Proportional population living below the international poverty line is, we can say, almost half of the population. Their income is less than 1.9 per day, according to WHO, from 2014 to 2018. Universal healthcare services coverage also same, almost 47% of the population received that. Antenatal care coverage, where we can say that the client or the pregnant received 4 visits or more, we can see that 30% only of pregnant ladies receive this care properly. And maternal and mortality, of course, here is the outcome. We can say that 190 Yemeni passed away because of pregnancy or labor. And this is statistics came from 2017. Mortality among children less than 5, we can see that it's 60. And the neonatal mortality around 27. Infant mortality rate around 45. Age standardized mortality rate of communicable disease, we can say, see that it's around, for non-communicable disease, around 900, and for communicable disease, around 180. And here, probability of dying from any cardiovascular disease, cancer, diabetes, or chronic respiratory disease between the exact age 30 and 70 by gender 2016, it's around 34 for male and 27 per female. Prevalence of wasting in Yemen and stunted in children under age of 5 by percentage for both gender, we can see that it's around 18 per wasting, and unfortunately stunting, I didn't find it clearly. So, setting the scene in Yemen, who will be the catalytic to improve the current situation in Yemen, of course, is the primary care physician. And not only normal family physician, we need 5-star doctor and researcher. 5-star doctor was described by Charles as a model physician for today's society, then by WHO, adopted by WHO 2000. He would respond to a real need of both the individual and patient and the surrounding community. Who will be care provider, communicator, educator, for his practice population and also for his team and for his student and for the junior students. Decision maker, of course, appropriate use of clinical reasoning style, evidence-based decision making, and community leader. So the current situation in Yemen, as Dr. Ali said, that the only medical school offering residency program in family medicine is Faculty of Medicine in Hadramaut University. The total number of certified family physicians, and correct me, this is the data that I can go, that it's around 47 family physicians graduated from Faculty of Medicine in Hadramaut. There is no existing active program of National Fellowship of Family Medicine in Yemen at that moment. There is no existing active program of Arab board in family medicine. So how can we bridging the gap? Futuristic view for happy Yemen. It's not too late to start. From the SWOT analysis, we need to put the plan. The plan, of course, we will not wait till have graduate after 10 years. So we need short-term strategy, which including a training of young primary healthcare physician, which we call it crash courses, and it's done in many countries, and one of them is Egypt too, and Qatar, and in many countries before, we can see it. The training of young primary healthcare physician through diploma, which is 1 year, and a training of and certification of all physicians, which we call it the grandfather clause. And for long-term strategy, starting where I don't know what is the problem to initiate family medicine department in every faculty of medicine in Yemen. And of course, when the people or the students, our students will be aware about family medicine and they know about it and learn from their stuff about it. Of course, big number of them, inshallah, will choose to be a family physician in the future. A training of young primary healthcare physician, National Fellowship, Arab Board of Family Medicine, and initiating family medicine program in the postgraduate along the university course, including diploma, master degree, and PhD. So, talking about just the short-term strategy, which is a crash course in family medicine, we have it already, and we implemented like 20 years in Egypt. We went everywhere in Egypt to teach our GB, and this included, we have all the curriculum about it. This is the adopted strategy for conducting a crash course is blended learning. The cognitive component of the course could be delivered through designed educational platform, pre-recorded videos, and of the educational session, along with interactive session to answer trainee questions. Hands-on training of family medicine practice center unit by potential trainer to acquire the required clinical skills in family medicine. Portfolio of course is needed. A pre and post test with formative assessment, with the summative assessment will be conducted. By the end, a trainee who will pass and fulfill all the requirements will provided with a passing certificate. The year of diploma, which we call it postgraduate diploma or professional diploma, it's 1 year. And the adopted strategy also, it's in 2 semesters. The cognitive component of the postgraduate or professional diploma could be delivered also through designed educational platform, including the pre-recorded sessions and also with the interactive session. Of course, there is hand-on training at Family Medicine Practice Center, and portfolio is part of the requirement. Applied knowledge tests there will be conducted at the end of each semester, and exam will be conducted, including the knowledge assessment test and, of course, OSCE. A training for the all senior primary healthcare physician, which we call it the grandfather clause. The grandfather clause or grandfather effect is a provision whereby an old rule continues to apply to some existing situation while new rules apply to all future cases. Those exempted from the new rules are said to have grandfather right to acquire rights. Grandfather clause have been used across range of different policy area, including the health care. And this initiative was implemented in some countries, actually in Korea, of senior primary healthcare physician to a crash course and depending on reforming of their previous experience to consistent with the evidence base. So just only to find the gaps with them, they have long years of experience, and the requirement is not too much, just to be sure that they are following evidence-based medicine, updated evidence-based medicine. And also we follow same hand-on training, and in addition to pre-recorded lectures and interactive sessions with them, and portfolio is important also to find out the gaps, and pre-test and post-test also is required. And by the end, they are certified when they are fulfilling all the requirements. Long-term strategy, as we said, initiating of family medicine curriculum in the undergraduate phase in medical schools is important. A training of young primary healthcare physician, national fellowship, Arab Board of Family Medicine, initiating family medicine program in the postgraduate phase in medical school, diploma, master degree, and MD or PhD and fellowship. So take-home messages here: primary healthcare setting is the scene where primary healthcare family physicians are practicing. Primary healthcare approach is the way to achieve universal healthcare and health for all. Family medicine has important principles that train primary healthcare physician and family physician to have and to implement the level of their practice. A lot of success has been achieved in health sector in Yemen, but more effort are required to improve health towards achieving universal health care and health for all. Five-star doctor is a catalyst to improve health in Yemen. Trained primary healthcare physicians are the cornerstone, of course, in the process to achieving this. The short-term strategy to improve health situation in Yemen could include the training of young primary healthcare physicians through crash course, enrolling in professional diploma, and along with grandfathering clause for primary healthcare physicians. The long-term strategy, as we said, to improve health in Yemen could include initiation and activation of family medicine national fellowship and Arab Board, starting family medicine curriculum in undergraduate phase, along with the diploma, master degree, and PhD. So change, of course, is difficult, but not changing is fatal. Knowing is not enough, we must apply. Willing is not enough, we must do. And thank you very much, and wishing you all the best.
Thank you very much, Mansoura. I'm just going to see if anyone has any questions at this time. Just waiting to see if anyone has any questions. Give me a second. Do you think that family medicine will grow more in Yemen? Sorry, Dr. Mansoura?
Yeah, I'm with you.
Yeah, so do you think that family medicine will grow in Yemen?
Why not? It's initiated in many countries, and myself, I have an experience here in Qatar. We came in 2001 and no family medicine here, and now you can say that we cover around 80% from the health services by primary healthcare physician, but we need to start. It's not impossible, of course we can.
Okay, and also, why is family medicine in Egypt more recognized by patients and doctors than those in Yemen?
I think it's because of the starting earlier. If you start with teaching the students themselves about the family medicine, and actually we started from 1980 family medicine in Egypt, and the media, the TV, the key persons, and when you teach the undergraduate and they choose, of course, it will be accepted and it will grow.
We have a question from Dr. Hakim. He says, do you think that the MRCGP program would be suitable for Yemen?
Actually, MRCGP in many countries, including Egypt, Gulf area, all countries of GCC, I think they also adopted the MRCGP International. And but of course, myself, I'm encouraging to have the national board in Yemen.
And also, is it possible to establish family medicine without government support?
It's impossible. We need the support from the government and from everybody to initiate the family medicine, because it's not only the manpower. We call it the manpower and materials. Materials, you need the structure, you need the budget, you need the equipment, and you need the manpower. Manpower, actually, as we saw from the WHO, that only 4% we have, 4 doctors per 10,000. Despite we need a minimum 45. So we need actually short-term plan, yani, as soon as, with full support, of course, from the government.
Yeah, I mean, there's barriers to that, and I know that it's sometimes getting government support isn't always easy. So is there a way around it that we can establish family medicine?
Before myself, I had one, like more than visits to Sana'a in 2012 and 2014, and we discussed with them how can we help to initiate family medicine. And of course, it will take time, and we offered that we can accept some residents to be trained in the Gulf area and in Egypt, like every country to take 4 students. So we ended like 40 per year. After 4 years, you will find 40 every year graduate.
Okay. My next question is that, do you think that it is a good idea if the fellowship should replace the master degree?
Yeah, I agree.
You do?
Yeah, too.
Is there a reason for that?
The reason that master degree, usually we rely on master degree, part of it is taking in the research. Despite I'm an academic person and I'm professor and teaching research and implementing research, but it takes like 5 to 6 months from the 2 to 3 years of master degree spent in the research. Despite I need all this just to let my trainee to be competent family physician. And if they are interested, of course, we will teach them the principles of research and how to read their papers and how they get the answers for their questions. But in the acute stage, we need them to be competent family physician. And if they are interested, they can continue in the research area. We are encouraging the fellowship and the board, MRCGB, whatever, but the master degree, it's part of it is theoretical.
Okay. One of my last questions is, do you think that cooperation and coordination between universities, public and private, all over Yemen regarding introducing family medicine will change the situation in Yemen?
Of course, I agree totally that we need the collaboration of all and everybody there to start and to initiate the families.
Okay. I don't think I have any other questions from anyone. I'd like to thank you once again, Professor Mansoura. Thank you very much for your time and dedicating your time as well for us. Is there anything else you'd like to say?
Thank you very much, and I'm ready anytime to help. If anything, help our people in Yemen. I'm ready anytime.
Brilliant. Thank you. That's good.
From Egypt.
That's good to know. Thank you very much. So we've come to an end, and I think we're going to break for half an hour. If everyone can just come back about 4 o'clock, that's UK time. So just in half an hour's time. Thank you.
مبشر Hello. Mubashir, should I start?
Can you hear me?
Yes. Yes, Wahib.
I think we may be starting at 12:30. Let me just check the chat.
Okay.
Oh, okay.
I thought Mubashir said we could start now with the second speaker.
We're starting at 4 o'clock. Dr. Al-Ghazi is our chairperson, and Professor Huda has kindly agreed to be the first presenter.
Yeah, that's fine. Then starting. Okay, I will start now. Yeah. Okay, Assalamu alaikum, and good evening, everyone. Welcome back to the third session of our international conference on family medicine in Yemen, INTERYem. INTERYem is a conference for the first time ever to focus on family medicine in Yemen, and hopefully with trying to build new experience of family medicine and to obviously to go forward with primary care in the Yemen. Our third session today, we have 5 speakers. We got Dr. Wafa Haj Al-Shuaib, and then Professor Huda Basim, Professor Amatul Latif Abu Talib, Dr. Hamoud Yahya Mahyoub Al-Hunahi, and then Dr. Najla Al-Jariri. 4 from Yemen, and I understand Najla from Saudi, from Riyadh. Our first speaker will be Professor Huda Basim. Huda Basim is the Vice Dean of the Faculty of Postgraduate Studies and Research in the Community Medicine and Public Health Department, and obviously in the University of Aden. Her talk will focus on the pre-service education and integral management of childhood illnesses. So, Professor Huda Basim, are you hearing me? Are you there? Can you unmute yourself? Huda. Professor Basim, Huda? You could start now.
Yes. Yeah, I am here.
Okay, you could start now, because the first speaker did not start as yet, so we thought we'll start with yourself. So, Professor Huda, can you start?
Okay, thank you.
Thank you.
I am trying to share screen, but it seems disabled. Are you hearing me?
Yes, well, I'm hearing you. You should be able to do it.
Okay, now.
Okay. Thank you.
Are the screen clear? Yeah.
Yes, clear, yes.
Thank you very much for the organizer for inviting me to take part in this important conference. My talk is about the need for pre-service education in integrated management of childhood illness in Yemen. For the outlines for this session, it is about why IMCI, and I mean the rationale for IMCI itself, and then the rationale of IMCI in the pre-service education. Then about what is the prevalence of IMCI pre-service education in the region, Emiro region. And we'll go to the phases of IMCI pre-service education and what are the standardized approaches of IMCI pre-service education in the region. Later on about the regional IMCI pre-service education package. There are many things are available in the region. And then what are the lessons learned? IMCI actually is a broad strategy. It is designed to reduce mortality, morbidity, and disability among under 5 children and to improve their growth and development actually by addressing all 5 major childhood illnesses or problems. It developed in the early 90s by WHO and UNICEF and other partners as a simple, affordable, and effective intervention with an integrated approach to overcome all these difficulties or limitation associated with disease-specific vertical programs. Why IMCI? More than 2/3 of children deaths are attributed to 5 conditions that are responsible for 80 to 90% of outpatient consultation. Also, research showed that programs focusing on specific diseases have limited impact on child morbidity and mortality, as well as that vertical programs were criticized because of duplication of resources, technical limitation, and failure to address the need of children and the risk to suffer those who suffer from multiple diseases. What is IMCI? IMCI, briefly, they have 3 components. It looks separated, but they are interrelated. Component 1 is about improving case management and communication skills of healthcare providers. The second is about component 2, improving health system quality and efficiency at the health facility. And the third component, which is community IMCI, improving family and community practices, which actually is the least developed and the least clearly implemented all over the world. The case management of IMCI, the first one and the widely addressed one, this is that because 40–60% of children mortality burden in systematic and integrated way. IMCI can do this. IMCI relies on syndromic case management instead of specific, signs and symptoms. As this syndromic case management is the centerpiece of strategy to establish child health services. This is IMCI in summary. We started by focus assessment. Then what are the danger signs, main symptoms, nutritional status, immunization, and other problems. For every child, these have done. Then come the classification. Those who need referred in red or pink color, those who need specific treatment at the center, primary healthcare center, and those that only need home management. After that, it comes, the evaluation of the treatment, identify treatment, if there is any failure or another treatment need to be added, and then counseling the caretaker and counseling and follow up later on. This is another way to see the syndromic diagnosis: assess the child for the general signs, classify the child, identify specific treatment, treat the child, counseling, and follow up. This is just an example. I will not go deeply. For example, if you take the problem of dehydration, we have to classify if it is severe dehydration, some dehydration, or no dehydration. Then the management plan should be done according to IMCI syndromic diagnosis. Actually, my PhD study is about IMCI, and we published a couple of literature, and we have some lesson I will share with you later on about IMCI is how it's running in our country. But about pre-service education, why pre-service education and what is pre-service education? First, pre-service education, as the title says, it is undergraduate education of health professionals, either before their graduation or after graduation, but before becoming, in the health services, so before joining the services. So it is IMCI, pre-service education is the introduction of IMCI guidelines in relevant undergraduate programs. The rationale, we have 4 rationales for having pre-service education. Number 1, we know that qualified and skilled human resources are the backbone of any health system. So we have to train our health staff about this. So pre-service education is the first step of development of human resources, long-term approaches for sustainability. In-service training exists and we still need it, but it has some limitation. It has major investment. It is costly, and for what? For the health system and partners, so those that like WHO and UNICEF. It has high turnover because the staff are not, staying in one center or in one place, and it have limited coverage. Usually, they are not addressing private sector in this training. the in-service, but in pre-service, all of them will expose to such training. Number two of the rationale that the large number of graduate work is in the primary health care. That is, our graduate will go to this center before becoming, specialized or having another specialization program. So we have to have competent healthcare provider ready for all those things that they will face in the primary healthcare center that sometimes lack essential requirement. But what is, IMCI? Is it separate alone? No, it is to complement the pediatric or the classical pediatric teaching. Number three, that the classical pediatric teaching is usually hospital oriented and usually on inpatient, the training of the student on inpatient with limited space for pediatric training at outpatient or home care. So stressing on accurate diagnosis also exists in our clinical practice, well-equipped health facilities, that is the teaching hospital. But in reality, the student or the graduate will come to those conditions that sometimes we cannot ensure everything is present. So this is weak connection between what they have learned in the classical practice and the reality they will work in. Number four, that teaching in developing countries, usually it is passive methods. Of course, there are exceptions of this, but in general, and there are little interactive learning, but in IMCI training and guidelines, there is a lot for, training in communication skills for the student. What is the prevalence of pre-service education? As of, 2019, the MRO, statistics said that there are 80 universities in the region, and Alexandria University is the first university incorporated IMCI, and that is long away, 1999. And Sudan has the highest number of universities, 32, followed by Egypt, 21. This is, the summary. For example, Afghanistan has only one university, Egypt 21, either private or public universities. Iran has 3, Morocco 9, Pakistan 9. Some of them have well established, like here in Nishtar Medical College in Pakistan. Sudan then separated 3 in South Sudan and to 32 in Sudan itself, and Syrian Arab Republic is the last one in 2012. What about Yemen? In Yemen, there were 2 workshops have been conducted, one in 2007 and follow-up workshop in 2010 to see what Yemen has done. And all this material that you have seen here, the handbook, the other guidelines and teaching material were given to the universities in Yemen. What happened that the medical universities actually not taken this opportunity, seriously, but in the Health Institute, they have done this well, almost well. There are still needs for in-service training, of course. In-service training, they are needed to prepare key person to plan at the Ministry of Health. They had to train the teaching staff, to have health professional already working. They have to also to expose to IMCI training and to prepare health facilities to receive graduate training. These are the phases of pre-service education. In the phase 1, to need to have orientation plan. By the way, IMCI itself, it needs time to be implemented. There are 3 phases: introduction, implementation, and then the expansion phase. And the same for the pre-service education. Sometimes countries needed years to have these phases, and this is not bad to have. And maybe this is the same, it can be applicable for family medicine introduction. So in phase 1, we have to orient and plan. In phase 2, to prepare and conduct teaching. And this is have many things, train teachers, prepare clinics, prepare materials, coordinate teaching, monitor teaching, and then come the phase 3 for reviewing and replanning. So we come with review plan, and phase 4 come here to evaluate all things, by assessing the outcome. And then the cycle come again and again. And this is, we have a good example from Alexandria University and from Al Jazeera University in Pakistan, in Sudan. There are standardized approaches, as I said. We can stay here. What is this approach at the national level and then at the institutional level? At the national level, at first, creation of supportive environment. Without this, without the commitment, without the endorsement from higher level management, we cannot have good IMCI implementation. So who are the partners who are having the ownership of this? Give the universities the feeling that they have this program, and they will collaboratively with the Ministry of Health, obtaining the endorsement and commitment of the decision maker, and to have national management structure. So without this, coordination between all partners, Ministry of Health, the universities, and other institutions, we cannot have good IMCI, service education. Again, also at the national level, creation of supportive environment, continuation, raising awareness and sensitization. I remember in the 2007 workshop, we have two departments participated, Department of Pediatrics and Community Medicine. I remember the colleagues in Department of Pediatrics refusing totally to have this program. But when we come 2010, the condition little bit become better. They have some, we can say tolerance to have this, but in reality, nothing done. So raising awareness, sensitization, very important, and identification of targeted institute. Not necessarily all institute to have, and that list that I provided, they come in several years. So development of a national IMCI pre-service education plan with many steps. At an institutional level, we have to identify who are the department, as I say, what are the workshops that we have to, follow up and to take part, official endorsement, management structure, who will be the focal point, who are the teaching staff that will be implemented, and so on. At the institutional level, each department to implement, and the faculty council to have implementation plan. And this is important for sustainability and to have internal monitoring and internal and external evaluation. This is also very important. IMCI better to have in this way, that to be part of essential pediatrics training, teaching, not like this, that is like separate teaching program, not like this, that is certain blocks happen. So it will be at the center of the pediatrics training. Sometimes they have different ways, sometimes like blocks separated and sometimes one block. This can be, adapted according to the situation of each university, no matter about this. This is that I have explained, the syndromic diagnosis, we can skip. This is the pre-service package. WHO and UNICEF has prepared everything. There are IMCI teaching method, these are certain books already exist, and it is also available online. IMCI teaching method and IMCI lesson plan, what are the lectures, the guide on evaluation of IMCI pre-service education, and the question bank about the IMCI. So the service, the package of the pre-service education show that how IMCI could be incorporated. I say there are the theoretical concept, the guideline, how we can adopt into the teaching, because we have to introduce new things inside something exists. That is the classical pediatric teaching. We have the practice, how we can supervise the practice, how can we give the communication skills. We know our teaching not much having this room for the communication skills, how the knowledge and skills and attitude to be changed or be upgraded. We cannot change, but it is upgrading of these skills. And then come the stage of official inclusion. how this will be in the teaching curriculum. The Supreme Council, the National Medical Curriculum have to be aware about the institution ownership, the institutional approval. Faculty of Medicine, for example, Eden University, what to have to be done, how the department will be taken this, not only some individual enthusiastic about this, but should be the department vision to have this training or this teaching. National IMCI education structure and incorporation of IMCI finally, incorporation into IMCI pediatric textbook. Adopting IMCI as an outpatient pediatric also, this is important because I say very small room for pediatric teaching in the outpatient, and continue monitoring and evaluation to be taken to have corrective measure if there is something appear for the time, maybe the student become not well trained and so on. So this need to have allocating enough time for clinical practice, and what are the options we have for big number of students. That is the problem that we are facing in our Yemeni universities, big number, while those places for outpatient or clinical examination or having a communication skill is very small. So, and thank you very much for your listening. Hello?
Yes, thank you, Professor Basim. It was very good and enlightening talk. You know, personally, first time I hear about IMCI. I'm a GP practicing in the UK, but sounds very good lecture. So if you want to recap your lecture in few minutes, basically, is that like you're focusing on education and training in terms of childhood illnesses, and with incorporation about both community medicine, family medicine, and pediatrics? Is that what you are focusing on, isn't it? So we should both thinking the same.
Yeah, why am I presenting this in this family medicine? Because IMCI is having good link between clinical practice and community practices. So it will be a good example of those programs could be included or at the center of the family medicine programs.
Well, sounds very good. And it's also about between pediatrics and family medicine as well, isn't it?
Yeah, yeah.
Well, thank you very much. So very good talk. We'll go to if any questions and on the question panel. We don't seem to have any questions. Anyone from the audience, are there any questions live you could ask? Okay, I don't think we have any questions. Thank you again, Professor Basim. We will move now to the second talk. Thank you.
Thank you.
Thank you. The second speaker on our session is Professor Amatul Latif Abu Talib. Professor Abu Talib is an assistant professor in community medicine at Sana'a University, and she is the manager of the family medicine program in the Ministry of Public Health. Her talk will focus on experience of family medicine in Sana'a. And Professor Amatul Latif, are you there?
Yes.
Okay, you could start now, please, if you can.
السلام عليكم ورحمة الله.
وعليكم السلام.
سأقوم بالتقديم باللغة العربية.
Okay, and خير إن شاء الله. No worries. I think probably we'll have translation live. Okay, Arabic is fine, no problems. Okay, تفضلي.
هل تشاهدون الآن الشاشة معي؟
لا عاد
ليس الآن.
ليس الآن، نعم. حاولي تحاولي تعملي شير سكرين.
شير سكرين. والآن؟
نعم الآن موجودة. تفضل يا دكتورة.
تمام. السلام عليكم جميعا. سيتم الآن تغطية ما قدمناه أو ما بذلناه من جهد خلال السنوات السابقة فيما يخص برنامج طب الأسرة وزارة الصحة الجمهورية اليمنية صنعاء. مبررات إنشاء البرنامج أن أثناء عملي ودراستي بوزارة الصحة فقد درست دبلوم طب المجتمع في 1998، وكان من الواضح جدا أن هناك مشاكل صحية كبيرة في البلد، وهناك أيضا تغطية السكان برعاية صحية لم تزد عن 62% خلال أفضل حالات البلد. وكان السؤال هو من يقدم الخدمة للآخرين؟ 40% تقريبا من السكان لا يلقون أي خدمة صحية. والسؤال أيضا عن جودة الخدمات الصحية التي تقدم في هذه التغطية، وماذا يقدم؟ أيضا الخدمات الصحية تقدم عبر برامج رئيسية الفيرتيكال بروجرامز، ويعتمد نشاطها على مستوى توفر الدعم خاصة من المنظمات لأن دعم الدولة قليل. إذا ما هو الضامن لاستمرارية هذه البرامج إذا توقف الدعم أو خف حسب ما هو بالاتفاقيات مع المنظمات أنه خلال فترة معينة من 5 إلى 10 سنوات يقل دعم المنظمة ويبدأ دعم الدولة. فإذا لم يتم الدعم بالشكل المضمون إذا ما هو مصير هذه البرامج؟ وكل برنامج عبارة عن دولة مستقلة، ويتم الحديث دائما داخل وزارة الصحة عن التكامل بين كافة البرامج والمشاريع داخل الوزارة، الانتجريشن. ومنظمة الصحة تكلمت كثيرا عن الكلاسترز والكلاسترز اللي هي العناقيد، ولم يتم تنفيذ شيء منها. كما أن هناك غياب للرؤية الصحية والاستراتيجيات التي يتم الالتزام بتنفيذها، ويتم التركيز غالبا على الخدمات الصحية الثانوية. كما أن هناك ضعف في نظام المعلومات الصحية وهدر الموارد في إنشاء أنظمة معلومات منفصلة لكل برنامج رئيسي، حيث أن كل برنامج ينشأ جديد يجد أن ليس لديه المعلومات الكافية حتى يستطيع أن يبني البرنامج أو ينفذ خطته، فيقوم بإنشاء نظام معلومات خاص به يجمع ما يحتاج له هو فقط معلومات، فتهدر هذه المبالغ في حين أن النظام الخاص العام داخل وزارة الصحة ما زال ضعيف وغير فعال. ووجدنا كذلك أن كل الجهود المبذولة للمكافحة والسيطرة على الأمراض لا تؤدي للقضاء على الأمراض لعدم أخذ العوامل المجتمعية والبيئية في الحسبان وغيرها، أو لعدم إمكانية حلها، بحيث أنه كافة البرامج لديها موازنات محددة، وما يتبقى من العوامل يجب على الدولة أن تقوم بمكافحته أو السيطرة عليه. ولا يوجد هناك تنسيق واضح بين الوزارة، برامج الوزارة وباقي الوزارات، مما يؤدي إلى ضعف السيطرة على هذه العوامل وإعادة انتشار الأمراض بعد أن يكون تم السيطرة عليها بشكل كافي، مثل الملاريا. العوامل اللي العالم اتخذ منهجية الرعاية الصحية الأولية وأخيرا طب الأسرة لتقديم الخدمات الصحية لكافة السكان بجودة عالية. فمتى سننضم للركب مع حاجتنا الشديدة والعاجلة لهذا النظام؟ أي أننا وجدنا أن كل العالم سبقنا رغم وضعهم الاقتصادي الأفضل بالكثير، رغم أن الخدمات لديهم والمؤسسات أقوى بكثير، ونحن بكل الفقر الموجود وبكل الاحتياج لمثل هذا النظام وللرعاية الصحية الأولية لم نبدأ بعد. هذه كانت المبررات التي تم عرضها على وزير الصحة، وكان هذه الأيام في 2013 الدكتور العنسي أحمد العنسي، وكان قد عاد من زيارة لكوبا وشاهد فيها نظام طب الأسرة، وكيف أنه برغم الحصار والفقر في كوبا إلا أن لديهم أنجح نظام صحي لأنهم اعتمدوا فيه على طب الأسرة. فقام بمباركة الفكرة وطلب مني أنا والفريق، وإحنا عبارة عن 3 أشخاص فقط كنا، أنا الدكتور عبد الجبار علي عبد الله والدكتور جمال بعثر. طلب مننا أن نجهز تصورنا لما يجب أن يكون عليه البرنامج لكي يقره. وصدر القرار الوزاري في عام 2013، وكانت هذه المهام التي أكلت إليه: تحديد المواقع التدريبية والخدمية ونظام الإحالة وفق المعايير الدولية، تحديد المستشفيات المرجعية بحسب النطاق السكاني، اختيار المتدربين للالتحاق بطب الأسرة، عمل مسوحات مجتمعية لإعداد قاعدة بيانات للمستهدفين، اختيار المدربين وتأهيلهم للبدء بعملية التدريب، تصميم الملف الصحي والبطاقة الصحية، وضع السياسات والاستراتيجيات الخاصة بطب الأسرة، التنسيق والتعاون بين البرنامج ونظام التأمين الصحي، لأن نظام التأمين الصحي لن ينجح بدون طب أسرة، وطب الأسرة لن ينفذ إطلاقا بدون تأمين صحي، مع الفقر الشديد في البلد ومع حاجة السكان لكل الخدمات. وضع التصورات بالأنظمة المساعدة المطلوبة لتحقيق أهداف طب الأسرة، والتنسيق والتعاون بين الجهات المختلفة ذات العلاقة، وتحديد أدوار مسؤوليات وعلاقات الجهة داخل وزارة الصحة مع البرنامج، وذلك لأن البرنامج سوف يتعامل مع كافة الإدارات والقطاعات داخل الوزارة، وكل قطاع وإدارة سيكون له دور في تنفيذ منهجية طب الأسرة، وهذا يعني تغيير شامل داخل وزارة الصحة. خطة البرنامج: أول خطوة قمنا بها كانت أننا قمنا بحملة ترويجية كبيرة لكي نعرض لكافة الكوادر والناس ما هو طب الأسرة، لأننا كنا كلما نسأل أي حد ما هو طب الأسرة لا أحد يجيب، الجميع لا يجيبون إطلاقا، معناها أن المفهوم ليس موجودا لديهم وليس لديهم أي فكرة عما قد يحتويه هذا النظام أو ما قد يغيره في النظام الصحي في البلد. فقمنا بحسب الهيكلية داخل الوزارة بمقابلة كافة الوكلاء والمدراء العموم، ثم انتقلنا إلى المستشفيات وقابلنا وعملنا اجتماعات مع الأطباء، قابلنا مدراء مكاتب الصحة، ثم دخلنا إلى المنظمات، ليس لأنهم لا يدركون معنى طب الأسرة، ولكن لكي نطلب دعمهم في زيادة الترويج ودعمهم بوضع ميزانية ولو بسيطة للبدء في النظام. كما ذهبنا وتواصلنا مع لجنة الصحة في مجلس النواب، وسمح لنا بإلقاء محاضرة قصيرة تعريفية عن طب الأسرة. ثم وصلنا إلى المجتمع عبر عمل مقابلات إذاعية وتلفزيونية ومقابلة أعضاء المجالس المحلية. كل هذا في الأول حتى يتابعنا الناس ويفهموا عن ماذا نتكلم، ما هو العنوان الذي نود أن نطرحه. لماذا توقف؟ آسفة جدا.
دكتورة استمري، نحن متابعين.
لدي توقف فيها.
اوكي خير ان شاء الله، حاولي.
مشكلة بسيطة في النص. ثانيا تم الاطلاع على تجارب الآخرين في تطبيق نظام طب الأسرة، وقد أرسلنا الوزير وزير الصحة لزيارة كلية الطب بجامعة حضرموت، باعتبارهم كانوا قد بدأوا بماجستير طب أسرة، وكان لديهم قسم يدرس طب الأسرة داخل كلية الطب، وأيضا لديهم في مكتب الصحة مراكز صحية تعتمد هذا النظام، فأردنا أن نزورهم لكي نتعلم منهم ماذا عملوا وكيف طبقوا هذا النظام وما هي آلية تطبيقه. ثم قمنا بزيارة برنامج طب الأسرة بمملكة البحرين، ثم تركيا، ثم سلطنة عمان. بعد هذه الزيارات تم عمل أو إعداد التصور الكامل لكيفية تطبيق طب الأسرة في اليمن. وقد جمعنا من جميع البلدان التي قمنا بزيارتها وثائقهم التي سلمونا إياها وما اعتمدوه من استمارات وسجلات وأدلة، راجعناها جميعا ووضعنا التصور الأولي لكيفية النظام الذي سيتم تطبيقه في اليمن. ثم عبر مكتب التعاون الخليجي بالوزارة تم التواصل مع رئيس مجلس التعاون الخليجي، وأرسلوا فريق من الخبراء العرب في طب الأسرة في الوطن العربي، وكان على رأسهم الدكتور توفيق هوجة، الدكتور عادل كاظم، الدكتور نبيل، الدكتور، يعني 8 كانوا منهم، وقاموا بزيارة المراكز الصحية المختارة في مستشفى الثورة والجمهوري ومستشفى 48، وكل هذا حتى يسرعوا بالموافقة على بدء الزمالة في طب الأسرة. هنا أود أن أرد على الدكتور وطرفي أننا لم نكن أصحاب القرار في التخصص، وإنما كانت هذه ما كتبوه وما أرادوه الخبراء الذين وصلوا إلى اليمن وبدأوا تدشين البرنامج في 3 مارس 2013، باعتبار أننا نحتاج إلى كوادر عليا في هذا التخصص ليكونوا هم المدربين لكافة الكوادر والتخصصات التي ستنشأ لاحقا داخل البلد. ثم تم إعداد ملف الأسرة والبطاقة الصحية وكافة السجلات مع الأدلة. الخطوة الرابعة، بدأنا بتطبيق التجربة القبلية لمنهجية طب الأسرة في المركز. أولاً تم اختيار أمانة العاصمة لعمل التجربة القبلية لتكون في إمكاننا الزيارة يومياً للموقع ولقربها من الوزارة ومتخذ القرار. ثم تم اختيار أفضل 10 مراكز، مركز من كل مديرية بأمانة العاصمة، للنزول إليهم لتقييمهم بحسب معايير طب الأسرة. وبعد أن تم التقييم تم اختيار أفضل مركز من 10، وهو مركز مجمع الشهيد علي عبد المغني بمديرية الوحدة بأمانة العاصمة. داخل هذا المركز لكي نبدأ بالتنفيذ قمنا أولاً بلقاء مع مدير مكتب الصحة وأعضاء المجلس المحلي بمديرية الوحدة لكي نوضح لهم ما هو طب الأسرة وما هي فوائد طب الأسرة وآلية التنفيذ وسهولة التنفيذ. ثم قمنا بتحديد الزمام السكاني ورسم خارطة به باستخدام المعلومات المتوفرة لدى برنامج التحصيل وأيضاً من التعداد السكاني. بعدها تم تعيين فريق متطوعين من المجتمع في هذه الزمان، ونزلوا للأسر لكي يوعوهم بالنظام وفوائده، وأيضاً لتعبئة استبيان للفرق. تم إدخال كافة البيانات في برنامج إلكتروني، وقمنا بطباعة البطائق الصحية لهذه الأسر، ووصل عددها إلى تقريباً 450 أسرة اللي تم التسجيل يومها. ثم نفذنا ورشة عمل لكافة العاملين للأطباء بالذات في طب الأسرة بالتعاون مع جامعة حضرموت، ولهم جزيل الشكر، فقد قدموا إلينا جميعاً وقاموا بأفضل عمل ممكن. ثم قمنا بإعادة توزيع وتسمية غرف المرفق حسب منهجية طب الأسرة، وإضافة الخدمات الناقصة مع تدريب كل عامل على مهامه. هذا فيما يخص داخل المرفق الصحي، المركز الصحي. لكي نبني بناء نظام الإحالة الغير موجود داخل الوزارة، تم الاتفاق مع مستشفى الجمهوري ليكون مستشفى الإحالة لهذا المركز، وفتح مكتب للحالات المحولة مع اعتماد نظام للمواعيد البوكينج سيستم. تم تدشين افتتاح المركز كأول مركز خدمي وتدريبي لطب الأسرة في 7 يوليو 2014. خامساً، الإعداد للبدء في تدريب زمالة طب الأسرة. بحسب ما قلنا سابقاً بأنه لا يوجد لدينا ولا أخصائي واحد داخل البلد طبيب أسرة، ورغم هذا فإن الخبراء العرب الذين قدموا إلى اليمن قدموا التماس في المجلس العربي لاعتماد البدء بالزمالة، وأنه سيتم التعاون مع البحرين ليوفروا المدربين والمدرسين إلى أن يتم تخرج أول دفعة. قامت لجنة الخبراء بتقديم الطلب وتم الموافقة عليه وتم إرساله إلينا، ثم تم إعداد المنهج والجداول التدريبية والإعلان عن الزمالة للطلاب، وتم إعداد القاعات التدريبية في مستشفى 48 ومستشفى زايد. تقدم للامتحان 40 طالب وطالبة. وبدأ العدوان في 26 مارس قبل أسبوع من الدراسة، فلم يعد بإمكان المدربين من البحرين الحضور أو دخول اليمن، واضطرينا إلى توقف الزمالة، وهذا هو السبب دكتور علي الذي أدى إلى توقف زمالة طب الأسرة. دور منظمة الصحة العالمية. قامت منظمة الصحة العالمية بدور فعال بمحاولة دعم البدء ببرنامج أو منهجية طب الأسرة في اليمن، وذلك بأن دعت كافة الدول الإقليم والمنظمات العالمية العاملة في طب الأسرة إلى اجتماع بالقاهرة، وتم خلال استعراض كافة التجارب لتطبيق طب الأسرة والمعوقات التي تواجهها. ثم دعت كافة الحضور بدعم اليمن وباكستان والصومال للسير على هذا المنهج، وقد دعت سلطنة عمان بدعم اليمن مع شراكة كافة الأشقاء. قامت المنظمة بمخاطبة الوزارة بنتائج الاجتماع مع نتائج اجتماع جنيف الذي لحق مؤتمر القاهرة. وإلى الآن أنا كمديرة طب الأسرة لا أعلم ما تم أو قد يتم في هذا الموضوع، لأن كل مراسلات منظمة الصحة العالمية لم تكن تصل إلى البرنامج، بل كانت تصل إلى مكتب الوزير، وأنا لم أعلم شيء من بعدها. فيما يخص سادساً، الخطتنا سادساً كانت تدريس منهج طب الأسرة لطلبة كلية الطب. تم عرض الموضوع على قسم طب المجتمع بكلية الطب صنعاء والعلوم والتكنولوجيا، وتمت الموافقة على تسمية قسم طب المجتمع بقسم طب الأسرة والمجتمع. تمت الموافقة على المنهج المضاف الذي سوف يدرس في سنة 5 ابتداء من السنة القادمة. انظروا إلى الفرق الشاسع في السنوات، لأنه لم يكن هناك حماس داخل كلية الطب بأن نبدأ بالمنهج كمنهج طب أسرة، ولكن أولا وافقوا لنا على إضافة عدد قليل من المحاضرات، 4 محاضرات فقط للتعريف بطب الأسرة ومكوناته الأساسية، لكن كمنهج كامل لم يضاف إلا من هذه السنة، وسيدرس بإذن الله من السنة القادمة. قامت جامعة العلوم والتكنولوجيا باستدعاء خبراء من ماليزيا وقررت البدء في ماجستير طب الأسرة. حضرنا معهم الاجتماع وناقشنا الآلية، وتم إقرار افتتاح مركز طب أسرة تابع للجامعة، ولكن توقفت كل الأمور من بداية العدوان ولا نعلم ماذا حصل بعد ذلك. المعوقات. أهم وأكبر المعوقات التي واجهتنا منذ بداية الكلام عن طب الأسرة هو أن هناك نواقص خطيرة داخل النظام الصحي بوزارة الصحة أثرت على العمل ككل، ولا يمكن أن ينشأ برنامج لطب الأسرة أو تنفذ المنهجية في عدم وجودها، مثل عدم وجود نظام معلومات قوي وموحد. وإلى الآن ما زال كل برنامج لديه نظامه الخاص، وما زال البرنامج العام الذي يتبع الوزارة الذي هو يسمى الإدارة العامة لنظام المعلومات أضعف ما يكون، ولا يوجد ملف موحد ولا يوجد آلية موحدة لنقل المعلومات، حتى أنه يوجد داخل المرافق الصحية على مستوى الوحدات 17 سجل على العامل الصحي الوحيد أن يكتبهم جميعا، لأن كل برنامج رأسي يريد أن يتعبى معلومات. ثانيا عدم وجود نظام الإحالة، فكيف ممكن أنا أن أبدأ أشخص الحالة وأشتغل في المركز الصحي بشكل مثالي بدون أن يكون لدى المريض الحق بأن ينتقل بطريقة سليمة وآمنة لتلقي الخدمة عند وجود طارئ أو الحاجة العملية أو الوقوف في المستشفى أو لعمل أي فحص لا يتوفر إلا في المستشفيات. فعدم وجود هذه الآلية معناها أنني أشخص الحالات البسيطة أو الحالات المزمنة المباشرة، ولا أستطيع أن أقدم للفقير الذي يأتي وليس لديه حتى ما يتواصل به ما يمكن أن يخدمه في أن يحصل على خدمة ثانوية داخل المستشفى. ثالثاً التأخر في البدء في تطبيق التأمين الصحي. كنا بدأنا مع بداية البرنامج بدأوا في تجهيز كافة الأدلة والنظام لتطبيق التأمين الصحي في اليمن، ووقف البرنامج كما وقف طب الأسرة، وإلى الآن لم يستطيعوا أن يبدأوا فيه من جديد. وعندما يبدأ التأمين الصحي نستطيع بسهولة أن نبدأ طب الأسرة، كما أنهم لا يستطيعوا أن يعملوا بدون طب أسرة. رابعاً التغلب على البرامج الرئيسية والعمل على التكامل بينها، لأن هنا كما قلت كل برنامج لديه موازناته الخاصة وفريقه الخاص الذي يعمل ابتداء من وزارة الصحة إلى أصغر وحدة صحية، مرتبطين بشكل واضح ومباشر بالبرنامج الرئيسي، وهم لديهم الإمكانيات أكثر. قد يكون عامل بسيط موجود في الوحدة الصحية يتبع برنامج مثل التحصين، لديه من القوة والصلاحيات ما يتزيد عن المدير المركز نفسه أو حتى مدير مكتب الصحة. وهذا يجعل من الصعب جدا أن نجمع جميع البرامج لكي تشتغل وحدة واحدة لكي تقدم خدمة وحزمة كاملة من الخدمات على مستوى الوحدة والمركز الصحي. أيضا من الصعوبات والتحديات استمرار العدوان على اليمن مع توقف الرواتب وقصف المرافق الصحية، وأصبح من الصعب جدا أن نتكلم مع أي من الموظفين الدكاترة والممرضين أو غيرهم بالضرورة الالتزام بالعمل والدوام أو تنفيذ البرنامج في المركز الشهيد علي عبد المغني وليس لديه حتى ما يكفي يصل إلى المرفق. عدم البدء ببرنامج التأمين الصحي كما قلت في السابق، وزيادة الفقر وانتشار الأمراض. وقد زاد انتشار الأمراض حتى الأمراض التي يعلن على أنها اختفت من العالم مع الحرب والعدوان زادت بشكل كبير، وأصبح يشكل عبء كبير جدا على الناس، ويزيد من نسبة الفقر ويقلل من استخدام كل المرافق الموجودة. ثم توقف كافة الموازنات، أصبحت لم يعد البرامج الموجودة أو أغلبها لم يعد لهم موازنات تشغيلية، توقفت أعمالهم، وأصبح من المستحيل أن نتكلم عن تقديم خدمة كاملة بعدم وجود أقل أدنى كم من الموازنة لتوفير المواد والمستلزمات والمواصلات لكل البرامج حتى الطباعة. محاولة البث تنفيذ البرنامج مع البنك الدولي في حجة ولكن البرنامج وتوقفت كل التجربة اللي كنا وصلنا إلى أننا لم يبقى إلا أن ننزل للتنفيذ وكان كل شيء جاهز. تغير الوزارة والاحتياج لوقت لإقناع الجديد بأهمية البرنامج. عندما كان الدكتور أحمد العنسي كان متحمس جدا معنا وكان يعمل أقصى ما يمكن أن يقدمه لنجاح البرنامج والتسريع في العمل فيه. عندما تغير الوزير وظهر وزير جديد احتجنا شهور حتى المقابلات وفترة أطول حتى نحاول إقناعه بأهمية البرنامج ولم نستطع. عندما تغير الوزير وظهر وزير جديد حاولت مقابلته وأخذت موعد حضرت ولكن لم أجد أنهم متفهمين لأهمية البرنامج وبدأ العمل به. رغم غيابي فترة عن الوزارة للمرض وأسف جدا للكحة لأنه ما زلت أعاني من التعب. ثم توقف العمل بملف الأسرة بالمركز مع ظروف العدوان والعمل بنظام المناوبات. يعني حتى المركز الوحيد الذي فتحناه ووقف فيه العمل بالملفات والنظام لأنهم أصبحوا يعملوا بنظام مناوبات يحضروا 2 أو 3 فقط في المركز ولا يستطيعوا أن يقوموا بكل ما يجب أن يطبق للمرضى. ورغم هذا فإننا لم نتوقف وسيظل الحلم هو الأمل، لأن طب الأسرة هو الحلم الكبير الذي عشنا عليه هذه الفترة ولن ينتهي بإذن الله طالما نحن أحياء، وهو الأمل الذي نسأل الله أن يعيننا أن نصل إليه. رغم استمرار العدوان وتوقف الخدمة والتدريب بطب الأسرة فقد واصلنا في البرنامج العمل داخل وزارة الصحة. ليس العمل في تطبيق طب الأسرة وإنما في محاولة إصلاح أو تأسيس الأساسيات داخل الوزارة حتى يبنى عليها طب الأسرة، مثل المشاركة في وضع الدليل المعياري للوحدات والمراكز الصحية وتم الأخذ بالاعتبار معايير طب الأسرة، العمل على توحيد الملف الطبي في كافة المرافق. نوعا ما وصلنا إلى أن كل قطاع الآن أصبح لديه ملف واحد، وهذا إنجاز. بدلا من 18 ملف أصبحوا الآن 3. الحث على وضع معايير لكافة الخدمات الصحية ووضعوا معايير الخدمات في المستشفيات في الأقسام المختلفة، معايير المستشفيات العامة والخاصة، معايير، وهذا إنجاز. استمرار الترويج لمنهجية طب الأسرة وأنها هي الحل. فما زلنا إلى الآن في كل مناسبة وفي كل اجتماع وفي كل موقف نظل نتكلم عن طب الأسرة إنه الحل والحل الوحيد لكي يتحسن خدمات الصحية في البلد ولكي نستطيع أن نقدم خدمة لكل اليمنيين بعدالة وشمولية. ثم تم إعداد منهج لدورات قصيرة لتوقف الزمالة وعدم توقف الحرب. نعلم بأنه لا يمكن إدخال أي من المدربين من الخارج، لذا جهزنا منهج لدورات قصيرة وقصيرة جدا، سواء كان دبلوم أو 10 أيام الأطباء في الخدمة الريفية. وتم الاتفاق مع المسؤولين عن خدمة الريف وبإذن الله يتم، لأنه الآن أعادوا الإقرار بإلزامية خدمة الريف، وبإذن الله نبدأ بالتدريب، تدريبهم على منهجية طب الأسرة قبل أن ينزلوا الميدان. من أهم المعوقات على الإطلاق وهي من أول يوم وإلى الآن عدم توفر الإرادة السياسية لاتخاذ قرار مصيري بهذا الحجم والذي سوف يغير كل مكونات الوزارة وبرامجها، والاكتفاء بوضع المنهجية كجزء أساسي في الخطط المستقبلية والتي نسأل الله أن تتم في القريب العاجل. ولكم الشكر. السلام عليكم.
وعليكم السلام دكتورة أمة اللطيف، شكرا جزيلا على المحاضرة وندعو لك بالسلامة وربنا يشفيك إن شاء الله وتقومي بعافية. وفي الواقع يعني كان عرضك عرض ممتاز، ويعني استعرضت تقريبا التجربة من البداية. واضح أن المعوقات كثيرة تقريبا في كل المراحل، يعني معوقات على مستوى وطني بمعنى أنه ما في سياسة، لا توجد سياسة عامة وتوجه قوي لإنجاح البرنامج. معوقات حتى على مستوى التعليمي في الجامعات وكليات الطب، وعلى المستوى التنفيذي في المراكز الصحية. إنما نتمنى أن تنتهي إن شاء الله طبعا الأوضاع الحالية الصعبة وتعود الأمور. أتمنى فقط تجنب مصطلحات يعني مثل العدوان وما ذلك، لأنه يعني يمكن نقول الحرب، بحيث أنه نحن كبرنامج علمي نحاول أن نتجنب الدخول في يعني في مواقف سياسية معينة. في بعض الحضور طبعا يتكلموا باللغة الإنجليزية، بس حاول أن أعطي لهم بس brief translation what you said. Professor Amatul Latif Abu Talib from Sana, she just gave us a quick, basically, background about experience in family medicine in Sana. She did try hard in Kabul, since the last 7 to 8 years. And on 2 occasions, a team came from Bahrain, and then another team came from Malaysia. And they tried to establish the family medicine program in medical schools in Yemen, and then obviously within the Ministry of Public Health. But she quotes that because of the current situation of the current war in Yemen, obviously the program stopped and they could not actually go on. So that was in a nutshell. Then she mentioned the obstacles, where obviously there are many obstacles, in terms of management level, administrative level, and on the actual the level of implementing level as well, like the hospitals and health centers. But thanks very much to Professor Amatul Latif. I'll just see if any questions here. إذا في أسئلة. اوكي، في سؤال من كوكب الحداد، قالت أظن سوت وماذا بعد، يعني how we could benefit from all these efforts to implement family medicine in our country, how we could improve situation from where we could start. كوكب الحداد تسأل يعني إذا بعد كل ما ذكرت، يعني كيف ممكن نستفيد من التجارب، وما رأيك كيف ممكن أن نتحسن ونمشي الأمام؟
دكتور عبد الحكيم، شكرا جزيلا على الترجمة، ولكن طبعا أنا أتكلم الإنجليزية بشكل كويس جدا.
الله يحفظك. تمام.
فما تحتاج الترجمة، أنا ممكن أقرأ معك الأسئلة وأرد عليها.
أوكي ممتاز، جو أهيد، تفضلي.
بالنسبة لكيفية الوصول لتحديد أو تنفيذ طب الأسرة في الواقع، فيجب أن نواصل الكفاح إلى أن نجد مسؤولين يستمعوا إلينا ويجدوا في كلامنا هو الحل ويدعمونا فيه. هذا هو الشيء الوحيد الذي نستطيع أن نعمله الآن. وبالنسبة طالما ربنا أراد لي أن أعيش، سأستمر في الكفاح إلى أن يأذن الله.
ربنا يحفظك.
الله يخليك. بالنسبة للذكرى، تسأل على بالنسبة تقول إنه بالنسبة لIMCI، تعليق على الأول.
نعم، ذكر إنه زي لي في السؤال للأستاذة هدى، للدكتورة هدى، ممكن خليها تجاوب، بس في تعليق في سؤال لك أنت أيضا. هي ذكرت very good presentation indeed، يعني we have shown very clearly and smoothly the life cycle program. وكان تعليقها أيضا of course the internal and external war has impacted negatively. طيب, but I think if the Ministry of Health with your valuable lead insisted to continue, هي عبارة عن تعليق أكثر من السؤال. قالت تقول التجربة في حضرموت تجربة ناجحة ومستمرة، ممكن يحصل تنسيق مع جامعة صنعاء مع الوزارة أيضا، وسيتويشن يمن way from complicated، فعلا معقدة جدا.
ما زلت أؤكد يجب أن يكون قرار سيادي قرار يخرج من مكتب وزير الصحة ويدعمه مجلس الوزراء ورئاسة الجمهورية، لأن هذا تغيير شامل للنظام الصحي في اليمن.
نعم أتفق معك. طيب بروفيسور عبد اللطيف، موضوع التأمين الصحي أنا كان لي تعليق. أنا هنا طبيب جي بي في بريطانيا. الدول تختلف من ناحية أساليب الدعم. مثلا نحن هنا ما يوجد عندنا تأمين صحي، بمعنى أن الحكومة هي تتولى النظام اسمه NHS. في أمريكا مثلا نظام الهيلث انشورنس وبعض الدول. فاليمن طبعا بلد يعني لا يزال ديفلوبينج نامي، فموضوع التأمين الصحي هو أحد الأفكار، لكن في ظل وجود دولة ممكن تتبنى الدولة يعني دعم القطاع البرايمري كير، الصحة الأولية، ويعني مثلا قصد بالدعم بحيث أنه يكون برنامج ناجح وبدون العودة للتأمين الصحي كبداية، أو يطرح خيار يكون أوبشن في تأمين صحي لمن يكون مثلا عنده قدرة أو قد يكون على مستويات معينة. فبالنهاية هو أحد الخيارات التأمين الصحي وليس الخيار الوحيد يعني.
لأنه في اليمن لدينا فقر يصل إلى 70% من السكان تحت خط الفقر، لا يستطيعوا أن يدفعوا حتى تكلفة المواصلات إلى الخدمة الصحية. وسكان الريف هم أكثر الناس فقرا، فيجب أن توفر لهم الدولة ما يدعم المرفق الصحي وما يأمن لهم مجانية الخدمة، وهذه لن تتم إلا بالتأمين الصحي، لأن كل المحاولات السابقة لم تنجح. ولكن بإذن الله إذا بدأوا التأمين الصحي سنأمل خيرا بإذن الله.
إن شاء الله خير. طبعا هو one of the options يعني خير إن شاء الله. طيب شكرا جزيلا للبروفيسور عبد اللطيف. أي أسئلة أخرى ممكن أي حد يرفع يده؟ أيضا كوكب قد do you think coordination، هل تعطينا التنسيق مع جامعة حضرموت والهيل؟ هل يعني will help us in this phase؟ سؤالها لك يعني.
أيوة طبعا إحنا إذا بدأ وتمت الموافقة على البدء بالنظام فسيكون 100% من خريجي طب الأسرة من جامعة حضرموت سيجدوا لهم أعمال، ونحتاجهم 100% كمدربين لكافة الكوادر الصحية في المرافق التي سيتم فتحها. لا نحتاج لكوادر من الخارج إذا كان لدينا خريجين مؤهلين، وأنا متأكدة أنهم بمستوى رفيع، فالتعاون بإذن الله سيكون حتمي.
شكرا جزيلا. الدكتور وهيب العزاني أيضا عنده سؤال. How many family medicine residents in Sana'a currently؟ يسأل كم حاليا، هل يوجد family medicine يعني أطباء يعني ضمن برنامج family medicine residency حاليا؟ أظن حسب جوابك أنه لا يوجد، النظام البرنامج كله متوقف، أليس كذلك؟
تماما 100% توقف.
فعفوا دكتور وهيب، لا يوجد. Is it possible to start family medicine during political conflict؟ يعني هو السؤال هل ممكن خلال مرحلة الصراع السياسي القيام بهذا البرنامج؟ would collaboration with حضرموت؟ نفس السؤال. نعم
ممكن جدا إذا كان في موافقة من الجانب السياسي من الوزير شخصيا ودعمنا في هذا، ممكن أن ندعو جامعة حضرموت للبدء بفتح نفتح دبلوم طب أسرة، ونبدأ بتأهيل على مستوى الدبلوم إلى أن تنتهي المشكلة وتحل الأمور ويرفع الحصار. عندها نستطيع أن نعطي لهم الفرصة بأن يكون الدبلوم سنة أولى في الزمالة ويواصلوا باقي الزمن.
أنت تقصد الزمالة العربية اللي هو أرب بورد، البرنامج العربي؟
أيوه. ممكن يحصلوا عليها فيما بعد، ولكن الآن أقلها لتقديم الخدمة يحصلوا على دبلوم
شهادة لمدة سنة. نعم ممكن أحد المقترحات. نعم. وأيضا يعني مستقبلا أنا هنا في بريطانيا أنا عندي يعني أفكار إنه ممكن نعمل تعاون مع الكلية الملكية هنا LCGP لأطباء الأسرة، وفي حال استقر الوضع السياسي في اليمن نبدأ برامج يعني تدريب أطباء في اليمن وعمل امتحانات زمالة في اليمن أيضا، يعني إسوة مثلا بعمان ودول الخليج الأخرى والبحرين عندهم برنامج ناجح اللي هو يسموه عن مع CGP انترناشنال، وممكن جدا يعني مثلا بحيث انه يكون نعمل تنسيق مع الرويال كوليج هنا في قسم الانترناشنال ديبارتمنت معهم، ونبدا يعني بالتنسيق حتى ولو خطوات اوليه. فطبعا ان شاء الله بعد وضع يعني عندما تنتهي
لا يمكن
الحرب الحاليه وتستقر الامور يعني.
دكتور عبد الحكيم، لا يمكن القيام بأي تنسيق لامتحان خارجي لأن ليس لدينا البنية التحتية التي سيتم تدريب الطلاب فيها. ليس الامتحان مجرد مذاكرة في البيت.
نعم.
ليس
صح. لا يكون برنامج في ضمن كليات الطب، يعني incorporated، يكون برنامج ناجح فاميلي ميديسن، وبحيث انه تترين دكتورز، يعني اعتقد حتى قبل التخرج وبعد التخرج. نعم.
يجب توفير المرفق الصحي على منهجية طب الأسرة حتى يستطيعوا أن يتدربوا عليه بشكل سليم ويكونوا فاعلين، ونستطيع أن نطبق المنهجية وبعدين في البلد كله.
طيب شكرا جزيلا. أي أسئلة للدكتورة عبد اللطيف؟
دكتورة ذكرى سألت أي وزير لصنعاء ولا عدن؟ أنا بتكلم عن صنعاء، أنا في صنعاء.
نعم. هو طبعا الوضع معقد حاليا دكتورة، لكن إن شاء الله تزول الغمة وتنتهي الحرب الحالية وتستقر البلاد بإذن الله قريبا إن شاء الله.
بالنسبة للدكتورة كوكب قالت لو نستطيع أن احنا نعمل التدريب عن بعد، صعب جدا، لابد أن يدربوا على حالات ولابد أن يكون عليهم إشراف مباشر.
وأيضا دكتورة نظام السوفت وير، برامج الكمبيوتر حاليا في برامج ناجحة، مثلا بدل استخدام الدفاتر القديمة والأساليب، الداتا بيس الآن أصبحت كل شيء الكترونايز هنا في العالم، يعني مثلا حتى نظام الجي بيز أو نظام برايمري كير، هناك أنظمة ناجحة وممكن يعني تشترى هذه الأنظمة في اليمن وتطبق، بحيث أنه حتى يكون نظام الريفيرال، نظام التحويل ضمن النظام موجود، يكون نظام قائم في المراكز الصحية ويكون تنسيق مع المستشفيات سكندري كير، ففي أنظمة موجودة، بس كما ذكرت الوضع الحالي معقد وإن شاء الله تستقر الأمور.
يعني كيف أنا أخرج طلاب حتى لو حصلوا عليها بأي شكل من الأشكال؟ أين حيعمل؟ الطالب أو الخريج هذا أين البيئة التي سيعمل فيها؟ هل أخرجهم لكي يعملوا في الخارج؟
لا في المراكز الصحية في اليمن مثلا، على مستوى في الأرياف وفي المراكز الصحية ممكن.
ليست بمنهجية طب الأسرة، ما زال هناك التخصصية، عيادة نساء ولادة، عيادة أطفال، عيادة تغذية، عيادة، وكل عيادة منفصلة تماما، ليس للطبيب أي دور في ربط كل هذه الخدمات، ليس هناك ملف صحي، ليس هناك نظام معلومات، ولا يوجد إحالة. إذا كيف حيتخرج على النظام وعندما يأتي للعمل لا يجد مكان يطبق فيه ما قرأ؟
نعم شكرا. في رزاق أحمد هنا تسأل سؤال، قال great talk thank you. فهل is there sufficient يعني facilities technological facility in Yemen بحيث إنه to sustain telemedicine؟ ال HPY المنظمة اللي احنا فيها معهم برنامج الآن نفكر اسمه telemedicine، بحيث إنه يعني ممكن تكون حالات في اليمن تعرض على أطباء هنا في بريطانيا وطبعا حالة يعني قصدي كيس بيسس يعني. فهل تعتقدي انه ممكن، هل عندكم مثلا تقنيه ممكنه بحيث مثلا المراكز الصحيه مثلا في صنعاء نعمل تنسيق معنا ونكون يعني نناقش الحالات؟
ممكنه جدا، لانه الانترنت موجود واصل لكل مكان وعلى مدار الساعه، يعني ليست هناك مشكله، ولكن نبدا في تاسيس المرافق وتحسين النظام داخل وزاره الصحه حتى نبني الاساس، ومنها سننطلق خلال شهر إذا أردنا أن نبدأ
إن شاء الله. شكرا. طيب ذكرى أنت سأل do you need to find a donor who could convince the government everything is donor driven in the world setting. يعني الدكتورة ذكرت يعني طرحت إنه الآن البحث عن دونر مهم يعني.
دونرز الآن موجودين منظمات الصحة، هم المفروض متبنيين للمنهجية والرعاية الصحية الأولية. ليست المشكلة في الدونر، المشكلة فيما سيصرف الدونر، على ماذا سيصرف هذه الفلوس.
طيب شكرا جزيلا للمشاركين، الوقت يداهمنا، وكانت المحاضرة قيمة جدا من البروفيسور عبد اللطيف والمشاركات ممتازة. شكرا لكل من شارك وكل من سأل. شكرا بروفيسورة، وإن شاء الله لنا لقاء قادم إن شاء الله.
إن شاء الله.
الأخوة dear audience, our next speaker will be Dr. Najla Al-Jariri. Najla Al-Jariri is General Pediatric Consultant at King Abdullah bin Abdulaziz University in Riyadh, in Saudi Arabia. Her specialty is actually pediatrics, and the talk will be, will be titled Pediatrics and Family Medicine. So Najla from Riyadh, are you there?
Yes.
Okay, thank you for joining us, Dr. Al-Jariri. You could start, please.
Okay, thank you for all. I'm a pediatrician, so I will focus on caring of children and the role of the family physician in this care. My objective, why family medicine is important in children care, and awareness of family medicine about the behavioral and mental health of children, and the role of family medicine and pediatric care, how it is going here nowadays. And there is one case study I will done in Yemen. I will show it, inshallah, and I will provide some home messages and recommendations. So family medicine, as we know, is the specialty of the first contact with the patient, with an emphasis on providing comprehensive physical, psychological, and social care for the patient and his family. The focus is on the patient with the background knowledge of his family, and not just on the disease, entity, or the organ or system. Apart from the curative care of family physician is the best position to provide preventive care and promotion health and rehabilitation care within the community and familiar surrounding. So why it is important? Number one, because of the caring. The topmost quality of a trained family physician is caring attitude toward the patient, his family, and his community. This is the cornerstone of a doctor-patient relationship, which is an essential ingredient in providing effective care. Number two, clinical competence. Without caring without appropriate clinical competence is not enough for providing good quality of care for children. So unqualified practitioner can also put himself across as caring, but will lack the clinical competence to provide acceptable level of care. To achieve this reasonable level of clinical competence for far a wide variety of problems, the present day family physician have appropriate postgraduate training for 1 year. This level will make them acceptable as a specialist in his own right by the patient and also by the entire medical profession. Of course, cost-effective care. Cost-effectiveness, the management of uncomplicated problem by family physician in the community usually costs much less than being seen either in the hospital due to high overhead costs or by specialists who charge high fees for his or her services. Family physician can provide considerable amount of care of a remarkably low cost. And there is a study done in 1998. They found in one study by Whittle et al. Care of illness common in the population, for example, community-acquired pneumonia, was more expensive if provided by specialists than if provided by generalists or family medicine, with no difference in outcome. There is another study published in 2002 showed consistent with the finding within the country's international comparison of primary care showed that those countries with the good primary, with the low primary care had significant higher cost. So continuity of care. One well-trained physician is ultimately responsible for all the problems, including chronic ones, of an individual and his family. His safe the patient going from pillar to post with increasing financial costs and or inadequate and connected medical services. comprehensive care, and this is the most important one. Multiple problems of a patient can often be managed in one consultation by well-trained family physician. This whole person approach can obviously be cost-effective as well as time-saving. A family physician is trained to look at the problem comprehensively from the physical, psychological, and social aspects. Family physicians are also the main provider of personal preventive care, such as immunization, child health surveillance, preventive medical checkups, and health promotion, including advice on effect of lifestyle on health. They are also responsible for rehabilitation care in the community. Maybe you can see how it is meaningful to physicians to see all these patients year after year, to believe a variety of procedure skills and constantly stay challenged. But you might be asking whether this feature of a family medicine are superficial or if they are actually have impact on patients' outcome. In 2015, this study was published, and this very important question was addressed in this study, looking at a sample of a family and primary care outcome and the primary care physician, and they compare and they found their most effectiveness of the most comprehensiveness of the physician can lead to low, markedly low cost. It was also there is decrease in hospitalization. These results show us that the medicine advances and new technology are developed to physician who was linked to a lower cost. It was also associated with decrease in the tackle problems. The skill of the family physician as a comprehensivist is still of high value in its own right. So still, common problem management expertise. So a well-trained family physician is an expert in managing common medical problems of patients of any age and sex in the community. Chronic problem like asthma, for example, simple asthma, anemia, skin atopy, chronic functional constipation can be managed easily and effectively by family physician. Consulting other specialties for this problem can be costly for the patient and maybe overburden the concerned specialist with uncomplicated problems. Coordination of care, first contact physician, the family physician is the best position to provide the medical care for each and every problem a patient presents. He or she can usually manage most of the patient's problem and can refer the remaining problems to the concerned specialist. It is often difficult for parents and or of the patients themselves to determine what is the specialty they need to treat their child. So this is the role of the family physician to direct them which specialty is needed. Community-based care, including prevention and research. Community-based care and research comprehensive care at the doorstep is the hallmark of the care provided by family physician. This can be include not only the curative but preventive measures within the community and specified population. Research in the community setting is often more appropriate for the healthcare needs of the great majority of the population. Research on the hospital-based patients is often more relevant to the needs of the small percentage of the patients of the patient population and is less likely to produce knowledge for effective prevention of the disease. Communication and counseling skills of high standard. Communication and counseling skills is known by all the physicians in different specialties, but especially in the family physician in these skills. continuing medical education, family physicians have a good breadth of knowledge to solve each and every problem of his or her patients presented to him, either by himself or arranging an appropriate referral, as mentioned before. This role obviously due to updating of knowledge and learning skills throughout his or her life type of clinical practice. We can see here to understand why family physician or family medicine means so much for the future. Imagine what it would look like if medical school started meeting the needs of the patient and trained more primary care doctors. We already know that preventive care is a miracle of the medicine we are looking for. What do we see when the primary care workforce increases across the world, from the newborn to elderly patients? We already know that preventive care is the miracle of the medicine. So we can see everyone is healthier, as mentioned by Star in 2002, published in 2002, that said from newborn to elder patient, everyone is healthier when there are more primary care physicians. Also, there is a study mentioned that in 2000, published in 2005 by same author, said patients actually live longer when the family physician are added to community compared with all other physicians. Also, there is some study done, and they mentioned that increasing in subspecialty lead to increased mortality rates. In the same study was mentioned that. So what is about the family physician awareness and about children with behavioral problem or mental health conditions? Early diagnosis of autism spectrum disorder is important because it leads to a positive prognosis due to early intervention. But little is known about general and family practitioner involvement and confidence in dealing with children with common social problem and mental health conditions. One study was done about showing the awareness of the family physician and other specialties in these type of patients. I will present some studies internationally done in United Kingdom, a cross-sectional study, and they found that they have a high knowledge of autism spectrum disorder, but they have less reduced confidence in identifying and managing autistic patients. Also, there is a study done in Nigeria with the same questionnaire used in the United Kingdom, and they found that they have low awareness. Regionally, there is many studies done in Pakistan and in Turkey, and both found low awareness among the family physician resident, moderate to low awareness of about childhood autism. This is the study done in Saudi Arabia and published in 2018. It is a cross-sectional study conducted in 9 teaching primary care centers in Riyadh, and they found that among they used 344 family physician residents and a trainee, and who completed the questionnaire was 277, and they found that 23.8% they are not confident to recognize the signs and symptoms of autism in children, and 33.9% they are not confident to knowing the relevant care pathways surface for people with autism spectrum, and 38.6% they know how they can refer to other specialty. 41.2% are confident to identify stress in the parents and career of their patients. Here, also in the same study, they give them a questionnaire containing of 20 questions about the autism. And they found the first question is about knowing what is autism itself. And then the questions, many questions about how to identify and recognize the autism. And they found that if 50% correct answer, they will pass. If less than 50%, they will didn't pass. So they found 89.5% of family physician residents didn't pass the questionnaire. Only 10.5% passed. So their result was show low awareness level and moderate to low level of confidence in the physician ability to recognize and identify and communicate in regards to autism spectrum disorders. So now, how is the family medicine in caring children? How it is going? The proportion of children's health being provided by family physician has declined significantly worldwide since early 1990s. The number of pediatricians has dramatically increased in the recent years, and children in rural and underserved area depend on family physician more than ever for health care. So this is a study that published in 2019 in Annual Family Medicine. They found a declining proportion of children attending family physician practice, confirmed in this population. Also another study published in 2006 September in the same in the Pediatrics journal. They found family physician provide 16 to 26% of visits for children. Only that, and they found the general pediatrician population grows at 7 times the rate of the U.S. population, and the family physician workforce grow at only 5 times rate since 1981 to 2004. There is one study I found that's talking about the factors that lead to decrease care of family physician regarding their children. They found that physician age, if increases, it will decrease the children care. The odd ratio was 0.97. Also, female physicians are more likely to provide care for children more than male, and the odd ratio was 1.19. Many also other like family physician in partnership practice are more likely to provide care of children than others, and there is some in rural area or underserved population seen by family physician, the pediatric age group more than the other areas. And the family physician practicing in areas with few or not pediatrician are more likely to provide care of children. This is study done in Yemen. I found it in published in May 2002 about the primary care rule during crisis and conflicts in Yemen. The objective of this study is to examine how reproductive, maternal, newborn, child, and adolescent health and nutrition service has been delivered since 2015. Identifies the factors influencing implementation of these services in 3 governments of Yemen, Sanaa, Aden, and Taiz. They make content analysis method. We were used to analyze publicly available documents, which and database which published in 2000 since 2000, and 94 semi-structured individual and group interviews conducted with government officials, humanitarian agency staff, and facility-based healthcare providers, and 6 focus group discussion conducted with the community health midwives and volunteers in September, October 2018. They found the result was a humanitarian response effort focused on maintaining basic services at functioning facilities and deploying mobile clinics, outreach teams, and community health volunteer network to address urgent needs where access is possible. Attention to specific aspects of reproductive, maternal, newborn, child, adolescents, health services, and nutrition varies slightly by location, with different driven by priority of government authorities, level of violence, humanitarian access and availability of qualified human resources. Health services for women and children are generally considered to be priority. However, cholera control and treatment of acute malnutrition are given precedence over the services along the continuum of care. Although health workers display notably resilience working in difficult conditions, challenges resulting from insecurity, limited functionality of health facilities, and challenges in the importation and distribution of supplies limit the availability of and quality of services. So what they conclude greater attention to availability, quality, coordination of primary services coupled with the investments in health workforce development and supply management are needed to maintain access to life-saving services and mitigate longer-term impact on maternal and child health and development. And lessons learned from Yemen here on how to address ongoing primary health care needs during massive epidemics in conflict setting, particularly for women and children. So pediatricians versus family physician. When you will choose, what you will choose? You will choose pediatrician or family physician for your children. For more opinion, when you prefer pediatrician if the child is born premature, if there is birth defect, if there is a special need for some specialties, and if there is high anxiety in the child about visiting a doctor, because the pediatrician more trained about how to deal with an anxious child. I prefer family physician when your daughter needs gynecological care or there is the child no longer feels comfortable in the office or the family has a health issue in common. So I will provide some home message and recommendation. Children care is one of the important role of family physicians, especially in Yemen. More intensive rotation of trainee can provide them with good experience and good confidence to manage pediatric age group. Also, addition of integrating lectures and clinical exposure of autistic spectrum disorder to the residency training program curriculum. Message to preventive medicine, which is one of the principles of family medicine, is the cornerstone of health. So good service in primary care for children will keep clinic for organization and follow up growth and development for children will decrease the cost of the patient and the whole community. Also, we can train the family physician about the, for example, preschool ophthalmologist screening. Catch-up vaccination, it is very important for family physician. Collaboration between family medicine and pediatrician is important and it can reduce the cost for the people and overburden for healthcare system and number of hospitalization. Here the guideline is, I think, will be much helpful. Myself, with my team, we did a very good guideline and routine checkup for pediatric age group from 0 day until 14 years of age. As in Saudi Arabia, we consider children up to 14 years of age. Okay, thank you.
Well, thank you, Dr. Najla Al-Jalili. It was a very good talk and comprehensive. You touched upon so many areas. Well, thank you very much. I just noticed, obviously you did focus on the collaboration between pediatrics and family physicians, which what we all want. Going back to Professor Huda Basim and the model of IMCI, Integrated Management of Childhood Illnesses, do you think is that a model could be taken to implement your advice on, like going ahead with the collaboration between, family medicine and pediatrics? What are your views about IMCI?
Yes, I think yes, it is a good model to take to make a collaboration between pediatric and family medicine, especially if we make a policy guideline together, it will be much helpful.
Yeah, thank you. We have a question here from Maha Al-Minyawi. She said, thanks a lot for motivated lecture. Well, basically, she's thanking you for your good lecture. I had to thank you on that one. Any questions from the audience, please now. Otherwise, we will have to move to the next speaker, because we've got Dr. Wafa Haj Shuaib. She is with us now from Hadramaut. Any other comment? Najla, just before you go, a quick one. You know, obviously you practice in Saudi now in Riyadh. How is the primary care there? I mean, do you find it quite strong, or are they still like experimenting in Saudi? You know, like the link between primary care and secondary care.
Yeah, still family medicine. It is much better than many countries, but it's still not reached the level that it should be reached to as other developed countries. The primary care usually covering by general practitioner, and sometimes covering, general practitioners that they are not trained well as a family medicine program. They are not trained physician, just have some experience, practical experience. Still, they are running the primary care, but it is better than other developed countries. It is in between.
Sure, thank you. Okay, would you recommend, like, you know, models like here in the UK, you know, LCGP model like GPs, or Saudis probably follow some American style family medicine?
I'm not sure about what is your question again, please.
No, my question is, would you recommend a certain model, like following a UK model as like a MLCGP for training GPs, or perhaps like a different, like or maybe a local Arab board?
I think for our community, Arab board is much better than MRCGB, because I think MRC GB, they have to take this last part in UK, which is difficult for them. I think Arab board, if we open a program in Arab board as family medicine residency program, it's much better, and for the
be more successful.
Yeah.
Okay. Thank you, Dr. Nagla. Thank you very much. We'll see. Final question. Well, okay. Dr. Bebas. Well, there's a question. Are primary clinics provide vaccine for younger female adolescents? Well, they should provide vaccines for younger female adolescents, you know, primary care clinics. Then Hassan Bati said, they are very strong family medicine board program here in Saudi. Okay, basically, you know, focusing on your talk. Thank you very much. So we'll move to the last speaker in our session, Dr. Wafa Haj Shuaib. Dr. Wafa is a lecturer in the family medicine department in Hadramaut University College of Medicine. Her talk will be titled Assessment of Patient Safety Culture in Primary Care Setting. Basically, assessment of patient safety in a primary care setting. Dr. Wafa, are you there?
Yes.
Okay, can you please start?
There's a problem with the share screen. Okay.
Okay. Yes, you are there now. Yeah.
Good evening, everyone. Today, I will present a research regarding assessment of patient safety culture in primary care setting Al-Mukalla, Yemen. The researchers are Hana Uber, Salwa Al-Assani, Reem Al-Haddad, Wafa Haj, Manal bin Salim, and Dr. Abdullah Al-Yamani. Introduction. Quality and safety are the vital rule for all healthcare organizations. Patient safety means the extent to which patients are protected from avoidable harm. So, undertaking a baseline assessment of patient safety culture is the first step into starting with building any safety culture in any organization. Israeli Mediterranean and African study found that unsafe care affects around 10%, which can be prevented with a baseline culture, safety culture. Patient safety is a challenge against primary care success. So for that, World Health Organization providing a project in name of Safer Primary Care. There are a few published studies on patient safety culture in primary care, most of them in developed countries. There is only one published study assessing primary care patient safety culture in an Arabic population, which is taken in Kuwait and also two in Emirate region in Iran and in Turkey. Aim of our study to provide a baseline assessment of patient safety culture in primary care setting in Al-Mukalla, Yemen, as a first published study from a least developed country. Our methodology: a survey was conducted in a period between June to December 2013. The study area is Al-Mukalla district, which including 16 health centers and units in Al-Mukalla district. Those centers have those characteristics. It containing at least one outpatient clinic, and some of those have more than one. For example, in addition to general practice, have gynecology and nutritional clinic. Most of the managers are providers, and the majority of those centers are small buildings with limited resources. Most of them lack quality and safety system, and there is information exchange between those centers. The range of number of staff in each center from 3 up to 16. Our sampling method is a comprehensive method that all providers and non-care provider in 16 primary health care centers included. Those are physician, nurse, medical assistant, midwife, also non-clinical staff included. Those who work less than 1 month in health center will be excluded. The total number of 110, which is our sample results. Our tool is a paper-based self-administered questionnaire, which is provided and validated by Agency for Health Research and Quality. The outcome for the study is overall patient safety outcome and culture related to the patient safety. Overall patient safety outcome can be presented as overall rating on quality and overall rating on patient safety. So the cut-off percent for area need to be improved is less than 60% positive response. Result. We know that from 110 survey distributed in a health center, 78 return a feedback of survey, give a response rate of 71%. Most of participants were female or was female and have diploma qualification. Most of them are care provider, usually physician and nurse, and around half of them have education regarding patient safety, and most of half of them have worked more than 3 years in those centers and have less than 33 hours per week in the world. The figure 1, demonstrating that there is comparison between the United States office and Yemeni primary care center regarding the patient safety culture dimension, which are 10 dimensions: teamwork, organization, learning, overall perception of patient safety and quality, education about error, office process, owner, manager, grants, staff training, communication, work pressure, and patient care tracing and follow-up. We know that our study revealed that teamwork and organization learning give a high positive response, and while the least response for the patient care tracing, follow-up, and work pressure and peace. When comparing with the USA office, we note that regarding teamwork, the USA office is less than that in Yemen, and about follow-up, USA is higher than in Yemen. The average positive response for all dimensions was high, which is 67%. Table 2. The overall rating on quality result from Al-Mukalla primary healthcare. From the dimension of quality dimension, we note that patient centeredness have lowest rate, which is only answer excellent and very good by 33%, while equability provide a high percent. So the average or average positive rating on quality was very low, which is 49%. In this figure, we show that the comparison of safety culture grade in our primary health care and those in Kuwait primary care and USA and Iran. We note that in our primary health care, the percent is 46%, while it's lower than that in USA and in Kuwait. Conclusion. Although the patient safety culture in Al-Mukalla primary care setting is generally positive, patient safety and quality rating were fairly low. So our recommendation, we recommended to increasing the number of health workers per center, finding an appropriate method for effective patient care tracing. Communicate between the health care providers and staff within health centers need to be more clear and to be more better than what we implemented in our situation. Implementation of the safety and quality management system is in Al-Mukalla city, which is a mandatory one, should be done for that situation. Thank you for your attention.
Well, thank you, Dr. Wafa Haj Al-Shuaib from Hadramaut. It was a very good talk and brief. And patient safety obviously is something of paramount importance in primary care. Okay, we'll just check if any questions from the question and answer panel. Not really, and nothing on the chat. Okay. Anyone could raise his hand or her hand for Dr. Wafa Haj Al-Shuaib? Not really. Okay, so Dr. Wafa, just to recap, when you mean patient safety in primary care setting, is it like within the consulting room of clinician in the, like whilst the doctor or GP, consulting a patient, is that, where safety should be obviously looked at, meaning make sure patient is safe, no risk to the patient during examination, or do you mean the whole process of communication, documentation, integration, with secondary care? Is that what you, or is it everything?
It's everything in that. It's everything in the primary health care, involving from the manager, the teamwork, and patient care. So there is a survey, which is a valid survey, distributes to collect what are in our real practice is present.
Okay, thank you. Very good talk. Thank you. Okay, not questions. There are no questions. Okay, there's only one question then now. From Hassan Batis. It's in Arabic. said بالشأن الطب التواصلي عندي رغبة للعمل في هذا المشروع وبدأنا تجربة سابقا لم تكتمل. أعتقد حاجة لو شديدة نرى إخواننا يسافرون ويدفعون ملايين ويرجعون بلا تشخيص ولا علاج، فأعتقد يمكن يسهم على رفع مستوى الصحة في التشخيص والعلاج. الطب التواصلي ربما هو يقصد تيلي ميديسين. أيضا كوكب الحداد response rate 72%. Why 30% not responded? Dr. Kawkab al-Haddad is asking, why do you think 30% not responded? In your study, the response rate was only 71%.
Some of those are absent in the duration of the study. So the survey conducted in 1 week apart. To increasing the response rate, we involve the participant in the first week, then repeat in the second week to increasing the sometimes maybe the questionnaire in some item is not clear because the participants should not know the concept of the quality, as the tool we use is and translate from English to Arabic. So some words may be not clearly for the participants.
Okay, thank you, Wafa. Okay, we'll move now to Dr. Wahib Al-Azani, who would give the conclusion remarks for today's session and the conference for today. Wahib.
Thank you very much, Dr. Abdul Hakim, and thank you very much for who joined us today throughout the day and this afternoon and this evening. We had highly valuable information from Australia, from Africa, from the Middle East. We had professors from all over the place. We learned about good experiments, and we learned about the struggles of our colleagues in Yemen, in the north and in the south. And it was quite an eye-opener to see how the instability is contributing to so much delay and maybe undoing the good work which has been done by lots of very proactive people. And I think it's very important not to lose hope. These conferences will only add to our ability to raise awareness, highlight the importance of family medicine as an important aspect of healthcare, but also open the gates for collaboration with other people. You know, most of the people who came to this conference today, the guest speakers, they would be very willing to collaborate in one way or other, add their experience and their suggestions and tips to whatever struggle we have. Yeah, it's very important not to lose hope despite all this struggle. A lot of good work has been done, and it only can get better. We thank you all again, and we would like you to join us tomorrow. Tomorrow we have a couple of sessions as well. Again, just as important as today, a little bit shorter. And if you have any questions that come up between now and tomorrow, we'll be happy to address them tomorrow. Thank you very much for joining us today.